Good morning, everyone. May I request Dr. Lisa to start her presentation, please?
Okay, so you'd like me to share my screen now, right?
Yes, ma'am. Good morning.
Good morning. Okay. Well, first of all, I'd like to thank the organization for inviting me to give the keynote speech. And I know it's morning there. I'm in Florida in the USA, and it's evening. I'd like to speak about posterior capsule tear management and principles of anterior vitrectomy. I have no financial disclosure and nothing relevant. I have 30 years of practice under my belt. The first 10 years, I took care of everything from open globes to PKPs and trabeculectomy and buckles. The last 20 years of my practice, however, I had other subspecialists with me and therefore concentrated on anterior segment reconstruction, refractive cataract surgery, and complex cataract surgery. So I have been for many years teaching a wet lab as well as a course on anterior vitrectomy for the cataract surgeon. And there are certain unifying principles that we must always conduct ourselves with this in mind. To avoid intraoperative vitreous traction and to prevent postoperative vitreous traction is the most important goal, in that that's what leads to retinal tears and detachment. We want to maintain a normotensive globe because allowing the eye to become hypotenuse and particularly changing pressure dramatically from high to low will tend to lead to suprachoroidal hemorrhage, as well as, I believe, CME with hypotony. We want to always protect tissues from collateral damage. Just because we've broken the posterior capsule or the anterior hyaloid does not mean that we need to have an edematous cornea or chew up capsule, which is critical for proper lens placement when we don't have an intact bag. And certainly we want to manage our iris in a way that there are no sequelae. We want to limit the stage of complication, which means really paying attention, and we'll explain that in just a bit. And our goal is to leave a clean anterior segment, remembering that the lens material is antigenic, never having during embryology, our immune system never encounters that protein. And it's never more important than when we have a one-chambered eye because of breaking the anterior hyaloid to remove antigenic material and to reduce inflammation. And then we want to implant preferably a hydrophobic acrylic lens if possible, if that's going to be stable. Now, the more surgery we do, the less likely we are to have complications, and that complication rate is reduced to the point where staff may not really be facile in knowing what to get for you or how to handle it. And so I suggest that you be prepared by calling a code V, similar to what you might do to practice for a myocardial infarction or a hurricane. We can, at the end of the day, we still have our bottle hanging or all the equipment available. The patient leaves the room, we call code V, and everyone has to find out where is the instrumentation we might need that I call a VIT kit. We want to have available triamcinolone acetonide for particulate identification, triessence being the Alcon on label in the United States version of that without preservative. We want to know where our medications are to bring our pupil up, bring our pupil down, and we want to be sure that we have appropriate anesthesia for our patient. Vitreous, of course, doesn't hurt, but it is important with topical anesthesia that we know if we're going to make any scleral incision, it will hurt. And if we're going to work on the iris, it can. And of course, we may have a more prolonged case. Well, it's really important to understand the settings, and we're always going to be in I cut A in order to reduce or eliminate followability. When we do phaco, we want followability, but when we remove vitreous, that's the last thing we want. And therefore, foot position 1 on most machines is going to be irrigate, and then as we come down the foot pedal, it's going to be irrigate and cut, and only in foot position 3 are we going to add vacuum to that irrigation and cutting. We want to keep the globe formed with OVD at all times. And always have closed incisions, whether that requires a scleral plug or a valve or sutures, whatever it takes to keep an intact globe throughout. And we only want irrigation aspiration cut or bimanual when it comes to removing cortex, because there we do want followability, but we only use that setting once vitreous is completely out of the way. Now, we want to avoid followability, but we also want to limit the sphere of influence. Keep in mind that the vitreous is a little bit like a slinky toy, a spring attached to wallpaper. And if we pull on it over here, we can tear that wallpaper or that retina over there. And so we always want to use the smallest gauge available, the highest cut rate possible, and the lowest effective vacuum that will achieve our goals. We're not in a hurry. We want to keep everything low and slow. And we have to be sure that our infusion balances our vacuum to keep the eye normotensive. Whenever we're moving through vitreous, we want to be cutting so that we're not dragging anything along, particularly if you have a peristaltic machine, that might be possible. And unlike our retina colleagues, we want to exit on foot position 0 because we're not doing a full vitrectomy, but just an anterior vitrectomy. We want to have irrigation anteriorly, and wherever our separate vitrector is, never coaxial, we want to exit on foot position 0, so we're not just pushing vitreous out and having it follow our exiting vitrector. Now, I mentioned stages of complications, and if we're lucky, we're going to recognize a broken posterior capsule with an intact hyaloid. Then we have the opportunity to truly save the day, which we'll talk about some more. Then there's vitreous prolapse, which means that the anterior hyaloid is broken and the vitreous has prolapsed into the anterior segment. Vitreous loss means that it has traveled yet further through the incision, which makes it more difficult to keep a nice closed eye, as well as increasing the risk of tears. And it may or may not be complicated with retained lens material. I have a short time to talk, so I won't talk about removal of lens material.
Don't blink or you'll miss subtle signs. You'll see in a moment the spidering of the back capsule, despite protecting that capsule for the last fragment,
Yes.
right there. And that tells us that the likelihood is we've ruptured our capsule. We need to not withdraw our phaco instrument, but exchange the chopper
for viscoelastic. And the next maneuver, once we've filled the eye with viscoelastic, is to explore to see whether or not we have an intact hyaloid. If we have an intact hyaloid, then you're going to fill Berger's space, as you see on the right-hand side, where the OVD fills into itself, as opposed to dropping down into the posterior segment. Usually in older people where the vitreous is liquefied, you'll see it drop, but otherwise it'll just snake and not fill into itself. And this tells us, is a good sign to tell us whether or not our anterior hyaloid is still intact.
Toric implant is going in an unremarkable manner. I'm protecting the posterior capsule with my second-hand instruments, supporting the chamber as I always do with BSS while removing the instruments from the eye. And that was fortunate because I now see a strangely clear area in the posterior capsule, and on testing it I see that visco will drop right through, indicating that in fact I have a round punched out hole in the posterior capsule. Thinking fast, I'm using viscoelastic and the sulcus to flatten the anterior and posterior capsules to create a safe posterior capsular rhexis. We must find a little tag or make one if necessary with a scissor so that we can make a true rhexis which finishes outside of where it begins. No matter how round your punched out hole will look, it is at risk for expanding with any pressure, as it will not behave as a true created continuous rhexis will. The vector force has to be more centripetal for this very thin elastic tissue, and we will successfully complete this. That's much more difficult in the face of a ruptured anterior hyaloid, but fortunately we kept the chamber from collapsing on removing both the phaco and INA tips, and so the hyaloid never broke in this case, permitting us to go on with a completely uncomplicated case. Now that we've accomplished that, we can fill the bag and feel safe to place our toric implant. Pressure on that posterior capsule will not extend the tear because we have a true rhexis. When we go to remove our viscoelastic, we must keep in mind that we need this hole to be nicely tamponaded, holding the lens back if necessary with a second instrument while removing viscoelastic, and placing Myocol in the eye prior to removing the instrument to allow prevent any vitreous prolapse. This is amongst the saddest of situations, what ought to be a routine case, but you'll see that the rise time and vacuum are too high for this unpredicted, soft, myopic lens. I'm removing anterior cortex in the usual manner and planning a vertical chop technique. As I just begin to start to come through the anterior nucleus, you'll see that tremendous change in pupil bounce, and what happened was the material came sucking through the port, bringing the posterior capsule up to the phaco needle, and we have a rupture. That tremendous change in anterior chamber depth and bounce in pupil size is a surefire sign of complication, and you'll begin to see my adrenaline surge as I replace the chopper for a dispersive viscoelastic cannula and fill the anterior chamber with viscoelastic while holding my ground with the phaco tip in place to prevent lowering the pressure and losing the chamber. Only now, when we control the chamber, can we come out, inspect, relax, and plan.
So my paradigm is if there's a wisp around zonules, I'll cut it with an intraocular scissors to amputate the anterior posterior connections and then reposit it with OVD, keeping it compartmentalized with a reverse soft shell technique using dispersive viscoelastic over the area of zonnular lysis and packing that in with cohesive in which to work. If there's a small prolapse or if there's no view through the pupil, then I will always use a biaxial anterior incisions, which to fit the vitrector gauge. So never use your main incision. You want to close your clear corneal incision that's intended to be plugged with the sleeve, and we won't have the sleeve any longer. We can never do a coaxial vitrectomy without actually encouraging more and more vitreous to come forward. Now, if there's vitreous loss, meaning out the incisions or a sheet around zonules, then I prefer a direct sclerotomy, but always keeping irrigation anterior. So we're talking about a one-port pars plana vitrectomy. And if I can close incisions securely with sutures, or it's a planned vitrectomy with an intact eye, then I will always go for a sutureless trocar system, which is transconjunctival, and make an incision in that fashion.
This is an aphakic patient with a planned anterior chamber lens, and there's vitreous preoperatively in the anterior chamber, which we're identifying with washed Kenalog. As we remove the cannula from the paracentesis, you can see the vitreous follow the gradient of low pressure. When we cut it at the incision site, there's no real traction. However, you can very visibly see why we don't recommend sweeping the incision any longer, because you can see the tremendous tractional forces that are occurring through the pupil with this maneuver. We've made a pars plana.
This is a modified Miyake view, and we're doing an anterior vitrectomy. That's with a clear corneal incision, and despite the fact that I'm putting the vitrector through the rent in the posterior capsule, you can see that as much vitreous is coming forward from the vitreous body as what I am removing anteriorly. And as we withdraw, there's often a wisp to the incision, as you might see at the slit lamp the next day. Now we're going to intentionally break the capsule and plan a posterior incision through the pars plana. And Kenalog or Triessence is particulate identifying, and the moment we pull out with our other instrument, you can see that vitreous followed. And now we're going to go through the pars plana, still with irrigation anteriorly, but pars plana below. We've amputated our anterior posterior attachments. On the one side, it actually removed the vitreous from the incision. On the other, you can see there's no traction when we go to sweep it from the wound because there's no further attachment.
I want to talk a little bit about the incisions, and so here's a video to show you that.
Direct entry, measure 3.5 millimeters back to find the pars plana. Perpendicular to the sclera, make sure you see the point of the MBR blade in the pupil to be sure you're through and through. This is an old 20 gauge, so it's slightly larger for the flat edge. And then always watch the port while accomplishing this. We must have a plug or a temporary tie suture, and always suture this. We have to be sure there's no incarceration of vitreous. Next, we're going to see that we're going to do a trocar system insertion, and we're going to pull the conj so it's not coincident. We're going to go 3.5 millimeters back, limbus parallel to make a scleral tunnel. The appropriate angle is 30 degrees to the sclera, and then enter completely. And you'll see that the here it's a little extreme, that the collar pops backwards, so that we're sure we have not broken the ceiling or the floor of the scleral tunnel, so that when we come out we can apply direct pressure. And I'm told that it's preferable, rather than the pressure that I've applied here, to actually crush it with the tip of the trocar in order to be sure that there is no incarceration of vitreous. This should seal nicely without any bleb. Here we're going to see that we can only apply the trocar when we know that we have a firm eye, because you can see the kind of pressure it takes. And I'm showing this Miyake modified view that Liliana Werner helped me with in order to demonstrate the pressure, and also to show in your mind's eye what's happening inside in the pars plana. You can see how it tilted backwards because we had a really good scleral tunnel, and then when we bring the vitrector through the cannula, it comes through again. Now this is a regular 3-port vitrectomy, and it's just an endoscopic view of this 23 gauge incision that was made directly. And you'll be able to see that the reason that it's absolutely critical we have a scleral tunnel incision if we're not going to suture, if we want to be transconjunctival, is that here in this complete vitrectomy you can see the kind of gaping hole that is there, and we would be filling that with vitreous rather than having hypopyon.
Now, we're going to be placing an implant, and the standard 3-piece lenses that are available today are not intended for the sulcus. In the US, they're off-label for the sulcus, and so I always like to capture or suture such a lens. Certainly, there's no real data that shows that an anterior chamber lens is not the right thing to do. However, I think if the patient is older and you're most comfortable with that lens, it's still viable, of course, with a peripheral iridectomy, but it does require a larger incision, and it does require careful measurement of white to white +1. It's said that there are 2 sizes, too big and too small. Nevertheless, AC lenses are still used today, although not in my hands. Reverse optic capture is another possibility, besides putting a 3-piece lens in the sulcus and optic capturing, as you saw here on the side, through the anterior capsular rexus. Here's the 3-piece lens going into the sulcus, and then pressing on the pole 90 degrees away from the optic haptic junction on each side. Once it's rotated into the sulcus, will allow it to pop nicely and be secure and not move around. If you don't fixate with either iris fixation or scleral fixation, a 3-piece lens in the sulcus will have a tendency to find whatever tear there was and to sunset or sunrise, and I don't think that it's likely to be stable long term. The Yamane technique, of course, has taken over in many quarters. However, it does require a more complete vitrectomy than a simple anterior vitrectomy relieving prolapsed vitreous. So postoperative care, it's really important to use intracameral diluted Vigamox. According to Dr. Arshnoff, we can use the self-preserved, whether you have that in India or you actually can get that. I think you have the possibility of getting an intracameral moxifloxacin that you can actually buy, but otherwise the Vigamox bottle can be used with 600 micrograms per 0.4 cc's. It's been shown, even though there are resistant organisms, because we can get such a huge MIC in the anterior chamber, it's very rare to have an endophthalmitis, and if you do, it will usually be quite susceptible to other medications. There's a 7-fold increased risk of endophthalmitis when we break that anterior hyaloid, and that's why I think it's absolutely essential we do that. We want to warn our patients. And it was my habit, although I have no peer-reviewed literature, to give 1 Avalox systemic oral moxifloxacin on discharge or preoperatively in order to have an MIC in the vitreous cavity if we know we're going to be dealing with the vitreous in a case in order to meet the dictates of surgical prophylaxis. We want to warn patients to expect floaters, educate for retinal symptoms, prophylax and treat pressure spikes. We're almost always going to leave some OBD behind because we don't want to be aggressive enough to allow vitreous to represent. And so we want to anticipate that there can be a pressure spike and get ahead of it. Timely referral to a retinal surgeon, especially if there's retained nucleus, is essential. And particularly if you're not comfortable doing a good scleral indented retinal exam, particularly if we're going to have a pars plana, one part pars plana, port pars plana approach. We want to be sure that we did not incarcerate vitreous that can lead to tears later on because of postoperative vitreous traction. We want aggressive anti-inflammatory management. I will use topical steroids. I'll leave the last maneuver is to leave some triescence in the eye for its anti-inflammatory abilities, and then we'll treat more aggressively with a long taper, as well as NSAIDs topically, I think are most appropriate in these situations for up to 3 months. Close monitoring for CME and disclosure to patients is most appropriate. So I have a lot of these videos and far more. It's a 2-hour course that I prefer to do rather than a 15-minute talk on iTube, and I do have a chapter in the Fishkind complications textbook, and it's been a pleasure to talk with you. I'm happy to answer any questions.
Thank you, Dr. Lisa. Can you hear those claps?
Yes, I heard, I think
I'm
two
Dr.
people
Sanjay.
clapping.
Yeah, I'm
Yes.
first of all, on behalf of Pune Ophthalmological Society, I thank you for accepting our invitation. And it has been really kind. I know what a great teacher you are. I attended your courses in ESCRS 2004, 2005. And I said, this course I have to get when I become the president of this association. And I
Thank
also
you. I'm
learned
honored.
still from the CDs that you gave me on hard cataracts. Those are still one of the best learning experience, which I repeatedly see and learn from it. A few questions, but one question always we have that as a anterior segment surgeon, mostly vitreous and capsule problems occur when we are doing cataract surgery. So we are not that much prepared, especially if you don't have an institute or a backup. So in that case, we are in a dilemma. So many times we, not being trained, we feel we should do either pars plana, or is it an option to do through the side port or through the anterior incision?
Absolutely. In fact, as I showed in my protocol, I will do an anterior approach if there's a very limited amount of vitreous prolapse, or certainly if I have no view through the pupil. The critical thing is not to consider doing a coaxial approach. It has to be biaxial, separating the sleeve from the vitrector, so that irrigation is always anterior. No matter where we're going to place our vitrector, we want the high pressure to be anterior and the low pressure to be posterior, because vitreous will always follow a gradient from high to low. And so it's perfectly fine as long as we make a limbal incision that fits the vitrector gauge. The only trouble is that even if we go down, as you saw in my Miyake view, even if we go down through the tear, it's not the same as being underneath the tear for 2 reasons. Number one, it will almost always draw some vitreous forward, which will almost always enlarge the tear in the capsule. And the only way we can really hope to keep the tear stable is to actually have a pars plana approach. Dr. Abe Vasavada has some beautiful videos showing that as well with high speed. So we are sacrificing the opportunity to convert a capsule rent into a true continuous curvilinear capsulorhexis of the posterior capsule if we go from an anterior approach. Still, unless you're going to go to a wet labs or practice on eye bank eyes, or actually preferably now we have the simuli. I have no financial interest in other artificial eyes that we can practice on. You don't want to, for the first time, do a pars plana incision in the heat of battle, you know, when there's a complication. So you want to prepare yourself ahead of time for what really is the best approach in most cases. Now, there are exceptions to that. You know, I would wouldn't do an anophthalmic eye, pars plana. I wouldn't do, where you don't know where the vitreous is. And if there's significant retinal pathology ahead of time, maybe you don't want to own that by making that incision. And you certainly want to be sure that the retina people that you refer your complications to are on board with your understanding the tenets of this, and maybe even go with them to practice and watch how they do it. So that your patient has the same caring approach from you and your referral sources should they become necessary.
Thank you, Lisa. It was really a very nice presentation, right from preparedness to post-op complication care. And we really appreciate that you had taken your time to present it to us. Thank you very much.
Thank you. It's really an honor and a pleasure on my part teaching. You can take care of an individual patient, but when you teach, you take care of so many more people. So thank you.
Thank you.
Hello, good morning. I would now invite the speakers for the next session. Dr. Sucheta Kulkarni. To go on stage. Dr. Reshma Shah will not be attending the presentation. Dr. Varsha Purane and Dr. Vrishali Varad. Go to that.
Hello.
And
Good morning, all. And we have the second day of our conference, and and hope you have enjoyed the yesterday's scientific session and the banquet. We go to the next presentation, and that's a new presentation. I was not knowing what is this program like, but it's a new introduction by Pune Ophthalmic Society, that is Mentor-Mentee program. In mentors, we have esteemed faculty, Dr. Sucheta Kulkarni, Dr. Parikshit Gogte, who is online, and Dr. Agar Khedkar is with me as a chairman. I request Dr. Sucheta to start a presentation.
Thank you, sir. Good morning, everyone. Just one second. Let me open my slide.
Oh.
Yeah, thank you, POS, for this opportunity. I would briefly introduce the initiative that was taken by the President, Dr. Tekavde, and Secretary, Dr. Rujita Machwe. This was a research initiative, mainly for the benefit of clinicians who are not into research and who are mostly into clinical practice. They identified 3 of us as mentors, and mentees were, it was a voluntary participation from mentees. So the information was circulated, and people who were interested in getting trained under this initiative participated voluntarily. So why research? Basically, what is research is, systematic documentation of your data and trying to analyze it to improve your own knowledge. So it involves collection of the data, organizing it, and analyzing it in a scientific way. So which usually gains and benefits not only the researcher, but also the larger community of patients. So what are the challenges in medical research? Basically, lack of research training during our medical schooling is one of the biggest challenges that we see. And there is not enough research culture in the medical fraternity, especially during the years of our education. Usually, we are always immersed in under the huge clinical load where we don't have enough time and inclination to think from research point of view. And there is need of culture to develop to have prestige or recognition for any of the research activity that happens with the clinicians. So why this research initiative was taken by the POS? Basically, one must understand that research findings can change the way we manage our patients, and there cannot be a better example than COVID. We all know how ill prepared we were when the pandemic started, and how various research trials helped us improve our own understanding of the disease and how we took control of the pandemic. And we must also appreciate the fact that as clinicians, we are one of the most educated groups globally, and we are intelligent enough to understand complex data and analyze it. And not only that, it is a moral responsibility of an educated lot like us to share our knowledge for the larger purpose or larger good of the society. I would now request Dr. Shalaka ma'am to take over from here. She will explain how this initiative went ahead and what was achieved.
Thank you, Sucheta. Basically, this research the objective of this research culture or inculcate this culture in non-academic ophthalmologists. They do have lots of data with them. They do have lots of observations with them. And this was very nice and innovative initiative by the POS, Dr. Tekavde and Dr. Rujita. So at the end of 6 months, it was planned as that when you have to create, identify, and the pertinent research question from your observations wherever you are getting into the clinical practices. So you have to design a research proposal and implement it. Analyze the data and draw to the conclusions so that they can present their findings in lots of POS or organizations. And they know where and how to publish their research. This was the very novel concept introduced by POS. So the process started when they declared it as an initiative. They have selected three of us as the mentors, and then they had declared it in the meetings and the flyers that the voluntary participations were requested from all ophthalmologists, whosoever may be interested. So the process started like that. The mentors, then the mentees were identified, then the lectures were arranged to teach them for all aspects of the research methodology. What is research? What is ethics in that? How to identify the topic, how to design a proposal, how to convert your clinical observation as your hypothesis, and how to pursue it furthermore. Then ethics committee approval, where to approach, how to approach, were discussed. The data collected was already with them. Few of them had retrospective analysis. So all of them had their data and the hypothesis with them. And ultimately it was inculcated into the publication. So there were in all 3 mentors, 12 volunteers, 5 had identified a topic and worked on it, but initially to begin with, and later on because of some personal problems, few of them could not complete the work. Only 3 could complete the work, the rest still working on the data collection and the data analysis. So now let's listen from the mentees what they have done and how they want to present it. Thank you.
So Dr. Parikshit is online. He would participate in the discussion after the presentations.
Thank you.
So I think first mentee to present is Dr. Varsha Puranik.
So, good morning, everyone. Myself, Dr. Varsha Purani. And first, I would like to thank the POS committee for giving me this opportunity. My paper was regarding surgical outcome at 6 weeks after the cataract surgery in patients with the ocular comorbidities. As we all know, the major cause of the avoidable blindness being the cataract, and it has been found that ocular comorbidities has been found in association with the cataract in 26% of the patient by the Auckland study. The visual outcome of 6/12 or more has been found in only 72% of the patient undergoing the cataract surgery with the ocular comorbidities. So the preoperative ocular comorbidities has been shown to be strongly predictive of the poor visual outcome. But no study has been performed in India regarding the visual outcome in such a patient, so these studies were carried out. So the aim of this study is to assess and compare the visual outcome and complication at 6 weeks after the cataract surgery in a patient with and without the comorbidities. All the patients undergoing the cataract surgery between the age group of 18 to 70 years with and without comorbidities were included, while the patient with the combined surgeries were excluded from the study. So this is an observational case control study being carried out at our institute, and ethics committee approval was taken. Demographic data was collected, and for the purpose of study, we have defined cases as the cataractous eyes with the coexisting comorbidities, while control as the cataractous eyes without comorbidities. Cases were further classified as a mild comorbidity and severe comorbidity. Further diagnostic details like anatomical site, etiology were also collected, and the grades of cataract were noted. All the surgeries were performed by the skilled surgeon. The type of cataract surgery was decided by the operating surgeon depending on the ocular status. And we also noted the surgical complication, which were divided as a minor complication and the major complication. As per the difference of the visual outcome in a patient undergoing the cataract surgery with and without comorbidities, the sample size comes out to be 106. For this study, we have collected the cases as 127 and control being 223. Data was analyzed using the SPSS software, and primary outcome measure, that was the preoperative and postoperative best corrected visual acuity at 6 weeks. Coming to the results, as far as the age and gender was concerned, there was no significant difference in cases and control with the ocular comorbidities. We have found 63% of the patient having the mild ocular comorbidity, while in 37% of the patient, there was a severe comorbidity. Retina was the most common site for ocular comorbidity. This was the etiological classification. As far as the grades of cataract was concerned, we have found that the most of the patient from the cases that is having the comorbidity were having the medium and hard type of the cataract as compared to the control. So this difference was statistically significant. We have also noted the systemic association, and in cases we have found that in about 53% of the patient, we have the systemic association like hypertension, diabetes, and bronchial asthma. But the difference between the cases and control was not statistically significant. Coming to the analysis of best corrected visual acuity, we have divided into 3 groups like good vision, fair vision, and the poor vision. So in a cases, we have 36% of the patient with a poor vision preoperatively, but after the cataract surgery, so this was the 36% of the patient having the poor vision preoperatively, and this percentage was reduced to 6% after postoperative. So surgery significantly improves the vision in the patient with the ocular comorbidities. In a control group, this difference was not significant. Coming to comparing the grades of cataract with the best corrected visual acuity, in a patient with a cataract, we were having in a 9% of the patient were having good vision preoperatively with a hard cataract, but this percentage goes up to 64% after doing the cataract surgery. In all of the patients, we have done phacoemulsification only in 2 cases where we have to convert it to the SICS. So in a patient with a hard cataract, having the 9% good vision preoperatively, that percentage goes up to 64%. Coming to surgical complication, we have 12% of minor complication in a cases, while we noted the 4% major complication. While comparing the cases and control, these p-value was statistically significant. So in a cases, we have got more complication. Coming to the discussion, 63% were having the mild ocular comorbidity, while 37% having the severe. Retina being the most common site for ocular comorbidity. In a patient with a comorbidity, 36% were having poor vision preoperatively, which was reduced to 6% after the cataract surgery. And in a patient with a hard cataract, along with the comorbidity, 55% of the patient having the poor vision preoperatively, which was reduced to 14% postoperatively. In only 4% of the cases, we noted the major complication. So there was a significant difference in postoperative best corrected visual acuity despite of having ocular comorbidities and hard cataract preoperatively. So presence of ocular comorbidity has been shown to be strongly predictive of post-operative visual outcome and surgical complications. So these patients must be counseled preoperatively regarding fair to visual outcome and occurrence of complication. But despite of having ocular comorbidity, these patients may have the good visual outcome when surgery is performed by the skilled surgeon. Thank you.
Thank you, Dr. Varsha.
Yeah, sir, I would like to say a few words. Like, I would like to congratulate POS committee for such a great initiative. All the mentors were very extremely knowledgeable, and they have helped us a lot in such a minute things regarding the research activity. Especially, I would like to thank my mentor Suchita Kulkarni ma'am for her constant motivation, guidance, and support. And I would like to learn in future also regarding the research from all of them. Thank you. Thanks a lot.
Can you just briefly explain your definition of severe comorbidity?
Yeah, the severe comorbidities were defined as a patient which have anticipated more complication in a surgery as well as having the negative visual outcome, like major impact on the visual outcome.
Dr. Varsha,
Yes.
can you
ma'am.
please explain how much was the time period for the whole of the project?
Yeah, we have collected a record over the 3 months, ma'am. And for this, we have screened out about 2019 case, 2019 all
This
the
is
cases.
retrospective analysis
Yeah,
of the
this was a
data.
retrospective of
Thank you.
Thank you, ma'am. Thank
Dr. Urushali, we are running short of time. If you can just highlight of what your work you have done.
Good morning, everyone. First of all, I would like to Good morning, everyone. First of all, I would like to thank Pune Ophthalmological Society, President Dr. Tikkode sir, and Secretary Dr. Rujita for starting this initiative and giving me this opportunity. So we did, and my presentation will be common causative aeroallergens in allergic conjunctivitis. Objective of this study were to identify the common aeroallergens responsible for causing ocular allergy. We all are aware that exposure to the allergen is the first step to stimulate the cascade of an allergic reaction. So we tried to find out the most common aeroallergens responsible for causing an ocular allergy, and its usefulness of this testing in guiding the patient to avoid the allergen in day-to-day life. Materials and methods. We included around 160 patients. This data is around 4 years data, retrospective study. Both male and females were included between age of 4 to 12 years with a mild to moderate allergic conjunctivitis. We took detailed history, ocular examination, including vision, slit lamp examination, IOP fundus examination is done. After return informed consent from the parents, allergy testing is done by a standardized, modified, penless, bloodless skin prick testing with selected alloallergens. Allergens were selected according to the history. So we did testing with an skin prick test. This is an gold standard advised by an World Allergy Organization. With an experienced hand, this is an highly standardized and highly sensitive testing than an blood allergy testing. This is cost effective also. Then depending upon the history, the patients were tested for the most common aeroallergens. After 20 minutes, what we do in the allergy testing, we put a drop of the allergen on a forearm and introduce the allergen in a superficial layer of the epidermis with 1 millimeter of lancet. And we take a reading after 20 minutes. And after 20 minutes, we see look for the induration, and more than 3 millimeter is considered as a positive reaction to the allergen. After identification of a causative allergen, patients were guided about the modification of his or her lifestyle according to the positive, that is called as an allergen avoidance. I'm sorry, one picture is missing here that was showing an induration, or I don't know, this is not visible here. So what are the results observed in this study? Out of 160 patients, 143 patients showed sensitivity to dust mite. 126 patients showed sensitivity to pollens, 98 to molds, and 73 to other allergens such as insects, animal denders. In that, cat and dog epithelia and bird feathers such as in pigeon feathers were positive. This is a result displayed in a diagrammatic manner. So in a discussion, we already I explained that allergen exposure is the main culprit or main initiative for the allergic reaction. So according to the World Allergy Organization and the WHO, allergen avoidance and immunotherapy are the only treatment that modifies the course of an allergic disease, either by preventing the development of new sensitivities or by alternating the nature of the disease or the disease progress. So other medicines, whatever available, these medicines are mentioned here in the flow chart. These are just will control the inflammation or reduce the patient symptom or treat the patient symptomatically, but that will not change or modify the disease itself. So after finding out the allergen, these were the guidance or the modification of the lifestyle modification advised to the patient. If patient is sensitive to the house dust mite, then we advise them and to use an allergy-proof encasing, use dehumidifier at the home, and washing of beddings within hot water frequently, to keep their beds and pillow in a sunlight at least once in a week, then cleaning of the walls and floors frequently. If patients are sensitive for the cockroach, then we advise them to do pest control regularly, cleaning of the walls and floors, and securing the food waste matter properly. In cases of the pets, to remove the pets from the house. In cases of the molds, use dust humidifier, then cleaning of walls and floors frequently, and use a HEPA filter. In cases of the pollen allergy, avoid the outdoor activity if possible in a peak activity of pollens, and most importantly, wearing the protective goggles whenever they go out in pollinating season. So in a conclusion, exposure to the allergen triggers a series of allergic reactions which can further progress the disease and involvement of the other organs, such as the respiratory tract, leading to asthma. So avoidance of an allergy exposure helps in reducing the severe and progress of an allergic disease, so we can prevent the involvement of other organs. So other studies in the pipelines are progress of allergic conjunctivitis to the other allergic disease. We are trying to study the allergic march in such patients. Then association of comorbidities with an allergic disease such as rhinitis and asthma or sinusitis in such patients, and correlation of total Ig levels with the severity of allergic conjunctivitis. After this research project, I got motivated and I could present this paper in an international conference of an Asia-Pacific Allergy Asthma Congress in 2021. So what I gained from this project is I got motivated with the lectures of all the mentors. So that helped me to compile all the data which we were already having, which we already had. So proper compiling and interpretation of it was easy for me, and study was easy for me to do because of their guidance and lectures. Thank you. These were the references of studies. Thank you. Thanks a lot. Any question, ma'am?
Just a small question. Where you are primarily presented with conjunctivitis, or they had presented with allergic bronchitis and you had selected out of that
Pardon?
conjunctivitis? Your patients, did they present with allergic conjunctivitis primarily, or they were presenting with the allergic bronchitis and you selected having?
We selected, yes. They were having history of rhinitis also, some were having an asthma also. So in that patient who were having a mild to moderate allergic conjunctivitis, that patient we selected.
Primarily they presented with the allergic
Rhinitis.
bronchitis.
That is what we are coming up. Patients just neglect the allergic symptoms, even though they are having in signs. So that study is in a pipeline.
Okay,
Yeah.
thank you.
Thank you. Thanks, sir.
Thank you, Dr. Rushali. We have third mentor joined online, Dr. Parikshit. Can you just give your comments? Dr.
I
Parikshit.
think it is, yeah. Thank you, Shah sir, and thank you for keeping this at such a prime time on Sunday morning. Research is, I mean, it just says that this committee wants to have research as a priority. Normally, research is done either by DNB students or the MD students because they have to do it. And of course, there are some very few crazy who do it just for the passion, but otherwise it's something that is restricted to the institutions. So POS under Dr. Tekavde's and Dr. Rujita's leadership need to be commended, that private practitioners who form a very large group of practitioners or very large segment of the members, even they should be initiated and encouraged to research. And out of the 9 who had actually joined in, all of them are doing it and they are in various stages of it. So perhaps when the next POS meeting is held, we will have, what shall we say, presentations from all 9 of them. So thank you for having me on this.
Thank you. Thank you, Dr. Parikshit, Dr. Sucheta, Dr. Shalaka, Dr. Varsha, and Dr. Ushali for a wonderful initiative. And I hope that all the members will be now given a boost to start some amount of research work, because at our PG level, there is hardly any research that has been taught to any one of us. So unless until there is a push from somebody, people will not go into it. And I will be one of them to join. Thank you. Thank you. We'll start with the next talk.
Thank you. I just want to say a few things. This concept of research came with, I had one presentation in RO Meet internationally with Professor Dua, and there I learned some tips from him. I said, sir, can you share this with our members? He was kind enough. In our first meeting, he gave us 3 hours and he told that how you can do research anywhere, everywhere with whatever resources you have. So that time we decided that we will have this ongoing activity of encouraging our members for research. And I'm really thankful to Shalakha ma'am, Sucheta, and Parikshit, who gave their time. And these people have been working 9 months. Even the candidates, they have been working 9 months on this. And I congratulate all of them and I thank the faculty. Thank you. I now invite Dr. Jagdish Kakadia. He'll be joining online. Welcome, sir.
Thank you very much, sir.
He is a great innovator. I think there are hundreds of products which he has innovated, and we'll all be delighted to hear from him. Over to you, sir.
Thank you very much. I thank Pune Ophthalmic Society in general and Dr. Sanjay and Dr. Parikshit Dogate in particular to have invited me to present OmniGlow, the stereocoaxial illumination device to upgrade our surgical microscopes, which I have designed. Can you see my screen?
Yes, sir. Yes, sir.
So today is 100th birthday of my Guru Param Puji Pramukh Swami Maharaj, and with prayers to him and with tribute and respects to him. Before I begin my talk, I wish you all happy 2022, but a COVID-free happy 2022. OmniGlow is a name acronymed from the phrase omnipresent red glow, and I do have a financial interest in this device. And before I come to the talk, let me explain how I came across developing this device. When I first time used Lumira 700, Lumira T microscope in USA, I realized the advantages and importance of stereocoaxial red reflex, such as glow and depth perception, capsular axis, trench depth control, early perception of PCR, cortical cleanup, and anterior capsular cleanup, as well as enhanced pleasure and comfort and boosted confidence of the surgeon. I decided to buy Lumira for myself, and in those days it was costing 4 million rupees. Even today it is costing the same, but the bank said no to the loan. In 2008 in India, 4 million rupees was equivalent of 3 kilograms of pure gold, and also was equivalent of a decent small bungalow. So it was our 20th wedding anniversary, and I said to my wife, "Hi Sakhi, let us sell out our new house plot or your 3 kilograms of gold to buy me a Lumira 700. And it was very natural. No lady would like such a proposition on a wedding anniversary. And in 2006, I had made my own excimer laser and saved 24 kilograms of her gold. So she took me to my LASIK room, and she showed me that if you could build an excimer laser, why can't you build a Lumira device for your surgical microscope? As Plato has said, necessity is the mother of invention. And then I saw this picture of African boys making their own billiard table, and I decided that I'll make a Lumira device of my own. So I revisited our textbooks and read about Hermann von Helmholtz's 3 principles of coaxial illumination. I also had to study principle of stereopsis enhancer optics, because when you increase the glow, the stereopsis decreases. They are inversely proportionate to each other. So we have to also increase the stereopsis, not just the glow. And also I studied principles of phase contrast microscopy, which was introduced by Fritz Zernike. We know Fritz Zernike by his polynomials of aberrometry. Fritz Zernike was awarded Nobel Prize in 1953 for invention of phase contrast. And we need phase contrast because a trans-illuminated tissue, as the glow increases, the contrast decreases. And as you can see here, these are the images without phase contrast. These are the images with phase contrast. So we have to increase the glow, increase the stereopsis, as well as increase the contrast. So after a lot of thinking and experimenting with various optics, I developed a device which I named OmniGlow. This is a small compact device which can be attached to the bottom of any good basic surgical microscope. This is my Guru Puja Swami Maharaj blessing the OmniGlow patent paper, as well as blessing the first unit of OmniGlow which I made. Let us see a video of OmniGlow. It's a small device weighing less than 400 grams, which can be detached and attached within a minute or two to any surgical microscope. And once it is fixed, it becomes a part of the microscope, and it is very lightweight, so it does not add any load on the motors. In conventional illumination system, there is only one sweet spot of full red glow, which is usually in lower and nasal tilted position. But OmniGlow gives full homogeneous red reflex in any position of the eyeball. The glow is always there. The glow is never lost in any tilt, any size of the pupil. Case of dense PSC cataract is beautifully visible. Another case of dense PSC cataract with and without OmniGlow. Another case of dense PSC cataract with and without OmniGlow. We never need trypan blue dye for doing capsular axis except in fully mature white cataracts, because the advancing capsular axis is so clearly visible. Hydrodissection is always a pleasure because fluid wave is always very clearly visible. Hydrodelineation always gives us a very nice golden ring reflex. Phaco procedures are a great pleasure because of enhanced stereopsis and an excellent glow and excellent contrast. Even for aged surgeon with their own nuclear sclerosis, you are always happy doing the surgery. The blood behind IOL is so clearly visible, and because of better 3D perception, you are never afraid of going behind IOL to aspirate the debris from behind IOL. Injection of cohesive visco is clearly visible. An injection of dispersive visco and the cohesive visco going out is also. Visco aspiration is literally visualized till the last drop of the viscomat is out from the anterior chamber. There is usually no glow in small pupil in conventional microscope, but there is always a full glow in OmniGlow, even in 2 millimeter size pupil. In any tilt of the eyeball, any position of the eyeball, the glow is always there. Because of good contrast and 3D perception and glow, it's always confident and convenient to enlarge the capsular axis to make it concentric to the IOL border. PC rent is instantly perceived. It's so clearly, so beautifully visible. And in a well-dilated pupil, you can always see zonules. Zonules are so very well visible. The ghost images from the plastic drapes are instantly gone the moment we switch on OmniGlow. The cleaning of the rim of the anterior capsule in phase contrast illumination, you can see the epithelial debris getting cleaned, and the cluster of the removed epithelial cells can be so clearly visible. The microfibrils of the lens cortex while doing IA is so beautifully visible. Even when we capture the posterior capsule, the star folds are instantly visible so that we can activate the reflux and prevent the PCR happening. You can instantly realize and see the star fold of the posterior capsule. We can even see the posterior pole pathologies on table because we are illuminating posterior pole with OmniGlow. Even the disc, the macula, and the posterior pole blood vessels, retinal blood vessels are also very nicely visible. So, but for a true perception of enhancement of stereopsis, a surgeon has to have a live demo in his own operation theater. So OmniGlow is not just increasing the glow, it is also increasing contrast, three-dimensional perception, and saving 4 million rupees. And OmniGlow is light in itself, so it can become the primary light source. Microscope's own fiber optic light becomes secondary or not necessary. OmniGlow's dual lights are non-fusible halogen LED. So they have a 25,000 working hours life. So at the rate of 20 minutes per surgery, they will last for more than 75,000 surgeries, which is the total career of a surgeon. So OmniGlow is a device which will last for a surgeon's lifetime. And because the optics are made of cultured crystal plate, which is hard, second only to diamond, it cannot be scratched except by diamond. So the coatings and the lenses and the mirror will last forever. And OmniGlow does occupy a little space, about an inch under the microscope, but however, there's always enough room under OmniGlow for comfortable working. Beam splitter, camera handles, they all remain as is varies because the OmniGlow attaches to the bottom of the microscope. And Biome and OmniGlow are easily and quickly interchangeable for those who are doing retina surgery as well as intersegment surgery. And this is the most recent edition, OmniGlow SL, that is the OmniGlow which I made for slit lamp. And with this, with 30D lens or with a ruby lens, you can visualize the fundus so well that CSR or CME can be identified just by looking at the fundus. Quite often, I don't even need to see OCT. images with OmniGlow SL. OmniGlow can be made and fitted for any make or any model of the ophthalmic surgical microscope. I have by now made more than 1,000 for all the available known microscope which are there in India. And I was happy, it was a very happy surprise for me that a few doctors, friends who purchased OmniGlow for their Lumera eye, and their opinion is that OmniGlow's glow field is better than company's own illumination. They are using only OmniGlow as the light and they don't switch on the Lumera's own light. More than 1,000 eye surgeons are using OmniGlow since last 8 years, and none of them have reported photic maculopathy. And so at a 20th fraction of the cost, we can convert our available current microscope to a level of Zeiss Lumera 700 or Leica M822. Every day in every OT, my OmniGlow gives me a very nice Purkinje smile, not only on my face, but on my wife and my daughter's face, because they saved the 3 kilograms of gold, and you can also save your gold. And just to extend, I converted OmniGlow into a UV glow, which is a UV avatar of OmniGlow to treat keratoconus by C3R for cornea collagen cross-linking. The advantage is being that it is giving you a microscopic view throughout the procedure. It has 200 mm working distance, whereas in conventional C3R device, you have very little, only 5 centimeter working distance. Video recording is possible because you're doing the entire procedure through microscope, and it is cost effective. And this is UC Glow. This is a UV light device which can kill corneal infections in a matter of 5 to 6 minutes. Any organism, fungal, corneal, or amoebic infection can be destroyed within 5 to 6 minutes, and the eye will start recovering in 2 days or 3 days time. This clinical study is underway. And thank you very much again, Pune Ophthalmic Society, for allowing me and inviting me to present this talk at this August gathering. Thank you.
Thank you, Dr. Kakadia, for your wonderful innovation. And I think there are a few people using that OmniGlow in Pune also. And it really looks amazing. And I just appreciate your innovative and research-oriented ophthalmologist mind who has innovated so many things. Like, I know that we were together during early COVID days when we were together for one of the webinars where your research was going on about the development of masks and then UVC light and methylene blue for prevention of COVID. Great mind, and thanks a lot for your wonderful presentation. Dr. Parikshit wants to say something.
No, sir. I have been using OmniGlow, and it has made the surgery much, much safer, especially for dense cataracts, which are very common after COVID. And it has also made surgery faster. So if you are doing multiple surgeries in a row, it makes them safer and faster, and both saves time and money.
Thank you, sir. Thank you.
Thank you, sir. Now I invite our next speaker, Dr. Paraj Dave. He is online. I request him to share his screen.
Am I audible, madam? Can you hear us?
Yes, sir.
Okay. Should I start?
Yes, sir.
Okay, a very good morning to all of you. I'd like to thank the Pune Ophthalmological Society for this opportunity. The topic given to me is, clinical updates in glaucoma management, and with reference to fixing the problem of adherence. So without further ado, let us start with the talk. So we all know that glaucoma is a major public health problem, leading cause of irreversible blindness, not only in India but in the world itself. We all know that around 12 million people suffer from glaucoma in India, and the sad part is that more than 75% of the glaucoma cases in the country remain undiagnosed. We all know that India is predominantly a young demographic, and with the aging of population.
Can you make it to a slideshow?
This is a slideshow. From my end, it's a slideshow.
No, you.
This is the non-slideshow thing, and
Close that other window, left side window, the slide window.
this is the slideshow.
No, close the other side.
There's nothing open on my side. There's nothing open. Let me start the. I mean, I'll share the screen again. Let me stop and share again. This is me in my full slideshow mode. Is it okay, or is it still?
Yes, sir. Please go ahead.
Okay, fine. So this is a typical patient's journey from commencement of the disease to progression. So there's a person who would start off with having glaucoma, and we all know that there are lack of signs and symptoms in the early part of the disease, coupled with the fact that there is a very, very low awareness of the disease itself in the general population. And suddenly one day the patient would notice that there are some signs and symptoms, there's some problem in my vision, let me see the doctor. So he goes to the doctor there identifies the problem, and diagnosis of glaucoma is established. This often happens late in the course of the disease, wherein considerable irreparable damage has already happened. The patient is started on medications, usually eye drops in the beginning, but the patient cannot perceive any beneficial effect of the drops, because whatever damage has happened is permanent. So what happens is that the patient stops putting the medication. This again causes further progression of the glaucoma disease and further compromised vision that cannot be restored. So sort of a vicious cycle sets in. There is tremendous impact of glaucoma in the quality of life of the patient. Seemingly trivial activities like getting dressed, using the toilet, etc., become a huge task. It can also result in very serious side effects like anxiety and depression as well. So this is something that we need to be wary about. So at this point, I like to talk about two terms, adherence and persistence. So adherence is basically the degree to which the patient follows the treatment instructions during a finite period of time. Persistence is the time until which a patient first discontinues the use of medication. Therefore, for example, if you tell the patient to put a particular drop twice a day, and he ends up putting it just once a day, then he is persistent, but he's not adherent. So hope you notice the difference. Non-adherence rate with glaucoma medications are extremely high. They can be as high as up to 60%, and up to 50% of the patients, they actually stop taking the medication within the first 6 months itself. As far as the Indian scenario is concerned, 74.3% of Indian patients, they fail to attend at least one follow-up visit, and only 10% continuously refill the prescription within the first year. So adherence and persistence is a huge problem for glaucoma patients. All this, what it leads to is reduced treatment effectiveness, increased risk of complications, and poorer patient outcomes. This particular study aimed at identifying the barriers to adherence, and they found the following factors which were important as labeled by the participant. One was difficulty in putting the drops. Second was poor perceived efficacy of the drops. Third was poor knowledge about the disease itself. Fourth was wrong beliefs about glaucoma. Fifth was difficulty in maintaining the medicine schedule. Next was side effects. Then came the cost, and then came plain forgetfulness, just forgetting to put the medication. So what are the strategies you can use to improve compliance? One is reduce the number of medications, use the absolute minimum medication as required by the patient, and try and not overtreat. Also prefer using fixed dose combinations over unfixed combinations. This also helps in limiting exposure to preservatives, which in turn can lead to various side effects. And this also helps in preventive washouts, because patients frequently, they do not wait between two medications, and this leads to the previous medication being washed out. Selecting formulation with minimal side effect is another way in which you can ensure that the patient maintains the compliance. Multiple medications can be a problem, which is well shown by this particular study, wherein they showed that when the number of medication increases from 1 to 4, there is a 30% reduction in the adherence rates. Another study also showed that, when you use fixed dose combinations as opposed to the unfixed combination, there is a 20% increase in the adherence rates. These are the fixed dose combinations which are currently available for glaucoma management. In terms of beta blocker free fixed dose combinations, you have brimonidine, brinzolamide, and nitarsodil latanoprost. The second is still not available here in India. Under the beta blocker fixed dose combinations, you have the non-prostaglandin analogs and prostaglandin analogs. So under the PGA analog, you have various combinations of the prostaglandin with the timolol, the beta blocker, and the other is non-PGA beta blocker fixed dose combinations like dorzolamide timolol, brinzolamide timolol, and brimonidine timolol. So just to give you an idea as to how you should select the best medication for your patient, we'll take this example of the non-prostaglandin analog beta blocker fixed dose combinations. So there are 3 available. As regards to the dorzolamide timolol fixed dose combination, we all know that dorzolamide can cause burning and stinging, and this is sometimes not good.
Sorry to interrupt, sir, but we cannot see your slides. It's not moving.
Is it moving now?
No. So please continue.
Okay.
So we are running short of time. You please continue.
Fine. So for what I was talking about was that, if you are using, say, are you able to see the slide or it's still not visible? Fine, I'll just continue. So as far as the dorzolamide timolol combination is concerned, we all know that, dorzolamide causes the burning and stinging sensation, which is a problem. Brimonidine timolol combinations, we all know that, brimonidine is notorious for causing allergies, and therefore it is sometimes not desirable to use them. Brinzolamide timolol, on the other hand, has improved patient comfort and is usually better accepted by the patient. Another important aspect which we frequently neglect is spending adequate time with your patient. So my suggestion is, when you always talk about the compliance, you begin with an open-ended question as to ask the patient as to how they are taking the medication. Pay attention to how they respond, because this will reveal their level of understanding of the treatment regimen. Then ask them about how they manage to organize their medication, whether they tend to club it up with a particular activity or not. For example, say post dinner, before going to sleep, etc. And it is sometimes useful to have the patient describe the way in which they put the medication. Also, change the patient's expectation that you'll be judgmental. Tell the patient, that non-compliance is universal, and it is a known fact that no one can be 100% compliant, and it is normal to miss doses. Also, explain to the patient as to, he has to be very, very honest about his compliance part, because otherwise this is going to affect the decisions about medications. For example, if the patient is not putting a medication and he does not tell you, then you end up adding more medication, which just compounds the problem. And finally, you ask them about how often they are forgetting or missing the medication. So this will elicit a more honest output. So the checklist is, always assess the patient's background and understanding. At the first consult, at least demonstrate how to put the drops, show punctal occlusion and the importance of it. Ask about the daily routine of the patient, whether he'll be able to put drops at work. Discuss the side effects as well. Inquire about the support system, whether he has family members who can help him with putting the medication, whether the patient has any memory issues, arthritis, etc. And can the patient actually afford your medication? Because you may give them the best medication, but if the patient cannot afford it, he or she is going to end up not putting it. And also always motivate the patient when they come to you for follow-up, like, you have done a good job with the visual field, the nerve pressures look stable, etc., because this keeps them going. And last and not the least is know thyself. That is, you self-assess as a doctor whether you have the required time, expertise, or the equipment to properly manage your glaucoma patients. So just to summarize, glaucoma is a leading cause of irreversible blindness. Poor adherence has been documented in patients with glaucoma. Adherence is absolutely crucial for decreasing avoidable vision loss. Fixed dose combinations for glaucoma treatment are beneficial as they improve patient medication adherence, and spending adequate time with the patient is another critical aspect in ensuring treatment adherence. So with this, we will probably break this vicious cycle of patient, not putting medication, progressing, and further, compromising the vision that cannot be restored. So with this, I'd like to stop. Thank you so much for your patient listening. Thank you.
Thank you, sir. Now I request our chairman, Dr. Shalaka. Hello. Hello.
Hello. Can you hear me, please? Yeah. Thank you, doctor. It was really a wonderful presentation. The compliance for the glaucoma patients, and basically, I think standalone glaucoma specialists cannot go ahead with. You need a lot of technical support. You need a lot of human support for that from the doctors as well as this is just to conclude the first session. We'll hand it over for the next. Deshpande and moderator Dr. Nitika Tripathi on dais. I invite Dr. Tanmay Damankar for her talk for a first talk on fitness for ophthalmologist. I request all the speakers to stick to time as we are all
Hello. Good morning, everybody. We are starting this session, practice health and financial management. The subjects are varied. So I think this 1 hour, we are going to have very interesting topics. We will be starting first, fitness for ophthalmologist by Dr. Tanmay Damankar.
Thank you. Welcome to the session on fitness for ophthalmologists. I'm actually going to be speaking more about the ergonomics that the ophthalmologists need to follow in our day-to-day practice. So is ophthalmology being a pain in the neck for some of us? It is a well-known fact that certain medical professionals are prone to musculoskeletal disorders,
and ophthalmologists are at a particularly higher risk. The common ones include disabling back pain, neck pain, numbness in the hands and legs, and carpal tunnel syndrome. A lot of studies done worldwide show that a significant proportion of ophthalmologists in various countries across the world have been affected with musculoskeletal disorders. A recent study done in Shroff Charity Eye Hospital, Delhi, showed certain statistically significant factors like the ophthalmologist's age, female gender, and ophthalmologists performing retinal lasers and indirect ophthalmoscopy to be at a particularly higher risk. As against height, weight, time spent in the OT, years of ophthalmic experience, or duration of time spent in the OT was not statistically significantly associated. Certain specialties like squint, pediatric ophthal, neuro-ophthal, and oculoplasty had a lower incidence of back pain and neck pain. As a result of musculoskeletal disorders, we have to suffer absenteeism, sometimes early retirement. One may have to discontinue his specialty, like stopping maybe indirect ophthalmoscopy or lasers because of improper posture. One tends to get dependent on medication. Some surgery might be required for chronic back pain, and all this definitely affects the quality of life. So what can be done? There are certain basic ergonomic principles that we can follow to avoid neck, back, and arm and hand injuries. So we'll see them one by one. How to avoid neck injuries? Now, repeated flexion, extension, or improper position on the slit lamp can lead to a lot of strain on the neck. And in a busy OPD, this can be a major cause of chronic neck pain. So this first posture has to be avoided, in which the neck is extended, because sometimes the stool is away from the slit lamp and you have to lean your back forward and extend your neck to look through the eyepiece. So make sure the height of your stool is well adjusted. It's brought close to the slit lamp, so that your neck and back are in an aligned straight posture. Similarly, with the operating microscope, if you just tilt the ocular towards yourself by 20 degrees, it obviates the need for you having to lean forward towards the eyepiece. So make sure your neck is straight at all times, causing minimal pressure on the neck muscles. Also, during indirect ophthalmoscopy, the first picture is a wrong posture because the neck is completely bent, and for a long time that can lead to a chronic neck pain problem. So make sure we are using a lightweight indirect ophthalmoscope and maintaining a neutral spine position. Doing the indirect ophthalmoscopy within a sitting position, either you sitting or the patient sitting and slightly reclining, can cause minimum strain on the neck. If one is using surgical loops, make sure they're lightweight and preferably without an inbuilt illumination system, because that tends to increase the weight of the instrument. Also, one may consider shifting to a microscope for squint and plasty surgeries to prevent repeated neck bending due to the loop. Computer use also has to be kept in mind. So make sure you're sitting in a straight position with the back supported against a chair, knees bent at 90 degrees and feet planted firmly on the floor. The neck has to be in a neutral position with eyes directed slightly downwards, and adjust the bifocal segment of your glasses so that you do not have to extend your neck to view the computer through it. In order to avoid back injuries, mainly in the operation theater, make sure you're not leaning forwards, maintain a straight back position, and adjust the stool height, table height, everything before the start of the procedure itself, so that the back is straight. Similarly, the position of the foot pedal is very important. If we extend our leg, then it causes a lot of pressure on the paraspinal muscles of the back. So just like when we are driving a car, the clutch and accelerator balance is maintained by appropriately adjusting our car seat. Similarly, we have to adjust the foot pedal position as well. So make sure again the knees are bent at 90 degrees and we do not have to strain too much to reach the foot pedal. In order to avoid arm and hand injuries, again, make sure the keyboard is properly positioned in an ergonomic position, and you use a mouse pad with the proper cushioning so that it does not give pressure on your wrist. Avoid contact stress, avoid resting your elbows or arms or wrists on hard surfaces for prolonged periods of time. Obviously, one should invest in regular physical exercise, some form of yoga, aerobics, or don't hesitate to seek appropriate physiotherapy for your neck, back, and hand pain. Periodic vacations are very important. They help to rejuvenate our mind and body. and we come back pumped up for the rest of our work. So because the topic given to me was fitness for ophthalmologists, and I do conduct fitness classes as well, I thought of introducing a small fun session for y'all. So I request all of y'all to get up. Yes, but this audio has to play.
क्या कसूर बेकसूर बेकसूर नैना दा क्या कसूर बेकसूर बेकसूर नैना दा क्या कसूर बेकसूर बेकसूर ऐ दिल तू बता रे नैना दा क्या कसूर बेकसूर बेकसूर नैना दा क्या कसूर बेकसूर बेकसूर नैना दा क्या कसूर बेकसूर बेकसूर ऐ दिल तू बता रे
तो नैना का कसूर नहीं है, ऑप्थेल्मोलॉजी का कसूर नहीं है, हमें एडजस्ट करना है, फॉलो सर्टेन ergonomics and everyone will be fit and fine. Thank you.
Hello, this fitness topic is very dear to me. I also do a lot of yoga and meditations in the morning. You said that to avoid neck pain and lumbar pain, but you didn't say when we are on the stage and we have to stretch like this.
Yes, yes.
So how to avoid that neck pain and lumbar pain?
So that screen actually should have been more in front. So yeah, thank you.
I request Dr. Prakash Marathe to please come on the stage and deliver the talk on essential legal liabilities for ophthalmologists.
Hello, good morning. Am I audible? Yeah. Hopefully on Zoom I am audible. So good morning, everyone. I think after the physical fitness and enthusiasm by Dr. Tanmay, it is the essential legal literacy for ophthalmologists. Most of us know ophthalmology, but then about the legal issues we may not be knowing. So in this particular talk, I am going to cover legal literacy for ophthalmologists. Though you are very well scientifically, clinically, surgically, all those things are not going to take you forward. I think you must know these legal literacy so that it can save you in future for further litigations. In the past, if you are very good clinician, very good doctor, I think that was serving the purpose. But in today's scenario, you must be well equipped with all your weapons like legal literacy. So you have to face many more challenges if you want to be successful ophthalmologist. And those challenges, when faced properly, that can be only with your knowledge of all medical legal aspects of ophthalmology. So what exactly you need to do? In the past, when the family physicians were there, the patient just used to come in the clinic, the treatment was given, and they were going out. In today's era, suppose you do that, afterwards patient comes to you, doctor, you have treated my left eye. And if you have not kept proper record, probably you are not in a position to defend. If you have properly written which eye you have examined, what was the disease, what was the treatment given, probably that document is going to save you in that particular situation if it goes for further legal litigation. Or whenever patient comes in the mood of complaining, probably he is silent at that point of time only, if you have got proper documentation. So record keeping is very important. I must tell you with pride here, since almost 85 to 88, all hard copy documents of case papers are with me as on today. Whenever the patient comes, within 2 minutes, the case paper is out. That is because alphabetically I have kept that record. That is surname, name, and middle name. No need to tell any date. But that particular thing, whenever he visits the OPD, all notes are written on that paper. So whenever a patient says, Doctor 15 दिवसापूर्वी येऊन गेलो, Doctor 3 महिन्यापूर्वी येऊन गेलो, and the patient has last visit 2 years ago, he says something, I had the same complaint with this at that time. It is not cleared. And if it is properly written that it is other eye. So many things are sorted out. In case of surgery, I think patient tells that this eye was operated by you and it doesn't have good vision. Probably it is the different eye what you operated. And the record has written everything perfectly. Even if you do not remember, the patient doesn't remember, it is a document which remembers everything. So record keeping has to be perfect. In today's scenario, probably computerized record keeping is also there. But remember, sometimes that computerized record gets vanished. So you have to take backup all the time. So what I talked to you about is case papers. Even if the patient is your friend, relative, near and dear one, and you may think, why to take out the case paper? No, don't do that. Even if the patient, you are not charging anything. Even if the patient is your friend and relative, just make the case paper. Write all those notes. About indoor and outdoor, there is certain limit of keeping these case papers and documents for surgery also. In case of surgery, all steps of your surgery, even if it is eventful, uneventful, what are complications were there, what type of complications were there, and how you have tackled those complications. If those notes are properly written on your indoor papers, and if those papers are kept there for years together, I think that is going to save you. Even I have talked about for indoor papers, people are very casual about indoor patients. They do not write. And the worst thing is, you give the prescription and give that prescription sheet in patient's hand. Nothing is there with you. That is the worst thing. The patient and relatives, they have got the proof, but you do not have anything. When the notice comes, not even a single thing has been written in your records. Not even the name of the patient, age of the patient, what was the diagnosis, what was the treatment given. So you must keep that record with you whenever you give the prescription to the patient. I think some short notes must be written on the case paper, indoor case paper. As the law says nowadays about financial literacy, you must have receipt books, because for income tax purposes, that receipt book is important. I think up to 8 years, you have to keep those records for income tax purposes. Even receipt book saves you that what amount you have taken from that patient. And if it is properly maintained, not only for income tax point of view, it saves you from legal conspiracy if it happens in future. Profession tax, everybody knows it is applicable to all of us. The amount is not much more. In the past, it was just around 200 to 300. Nowadays, it is 2,500 per year. There is some concession if you pay for 4 years. I think 5th year is concessional. And one more important thing, like seniors may be there in the audience. If you cross 65 years of age, you need not pay profession tax. If you do not pay profession tax, if you are not registered under profession tax, I think they can send you the notice and they can recover so much of amount and you may be in trouble. So just keep that thing in mind. While starting your practice, maybe a couple of years are free for you, but then afterwards you must register yourself for profession tax. Nowadays, yesterday in inauguration, we have discussed about that daycare issue, nursing home registration issue. Luckily, clinics, there is no much more harassment. So clinics are not to be registered. But from corporation point of view, if you have got the operation theater, nowadays, unfortunately, there is no care, no daycare, but it is a nursing home and hospital, you have to register your surgical setup. And for that, corporation is giving trouble. So hospital registration, fire NOC, these things you must do. If you operate the patient and your nursing home or operation theater and that everything is not registered properly with corporation, probably the first thing what they claim is you have operated in the place which was non-registered. I think what depends whether the operation was done correctly or not, that is afterwards. But proper place was there for surgical operation, the registration has to be there and it has to be perfect. So be perfect in that corporation registration process. Nowadays, there are medical legal litigations. The compensations are not in lakhs, unfortunately in crores of rupees in some cases. So you must have your professional indemnity insurance. Not only personal professional indemnity insurance, but it is the hospital indemnity insurance you must have wherever you are attached to those corporate hospitals and big hospitals. From administrative point of view, you must remember that the patients may come to you and they may be having some insurance like cashless or few other insurance companies, they will be claiming their bills. So all your documentation and your process in your hospital must be perfect to make those claims in perfect manner so that they can get sanctioned. Even cashless, BOA, that is Bombay Ophthalmology Association, has said that they are not going to do cashless. You have to decide the policy in your city, in your hospital, whether cashless is to be done or not. TPA, then NABH is the thing. Our next talk will be under that particular topic, that is NABH. NABH accreditation, you may feel that it is a fancy thing. No, it is not fancy. It is helpful for you. So you can go for NABH, but it is little tedious procedure. SHOP Act is not applicable for medical fraternity unless you have got more than 10 people working in your hospital or in your institute. And the worst thing all of us have faced in Pune, that is Pune Corporation had sent notices to ophthalmologists saying that their scans have to be registered under PCPNDT. So that is A scan, B scan. Luckily, we are there in the court of law and there is stay for that particular process of PCPNDT. So even you are not doing that sex determination, if you have got scans, be aware that it is a swinging sword. So you are answerable to so many things. That is Indian Medical Council. In Maharashtra state, it is State Medical Council, it is MMC. At central level nowadays, it is National Medical Commission. You are answerable to Civil and Consumer Courts, that is CPA, Consumer Protection Act, you must remember. Police and criminal courts. Nowadays, suppose the death occurs, it is not 304 to be applied against medical professional. It should be 304A because it is bailable. In unfortunate incidences, recently at Nagar, one of the postgraduate she was behind the bar because of not only 304A, but 304 was applied to her. Information under Information Act, Human Rights Commission.
Dr.
The
Marathi.
people are using that.
Dr. Marathi, time is up.
Yes, within a short period I will finish. Biomedical waste, then forthcoming acts are Clinical Establishment Act, Anti-Cut Practice, licenses. Then these P's are very important: press, politician, pleader, police, poor people and physician. Then Janta Darbar, media trial are there. Local supervisory board and committees are there. So you have to face all this. So defamation through media, flag boards, then asking money, asking for refund of fees, mental harassment, candle picketing, demonstrations, violence. These are the worst things we have to face. So you have to be a member of some professional bodies like AIOS, MOS, QS, IMA, social associations like Rotary and Lions. So politically also, your career is, they can spoil your career. So friends, enemies and policies, usefulness for associations, laws and rules, all these things you must keep in mind. I think with these words, hopefully these are beneficial to you. Thank you. Thank you so much.
Thank you, sir. Actually, to start practice and to function it properly, all these legal compliances are very much essential, and all ophthalmologists should know in and out about these legal aspects. Otherwise, in some time or the other, they should not land in trouble. Thank you, sir, very much.
Now I would like to call upon our next speaker, Dr. Sanjay Patil. He is going to talk about NABH accreditation procedure to be followed.
Thank you.
Policy also, they agreed to that. So there was no question.
Video.
Is because just now the hospitals are registered under the Bombay Nursing Home Act. Now we are trying to change the criteria for registering ophthalmic centers under a new category, in which many of the provisions which are there in Bombay Nursing Home Act, which are not applicable to us, like having a GNM or a BSc nursing person in the hospital, etc., will not be there in the new this thing. Sir, but as of now, there is no such provision under which we can register legally. Definitely, sir. Yes, sir. Definitely.
Yeah. Shall we? Good morning. At the outset, I would like to thank POS, especially President of POS, Dr. Sanjay Tekode, Secretary, Dr. Rujuta Matswe, Trustee, Dr. Prakash Marathe, and my dear friend, Dr. Jeevan Ladi, to give me this opportunity to share my thoughts on NABH with you. Friends, today's talk is NABH, little introduction followed by procedure to be followed. NABH itself is a huge topic. We at IMA give training and technical support. It takes 2 days to understand NABH initially. So coming to today's talk, a little introduction. See, in many hospitals, we face many mistakes, errors, and negligence also. In ophthalmology department, madam, by mistake, I have put atropine eye drops in that patient's eye. Sir, we have operated wrong eye or used faulty lens with wrong diopter. And so many things, microscope stopped working during surgery. So why this happened and what are the precautions one should take? So interpretation may be like this: staff was unaware about the functioning, lack of training, and no proper SOPs, standard operating procedures defined, and the patient safety is compromised. So we need accreditation. How it will help? It will help by shifting dependability from a person to a process, that is standard operating procedure. So why accreditation is required? It gives you public recognition of achievement by a healthcare organization. It is demonstrated through internal, that is a self-assessment, as well as through external assessment by third party. And the aim is to improve the quality of patient care, as well as to ensure the safe environment and to continually work to reduce the risk to the patients and staff. The main focus is on focused on training, learning, self-development, and reduction of risk and errors. So the benefits are there to the patient, to the hospital and hospital staff. Patient gets a good quality of healthcare, better services, outcomes, results. Then satisfaction and value for money. Patients friendly and safe, they get a safe environment, better communication and protection of patient rights. About hospital staff, they get the benefit of better communication and satisfaction, more training and skill development, performance-based rewards and recognition, safe work environment. There is a huge list of benefits to the hospital. Mainly you get a recognition, then patient satisfaction with good results, then a safe and clean environment to develop corrective and preventive measures. This is very important aspect. Then continuous quality improvement, trained and skilled manpower, insurance and various empanelment. Then this gives you emergency preparedness. Also, what Dr. Marathe told about the medico-legal safety, this is offered through the accreditation. And if you try for accreditation, already these statutory compliances are required. That is, you should have registration, local authority, registration from local authority, biomedical waste certification, fire NOC, and mainly the MMC registration is required. So we are dealing with the various acts and rules that Dr. Marathe has covered already. And another benefit is you get transparency in billing system and you outsource the service management. And main thing as far as the ophthalmology is concerned is the infection control measures and documentation. So friends, NABH is a national accreditation board for hospitals and healthcare providers. It is a constituent body of QCI. A QCI is an autonomous body jointly set up by Government of India and Indian industries to establish and operate national accreditation structure. And NABH is an institutional member of International Society for Quality in Healthcare, that is ISQA. Their mission is to operate accreditation process in collaboration with HCO, focusing on quality of healthcare and patient safety based upon national and international standards through process of self and external evaluation. The core activities like to operate accreditation program, to develop accreditation standards, capacity building, and training of assessors and surveyors. So how these standards are developed? NABH started in 2009. Initially, large number of hospitals, especially small healthcare organizations, faced challenges and difficulties in implementation the complete NABH accreditation standards due to they were lacking in infrastructure, manpower, and there were financial constraints. In 2014, after intervention by IMA, national IMA, and with increasing demand from hospitals from all over India to encourage a small healthcare organization to join quality journey, NABH developed this new product that is a pre-accreditation entry-level certificate standard, and this helped many small organizations to join this quality journey. And these standards are more easily achievable and less expensive, but this process is totally voluntary. There are various terminology, policy, process, procedures, and what one should do is if you wish to get NABH, to start with, we do gap analysis, the things what are lacking with your hospital. Secondly, we complete the documentation. Then we do mock assessment, and that assessment is a self-internal assessment followed by we apply for the NABH. Then you get the acknowledgement from the NABH authorities, and then actual NABH assessment happens. And then there is some non-compliances. Once you close those NCs, you get the certification, but you have to report to NABH every 6 months. So for hospitals, there are mainly two versions. One is NABH accreditation, full NABH, and second is pre-accreditation entry-level NABH certification. And there is a now recently they have launched this separate version of standards for eye care organization, that is ECO, in line with full NABH. So for ophthalmologist, there are two types. One is NABH of eye care organization, and second is a entry level. ECO is valid for 3 years with the surveillance assessment in 18 months, and NABH is valid for entry level for 2 years. This is everything is available on their website about ECO and entry level certification. The OT size is not specified for ECO as well as for entry level certification. The temperature, humidity, the parameters they have specified specification about the air exchange. Minimal 20 air exchanges per hour are required. Then they have specified about air handling units. Again, no window and split AC models are allowed in ECO accreditation. And for entry level certification, there are no such requirements needed. OT shall be as per norm standards with a good infection control process. About ECO, there are requirements like for the infrastructural requirements are toilet for disabled patients, separate emergency room or area required, and triage area is needed. No such requirements are for entry level. Then fees structure is a different for the different type of hospitals, ECO and entry level certification. And depending on the number of surgeries, sir, I conclude in 5 minutes, 2 minutes, sir. So friends, before I conclude, I have witnessed almost 150 or 200 hospitals getting NABH accreditation through IMA. It is very easy process, and it is doable, less expensive, but this is a voluntary. There are 2-3 negative points of NABH accreditation, that they do not give value to surgical skills or medical management of the hospital or the qualification of the surgeons or physicians. Secondly, they insist on RMOs in 3 shifts, RMOs and nurses. The manpower problem is always there. So this accreditation is voluntary. Benefits are mainly 2, that is improve quality of care and safety. You get medical legal safety, And the lastly is a Mediclaim insurance, mainly cashless, you get through NABH, and they have extended this date till July 2022. With this, I conclude my talk. Thank you, sir.
Thank you so much, sir. That was very informative talk. Nowadays, NABH accreditation is very important for every practitioner. Now I would like to call upon Dr. Anaga Herur ma'am. She has 2 talks back to back. First talk is managing dissatisfied multifocal IOL patient, and the second one is tips and tricks in phakic IOLs.
Excuse me, you have changed the order or something?
Yes, ma'am. Ma'am, actually, ma'am has to rush towards Bombay, so she needs it earlier.
It's 10:30 over here.
Hello. Yeah. Ma'am, there is a change in schedule. Ma'am, Anaga ma'am wants to take her talk before yours. Ma'am, she has to rush to Bombay.
Okay. It will be midnight for me, so I was just expecting my talk to be in time. It's okay, Anaga is a friend.
Thank you. Thank you, ma'am. Thank you so much.
Really sorry for the intrusion in between. Very good morning to all of you. And at the outset, I'd like to thank POS, especially Dr. Sanjay Tekavade sir, for inviting me here and giving me an opportunity to speak to you all. I would be speaking on managing a dissatisfied multifocal IOL patient. So basically, all of us have experienced this. We have done excellent surgery. Patient is doing a very good job. He is having 6/6 vision and 6 near vision, but he's still unhappy. Multifocal IOLs are premium IOLs. We know that they are more expensive, and the patient's demands are also much more. Unlike a monofocal IOL patient where he knows that he has to use glasses for reading, many times we ignore their complaints. But here we are very aware and alert about his every complaint. Even though the number of multifocal IOLs that we are doing may comprise to probably around 10% of our practice, even one patient can make your life miserable if he is not happy. So one is the increasing or the exorbitant cost. So obviously many patients may not opt for it. If he is dissatisfied, he keeps coming to your clinic and keeps pestering you. There could be complaints of glare and halos is something which all of us really fear, and what we do not want is doing an IOL exchange for a patient who is dissatisfied. So times are changing. So it's very easy for us to say, I will do monofocal IOLs. I will not venture into uncharted territory so that I don't have a dissatisfied patient. But that's not what we can do, because there will be patients who demand a multifocal IOL because they have seen it on the Google or somebody else may have done it, and they are more educated. So we have to be very careful on our side, and we need to know how we can meet their demands. So one is patient selection, 2 is IOL selection, patient counseling, and yes, precise biometry and precise surgery is something which is absolutely mandatory. I would say, why only for multifocal? Even for a simple monofocal IOL, all these need to be followed. The first thing starts with how you can select your suitable candidate. So anybody who is highly motivated, when you go and pressurize a patient that, do you want this? I can give you this, I can give you that. Then you are actually burdening him with that, and he may not actually want that. He may be happy with his own glasses, or he may be ready to use near glasses. He should have realistic expectations. You cannot say, I will give you 100% spectacle free or spectacle independence. At the moment you say that, his expectations are going to go sky high. He needs to completely trust you. Somebody who is keeping on doubting every word you say will say, will this really help me? Will I really be happy? Probably you should be a little cautious about these patients. And he should be ready to use glasses for some activities. You have to make it clear. In fact, in our clinic, we put a stamp in a patient who is especially undergoing monofocal, that there will be dependence on glasses for near activities. So similarly, if it's a multifocal, and please do not just be dependent on your counselors, especially in multifocal IOL patients, make it a point to speak to the patient as well as at least one relative. Best would be 2, because the relatives, usually the patient may be an old man, a grandfather who may not really understand what you're trying to say. Now, what's the ideal multifocal IOL? Just like an ideal husband or an ideal wife, I think this is still going to be elusive. So what you need to do is basically choose the best IOL. Now today we are spoiled for choice. I think there are so many choices that we have today, depend, and it could be more of trade driven. So I think what you need to do is understand what works for you. Most importantly, there will be a gray zone where this patient may or may not be the ideal candidate, especially if you're going to start your multifocal practice, or if you're not very sure, it's better to avoid. Now, finally, what ends up is you're going to be a matchmaker. You need to know what your patient's needs are, visual needs, especially lifestyle choices, how is his personality. So speak to the patient yourself. So we usually ask 3 questions to the patient. One is how much is his near work? How many hours does he do reading? Two is how much of computer work. So you know approximately what is his intermediate work requirements. And third is how much of night driving. So these are the 3 questions in our clinic, which is first asked to the patient. So if he is a continuous or a regular night driver, say Mumbai, Pune every night, I would probably avoid. If he's saying that, yes, I do at least 2 or more hours of computer work per day, then you know that he needs intermediate distance. You cannot be happy giving him just a multifocal where there is no intermediate correction. Or you going for an EDOF, which gives him more. If he says that I'm not reading at all, then you can go in for more of a EDOF, which gives him more intermediate. So you have to decide what kind of lens you're going to what patient. Most importantly, under promise and over deliver. So suppose you have a patient now who is dissatisfied, how do you manage? So there are these 7 C's that you have. One is consecutive treatment, which means that you need to do both the eye surgeries ideally in a short span of time. You still have patients who come to you will say, I will do one eye now. Suppose the other eye, the lens is clear. What do you do? So I have had patients like this, but I need to counsel them. I tell them that yes, there could be a 50% chance that you may not adjust because one eye is using near glasses, the other eye has a multifocal IOL. So he needs to take a call. If you feel that the patient is a little fussy, better to avoid. Second is cylinder and residual refractive error. I would be going over all this a little more in detail. Capsular opacification, CME, corneal and ocular surface diseases, centration of the IOL, and a reduced contrast sensitivity. So most importantly is your residual cylinder or a refractive surprise. We talk about higher order aberrations, we talk about negative spherical aberrating lenses, but most importantly, you need to hit emetropia. Unless you have that, all else becomes invalid. You need to have a perfect biometry. Suppose you have a refractive surprise, identify where you have gone wrong, go back to your K1, K2, go back to your biometry, see whether you have opted for the wrong IOL, put in a wrong lens. And no matter what lens you use, even if it's a monofocal IOL, the moment you have a residual astigmatism, it is going to reduce the contrast sensitivity of the patient. So beware of patients who are say 0.75, 1 diopter, 0.9 diopter. So these are the patients where you have to be very clear whether you're going to use a multifocal toric, whether you're going to do an LRI, or whether you're going to tell him that you will have a 1 diopter residual, and if he's ready to accept, only then. So when you have a say 2 diopter, you are very clear that you need to do a multifocal toric. Now suppose you have a residual ametropia, what do you do? First thing is see how much is the residual. So for example, he has a minus 0.5 and he's not complaining. Your technicians or your optometrists have to be trained. They should not blurt out, हाँ आपका ना 0.5 number बाकी है. The moment he says that, whether or not he is symptomatic, he will have कि मेरा number बाकी है. Second, go back and do a topography if you have a residual cylinder. See whether you have induced it, whether there has been a wound burn. And if you feel everything is perfect, look at what is the residual and see what is the, if that residual astigmatism or spherical is stable or not. Now, suppose you have a spherical, around up to 1.5, you may do a touch-up either with PRK or LASIK, but I do not prefer that personally. If you have anything more than 1.5, definitely I would think you should go in for an IOL exchange. So more than just say 1.5 or 2, it all depends on at what point of time you pick up the refractive surprise. So in our clinic, what we do, immediately the next day we do a refraction. So you know grossly whether you have gone wrong in a gross way. So suppose a patient is 6.6 with say minus 0.5, you know. So next week anyway, you're going to give him the perfect refraction. So IOL exchange is something which you have to be aware of, but obviously you're taking the utmost care to have a good biometry to prevent all that. Now, posterior capsular opacification, sometimes you may have just PC folds. It may not be actually a PCO also. But these patients are definitely going to be more sensitive because already a multifocal IOL is going to, especially the diffractive variety, is going to reduce their contrast sensitivity. And remember that sometimes you have PCO on table. So you make it a point to mention it on your discharge paper and explain to the patient. But remember, once you do a PCO, YAG PCtomy, then IOL exchange will become very difficult. So you have to be careful. CME is something which sometimes we underestimate. So around 3 weeks, if the patient was happier earlier and he's now complaining, everything is fine, but his vision has dropped from say 6.6 to 6.9, partial, do an OCT. Many times you may pick up a early CME and you can treat it. Ocular surface disease is something which is now on the rise, especially post-COVID. Yesterday, I just presented a paper on face mask related ocular surface and dry eye problems in COSCON. So now today, if you look at the number of hours all of us are wearing masks, mask itself increases the amount of dry eye, reduces the T-bud. So all these patients, especially high risk category, diabetic patients, older patients, postmenopausal females, all having high risk category, you have to look at their ocular surface. We are including a dry workup in all our multifocal IOL
Madam, 1
patients.
minute.
Yeah. So if there's a decentered or a tilted IOL, especially if there's a zonular weakness, you have to be extremely careful. Glare and halos, you have to explain to them, counsel them earlier itself, but do not ask leading questions. You know that there is neuroadaptation. If you have a patient who has a glare and halo in one eye, would you go ahead and do the other eye? So first, go ahead and see whether there is any ocular surface disorder, PC folds, decentration, CME, PCO, all that has to be ruled out first. So neuroadaptation, just tell the patient to be calm, and it might take up to almost 12 months depending on the age and how the acceptability of the patient is. Angle alpha sometimes could be a little high, but I would really avoid a patient who is having more than 0.7. You have to look at eye tracy or even IOL master to get these values. If it's a previous refractive surgery, it was definitely be a strict no. However, I would like to present just last 30 seconds, a patient who had 4-cut RK and who insisted on a trifocal IOL. This was the topography. You have to work up these patients extremely well. And this was the IOL Master 700 report. And you do a ASCRS online calculator for prior RK, you can increase or keep a myopic target of around 0.5. This is the most important test. You do a pentacam holiday report and see whether there is a spike like this. Only then you know that the patient is going to be happy. So this was the routine surgery. I won't go into it. And patient was happy post-op. So basically, to conclude, patient should have realistic expectations and give them a good counseling. More than anything, beware of your multifocal IOL patient. If you are good to them and you have done a good counseling and a good treatment, he can be like a good wife, loving wife to you. Otherwise, they can make life hell for you. Thank you so much for your kind attention.
Whatever you explain to the patient in your language,
yes,
but only one question they have to ask to a doctor. खर्च किती येणार? खर्च किती येणार? And 50% patients drop out the idea of doing multifocal.
I agree, sir. But today
And
we
in
have very good Indian
insurance
varieties also.
They are not getting. Mediclaim also they are not getting for multifocals.
I agree, sir. But today we have good Indian varieties also. And basically, I think before we even speak about money, we need to know whether they want it. So if you tell them that, yes, you are dependent on glasses, do you want to be free of glasses? If they say yes, only then you go ahead. Otherwise, it doesn't, there is no question of going ahead at all. So it is a premium lens. We have to accept it. Actually, most of these patients have their relatives having iPhones. So I usually tell them that this is something that you are buying as a luxury and which you may change in the next 2 years. But your eye surgery is going to be once in a lifetime, whether it's for yourself or it's for your parents. So you have to decide what you want for your parent or for yourself. If you feel that spending for that is not relevant or not necessary, it's up to you. So usually we do not pressurize in any way. I think it is the patient's decision. Only then your patient will be happy. The moment you try to pressurize, then you become, the demands will be more, expectations will be more.
Thank you.
I hope it was...
for cashless, and there all the problems start because they think it is their right if they have any insurance, they want it cashless. But Bombay somehow, I think they have managed to keep the TPS away, and hence they can, whenever they tell the patients are willing because they feel it will get reimbursed. I don't know why we cannot do it here in Pune. I think Dr. Marathe is here.
I think for
Laptop.
cashless, that ban by Bombay Ophthalmological Society was there, because unanimously they decided. Here in Pune and otherwise in other cities, probably they have got that option, because if it is the cashless which is available for patients and relatives, maybe they are benefited. Even few of the hospitals, even corporates, they don't listen to you, and then they take this patient. So unity may not be there in other associations. About costing of these IOLs, probably what you're asking is whether it is covered under insurance or not. Probably this type of patient, they always say whatever is best possible in the world, we want that. Cost is no issue. Probably these are the patients for whom you can have these options of high-end IOLs. That's what I feel.
So I think the same thing holds true for femtocataract also. So we give them the choice. We do not say this is the only option available. So it is up to them to choose what they want. Can I go ahead with the second? Yeah, thank you so much. So phakic IOLs is something which is very close to my heart. All patients where LASIK is not possible, we have today a good option of phakic IOLs, no financial interest. Most importantly, all of us do LASIK or PRK, but we need to get out of our comfort zone to go into uncharted territory, which is a phakic IOL. So we need to think beyond LASIK. Remember that the learning curve may be short because we are already using IOLs like the plate haptic IOLs of Zeiss or any other company, which are similar to what phakic IOLs are. What is important is a perfect planning, a very meticulous surgery and a regular follow-up and watch for complications. So what are the main reasons why you could have a poor outcome? Why are we scared of doing phakic IOLs? One is you should have a very good patient selection. If you have an improper patient selection, improper measurement, I think the key to all good success outcomes in phakic IOLs is a measurement, and that depends on you. Do not depend on your optometrist or on your assistant. It is you yourself who has to do the measurement. Incorrect lens size, which is obviously a final consequence of an improper measurement, and an improper implantation. So let's see preoperative, intraoperative, and postoperative scenarios. If you look at patient selection, one of the most important things is a perfect refraction. You need to do a cycloplegic refraction. Now you have patients who have -16, -20. Some of them may not know the difference even with a 1 diopter plus or minus because of such very high ametropia. So you have to be very careful, recheck the refraction at every time, see the stability of refraction. Many times there could be progressive myopia, pathological myopia, and you should not end up having a residual or a refractive error which is coming to you after a few years. Remember, the power of the lens depends on the manifest refraction. So your refraction is going to be the key. If it's a patient who is keratoconus, he should be stable topography, especially over 1 year, both refraction and topography. You should have a centralized cone. Ideally, K value is less than 52 and a clear central cornea. Now, if you're looking at a patient who is a phakic IOL, how do you work up the patient? Just in short, because I would be dealing with the other surgical details more. One is it should be a complete refractive surgery workup. So not only just a slit lamp examination, you should do a topography, a tomography even for a phakic IOL patient, because you do not want to miss out on a very early keratoconus. Optical biometry, ideally, yes, I was just speaking to somebody, you can do an immersion also, but optical would be even better. A white to white, which is the crux of a phakic IOL patient. So white to white, how we do it, I'll show you in the next slide. Now, with regard to glaucoma evaluation, also ask for a family history. So a patient who is having a very strong family history, you should do an OCT optic disc, look at the gonio, look at the corneal thickness, as well as counsel the patient that he will need to have a regular IOP monitoring. Retinal evaluation goes without saying, and treat any kind of lattice or any peripheral degeneration, and a specular if required. Now, this is how we do the white to white on table. The patient is on under the microscope in the operation theater. You first calibrate the vernier calipers and then take 3 readings for each eye. And each time you switch it off, switch it on, calibrate, and then take. Bring it back to 0, not on the same number. Okay. And right from white to white is horizontally at the 0 180, because 0 180 is where you're actually going to put the lens. Now remember, if you are also doing an IOL master or a pentacam or lens star, these are having different optical principles. So you cannot say your white to white is different and your IOL master, which one should I choose? Usually by thumb rule, I consider IOL master to be 0.5 millimeters greater. That means you are overestimating compared to your white to white. Now, white to white measurement, both eyes ideally should have the same. If there is arcus, then you include the arcus. Sometimes you could have pigmentation, so you should exclude the pigmentation. Now, so you have two things you have. One is the calipers that you're going to use, and second is, for example, the IOL master. So which is better and how do you choose one of them? So for that, you need to know what are the basic differences. So in your manual measurement, what you are doing, I do it myself for all my patients. You know that it is accurate. However, there could be changes because sometimes for each of the three readings also, it could differ by say 0.1 or 0.2. It depends on the examiner. Greater variability could be there, less repeatability. It could be subjective because you may think this is white to white. You may think one person, for example, what I feel is right may not be a thought right by him. And take three values. Compared to that, if you have an automated measurement, like for example, a pentacam or an IOL master, it's more reliable, more reproducible, more accurate, objective, but you need to do both and compare and correlate. Ideally, use both. I used to also use the UBM very regularly. The problem with UBM is it depends on the technician. So many times when I used to refer, because I don't have it with me myself, I used to find that there was more error in that. So I stopped doing it. However, literature says that yes, because UBM actually checks the S to S, it is supposed to be more accurate. Now, lens size is something which is now a new concept. So you have two patients here, both with the same white to white 12.3. But the lens rise is in one is 418, the other is 1220. Now, what is lens rise? It's basically the length or the distance between the topmost part of the central part of the lens to the perpendicular drawn between the S to S. Now, what is the significance? If the lens rise is more, definitely you're going to have a lesser vault. So it is not only the white to white, but also the lens rise that is important. So how do you calculate the size of the phakic oil? All of us give our data to the company and then they use the nomogram. But rule of thumb is it depends on the ACD and the white to white. These are the two most important things. Now, suppose the ACD is less than or equal to 3.5. Rule of thumb is you add 1.1 and you round down. If it is more than 3.5, then you add 1.6. So just for your knowledge. But most importantly, I think it is more of a trial and error. You use a company's lens and then you see how your results are. And then you tweak your white to white and the size of the lens. Most importantly, whatever they give you after you have given them the data, recheck each and every reading, including K1, K2, eggshell length, everything. And then this is something like a toric IOL. You need to put it on your OT wall so as to know how to rotate it clockwise or anti-clockwise. Know your lens. Now there are different kinds of lenses. So you, for example, on the left, you have the IPCL from the care group. The ridge should be on the left on the leading haptic. Whereas on the right side is the ICL where the hole is on the right side. So you should know what lens you're using and how you have to align it. Now going on to the surgeries. Now this was a very interesting patient. I'm putting in the ICL and look what happens here. The lens has got folded on itself and it stays there for almost 30 seconds. So what do you do? So this is ICL is something which is very, very thin. So it can easily flip. Okay, so you have to be very careful. In this case, what you can do is actually rotate your right hand in such a way that it opens up in the right direction. Keep a watch on the leading right hole on the leading haptic. This is the extremely most important crucial step in any kind of surgery. Now, never attempt this. Now, this was a surgeon who was in a hurry to put in an ICL. The ICL has gone in the eye and now he sees that it has got flipped. And look what he's doing. He's actually using two instruments and flipping the entire lens in the anterior chamber, which I do not recommend at all. This is something which you should avoid because it can damage the corneal endothelium, the lens, everything, and this can really cause problems. So this was what this was my case where I was putting in an ICL and it actually got flipped in spite of me trying to rotate the cartridge, in spite of trying to adjust. So I put in a little more of viscoelastic. I'm trying to use the lens manipulator on one side and the Sinsky. But no matter what I did, it finally came out upside down. So how you have to know that you have put it upside down. That is the most important thing. Look at that hole, it's gone on the left side. So this is the most important thing. You have to keep your eyes open. So you can very easily remove it with a McPherson, reload it completely again. There is no shortcut. Do everything all over again. So it's very easy. You just put in, reload the lens, and then I'll just fast forward it a little bit. And then put it all over again. So simple tips, like whenever you're towards the end of the surgery, sometimes they could be shallowing. So hydrate the wound even before you start your IA, because the moment you stop your eye, the anterior chamber can shallow. Never go with the eye underneath the lens. Hold the eye around just over the central hole so that you can easily aspirate out the viscoelastic, and look for rotation. Even after you have removed the speculum, sometimes there could be AC shallowing, there could be slight rotation. So you have to be a little careful. Post-operatively, yes, all of us see vault. I see the vault the next day. But suppose you have a vault of say 300. Remember that it can change over the next 1 week. It will not remain 300. It will go even up to 400 or 500. So you have to be careful. Look at refraction, IOP, and vault at every visit. Now, improper sizing can cause, like on the left, if the ICL is too big, there could be an excessive vault. If it's too small, then it could be a very low vault. Now, this is something which you need to remember. There could be a mid-peripheral lens touch. So what happens is there's aqueous accumulation in the center, which can cause a cataract later on. So what you need to have is a complete separation between the ICL and the crystalline lens. And just the last 30 seconds, the most common cause of an ICL explantation is an improper sizing. So this was a patient who I had. The vault was perfect. It was around 650, but this was one of the first lenses. Probably the water content of the lens had some issue. So the pressures were very high. You can see how the cornea is edematous. It's not the video which is hazy. It's the cornea which is hazy. Pressure was around 50, and in spite of maximum medical therapy, it didn't come down. So this is an IPCL. So I'm just removing the haptic from the underneath the iris into the anterior chamber in front of the iris. It's very easy actually to remove these lenses. And then with the McPherson, you can just pull it out very, very gently. So basically, these are, this was a very good, interesting case, an IPCL patient who came to me 6 years later with cataract. Remember, this is an optically clear lens. So when you're doing a biometry, you don't need to make any changes. Just use whatever this thing you had, diopter you have. So this was the patient who wanted femto laser. So the femto has already been done. And because this was an IPCL, I thought it was a rigid lens. So I did a phaco underneath the IPCL. So I just rotated the IPCL vertically because I am doing surgery temporally. And then finally it was the same. I won't go into the details because of lack of time. So to conclude, this patient was 6'6". Do not compromise. Good preoperative workup, meticulous surgery and postoperative monitoring is important. Explain to the patient risk of complications. Every patient, I tell them about cataract and IOP rise, and I put it on paper. Marathi sir was speaking about good record keeping. Yes, I put it on paper. So let the patient go to 10 other people, take 10 other opinions, doesn't matter. Remember to tell them it's different from LASIK. Give them all the options that you have and need for regular checkups post-op. Thank you so much for your kind attention. And thank you, sir, for adjusting me. And sorry for the other speakers because I took before.
Anyone in this audience doing a phakic IOL? So you are the best just to ask questions.
No questions, but very good tips given by Dr. Anaga. One is the sizing. That is the most important thing. And I think manual sizing, if you do in your OT with the patient supine, considering the cyclotorsion, if you're sure about your 3 and 9 o'clock, manual caliper is equally good. You have to tell the company what you use. That is more important. You can't mix things like, you can't mix optical biometer reading with a manual
Thank you.
caliper. And secondly, now with the center hole, the issues of YAG and all have also been taken care. So I think it's a good option for any refractive patients who is not a good candidate for other procedures.
Thank you so much.
Thank you, Dr. Tekavde. Thank you, Anaga. There are two more speakers. Dr. Geetanjali Sharma. She
Yes,
will be-
sir.
Yeah, you can start your presentation.
Yes, sir. A very good morning to all of you. And at the outset, I would like to thank POS Organizing Committee, Scientific Committee, and especially Dr. Jeevan Ladi for giving me the opportunity and allowing me to speak online because I'm in the US. So right now it is 11 p.m. So I'll just start sharing my screen.
The topic is challenges for women ophthalmologists during COVID times.
Are my slides visible and is my voice audible? Please tell me because the glaucoma person who spoke, his slides were not seen. So you'll have to help me telling. Okay, I'm going to speak on challenges for women ophthalmologists during COVID times. Let me be honest, without the help, support and encouragement by men in ophthalmology, men at home and men at working place, these challenges are not possible. So it's always a teamwork. Women doctors are always having challenges. We have the inspirational stories of Dr. Anandibai Joshi, Dr. Akhmabai Rao. In olden times, it was more popular branch was obs-gynae, but anesthesia, pathology, etc. But when I took up ophthalmology had become very popular among women. But believe me, in last 25 years, ophthalmology evolved so much that we ophthalmologists, all men and women, had to take up the challenge to upgrade ourselves, to update ourselves, and to learn the new techniques. Surgical techniques changed, instrumentation changed, laser refractive became a specialty. So learning was a big challenge, especially for women, because we had families, kids, so we had to adjust with their school vacations to go for the training courses. But the most important challenge happened last year, and that was due to COVID attack. It was unexpected, unknown, invisible enemy, and unimaginable impact that it caused on the whole globe. So there were challenges in the hospital, challenges at home. There were financial crises, there were health challenges, and most important, there was mental stress. So women in ophthalmology were playing different roles during COVID times. They were deans of some institutes, institutional heads, head of the departments and faculty. I'm telling this because many of my ophthalm colleagues gave their services as COVID warriors in various wards of Sassoon and other hospitals. And there were private practitioners like me who never kept their clinics closed. In spite of the second wave, which was very severe, we gave our services. During COVID times, we had ophthalmology challenges as well, but redness and mucormycosis or vascular occlusions, we knew about them. We were trained about them. So there was no issue to manage these cases. But the main problem were the safety issues at the hospital and the staff issues. We women were working in the hospital and going back home. Our kids were there. Our elderly parents were there. In-laws were there. To keep a safe distance from them was a difficult challenge for us. I remember in those days, I used to come home and I used to clean each and every corner of my house. And I used to keep safe distance from my family members. That was a big challenge. So at the hospital, we kept all safety measures. Staff issues, as you all know, in the beginning, the residential societies of our staff removed them. So they had their own problems, financial problems, and their mental issues as well. And we had to manage, especially the women. We learned about online consultations, the legalities, etc. Because earlier times we used to give our advices on phone. Now it became a legal thing and we had to take up this challenge as well. No face-to-face communication was the biggest challenge for women ophthalmologists. Look at me in PPE and in masks and in facial shield. Who would recognize me? Usually the men, all men doctors, they say, or all men, they say that women use their personality and their beauty to convince patients. Yes, we do use our beauty, which comes through intelligence, and we use our personality to convince the patient. But when you are in PPE, patient doesn't know who you are. Many a times, it is not known whether this is a man or woman. and still we are convincing the patients. I'm always worried about my pediatric patients, but no issues. They are not scared of me. So this is one challenge that we all are taking now. At home, there were no maids, no cooks. So the whole work was done by women ophthalmologists at home. But as I mentioned, initially, of course, there was help and support from men in the family. Online schools was another challenge taken by all young mothers because it was not easy for them to deal with those. And all this caused a lot of mental stress on many women. Pregnancy and motherhood was another challenge taken by some young ophthalmologists, and these two beautiful angels have joined POS family, and my heartiest congratulations to Dr. Devika and Dr. Natasha. Both of them are POS MC members. So remember, they were taking up challenges at hospital, at home. Of course, POS duties were there, and still they took up this challenge. Hats off to them. Financial crisis, I may not speak at large because Dr. Seema is going to speak about this, but COVID times gave us a chance to all women ophthalmologists to understand investment, mutual funds, etc. So there was some literacy, financial literacy, and this challenge is also taken. Now I come to leadership challenge because definitely that is very close to my heart. I have just shown 4 photos of leaders, all these ladies, along with many others who were leading their respective associations, did wonderful job during COVID times. There are special qualities in women leaders. We are strong-minded, we are hardworking, we are multitasking. There is resilience, there is non-fragility, but most important is our caring and sharing nature. I would never say to any managing committee member, मला 2 तासात हे काम हवंय, मला 2 आठवड्यात याचं उत्तर हवंय, मला 2 दिवसात ईमेलचं उत्तर हवंय. No way. It's like a family. All managing committee members were like my younger brothers and sisters to me. We are fighters since our birth. I may not go in details, but everyone knows that sometimes a girl has to fight for her birth as well. We have to prove at every step. But in COVID times, we have to learn to live beyond beauty, and in leadership, we have to think beyond our womanhood. As you all know, my presidency and pandemic started together. So all the planning got washed off. But I feel very fortunate to be president of POS during those challenging times because I could do something different. I could do innovative and more creative. It was a historical year for POS, and in true sense, POS went global. Not just that I'm invited at various international meets to share my experience as POS president during COVID times, but there are many other members who created their name globally. Dr. Devika Joshi started Mandala art for POS, and then her art got published in European journal. Suchi Smita's art was there on the front page of IGO. So there are many other examples. I'm very happy today that we are back to physical webinars or physical activities or physical conference. And we also had live surgery. But last year we could not do, but we did a unique program called Surginar, right since 8 o'clock in the morning till 6 o'clock in the evening. 10 hours. Surgical videos were shown one after the other from all subspecialties, and this program was watched by ophthalmologists from US, UK, Dubai, Australia, from everywhere. And thanks and hats off to the secretary, Dr. Mukesh Pariyani, for a wonderful surginar that we could do. And Dr. Colonel Deshpande had said, both of you have passed the acid test. So these are some proud moments, and the challenging moments that we experienced during POS last year. So what did I do? I just tried to keep my managing committee together, and I just tried to create some connection with every member of POS, maybe through my
Gitanjali, 1 minute only.
Yes, morning blog, keeping peace, mind and body. So here, all the girls who are present and who are listening to me, my sincere appeal to them that think of joining the managing committee of POS. Take POS flag at more higher level. Don't get scared of elections. Elections are there, and just go for them. You have vision, you have ideas, do planning and do team building. Always remember, the ultimate measure of man is not where he stands in moments of comfort and convenience, but where he stands at the times of challenge. Martin Luther King. Do self-exploration, introspection, and you will find there is a lot of power inside every woman. So now we doctors, we ophthalmologists have to think beyond ophthalmology as doctor. I'm also now I'm a office bearer. So we are doing a lot of work in different fields for medical fraternity. So that can be vaccination drives, that can be awareness program, but never ignore your own health, your own diet, fitness. Already Tanmay has spoken about. I'm sure now POS will have definitely Garba, and Garba girls would like that. I never forgot my passion of Kathak or adventure sports or my poetry. Always give some space to you, 30 minutes at least in a day. Read Bhagavad Gita, have peace of mind and love. This is my daughter. Last year, I never told anybody. I was taking challenges at hospital, at home for POS, but she was also taking a challenge managing COVID patients in California. So as a mother, I used to feel scared, but then I told myself, this is the golden opportunity given by God to all the doctors, and let's serve. This is once in century happens. So let's all do, and we all sailed successfully. So girls and all the young men and women of ophthalmology, find your goals, reach the goal, but find another goal. The life is full of challenges. It is the journey that is more pleasurable. You can see my two pictures. The middle one, I've already reached the top. The board says you cannot go beyond this. And if you see the next picture, I have made my back to that board because I want to find another way to reach another goal. So that's my opinion, that one should find newer ways, neuros. Asa marga maza nirala asawa. Thank you very much. Thank you, Dr. Jathar sir, for giving me this
Thank you,
extra money.
Gitanjali. You continue your journey further. And we must appreciate her work during COVID period, that she kept the POS activities lively for whole year.
Yes, sir. We did more than 43 webinars and 3 physical activities as well. As and when we got chance, we could do it. But congratulations to the new team for the fantastic conference, to Dr. Tekaude and the whole team. The conference is really, really good. And congratulations to Dr. Dake sir, Dr. Pahuja, Dr. Seema, and all award winners of POS. Congratulations. I'm in the US, and so it is already 11 in the night. So let me say good night to all of you.
Thank you. Thank you, madam. Now I request Dr. Seema Khaire, madam, to please come on the dais and to give a talk on financial management.
Good morning, delegates. At the outset, let me thank the POS for giving me the opportunity. Chairperson, co-chairman and moderators and seniors and my colleagues. See, today, right now, I'm going to talk about the financial management. In the corona pandemic, how many of you not suffered any financial problems, or there was no financial impact? Everybody had some impact or the other. In the morning, we had a beautiful lecture by Tanmay talking about fitness. Dr. Kakadia said about the Omniglow. So, and Marathi sir said about legal aspects, NABH. So, for all these things, what requires is a financial stability. The moment you're financially stable, you can think of fitness, and then you can think of patience and buying new instruments, and even attending the conference. Yesterday there was a less attendance because everybody was busy in the OPD. So all comes together, all your quality of life comes with your financial management. So what is the need of financial management? See, you should be ready for various situations that can come in your life. And secondly, if you have your passive income, that is the income coming from your investment, is more than the what you are earning through your OPD or IPD or whatever your core business or core profession is, then that is a need to have financial freedom. What is the financial freedom? you have to plan your expenses in such a way that, for example, after 10 years, you equally earn, or your income is so stable from the other sources that you can concentrate more on your passion, you more on your profession and your patients. So it doesn't mean, suppose you are getting a lot of income through your investments, you are not going to stop your practice. No, but you will be more free. Dr. Marathi sir said that there is a lot of harassment we face as a doctor. Why? Suppose a patient is asking for the concession, we tend to give some concession. Okay, 15,000 करा, 10,000 करा, 5,000 रुपये concession. Why? Because like all the time we have some botheration about EMI or salary or something. So financial freedom is very important. So financial freedom, how we can invest in the real estate is a main, what we can say, your growth or your money can multiply in many folds. But importantly, when you buy any real estate, the profit is when you are buying. बरोबर आहे. जेव्हा एखाद्या गोष्टीची किंमत कमी असते तेव्हा विकत घेतो, पण आपल्याला जेव्हा विकायला जायचंय तेव्हा मार्केट रेट पेक्षा कमी द्यायला लागतं. ओके, सो वेन यू आर बायिंग रिअल इस्टेट, इट इज अ प्रॉफिट वेन यू आर बायिंग. Rent you get through the real estate or through your any shop or flat should be more than the interest you are paying for that particular asset. Then it is a asset, otherwise it becomes a liability. Gold is also another good option, but understand like liquidity is easy, but a capital gain tax is applicable. The risk of robbery is there. So buying a gold bond, so within gold bond is a good option. Mutual fund is another option for investment because there is no active time required, but profit is relatively less, around 3%. And if you are buying through the agent, then 1% agent takes whether you are in profit or loss. So do it yourself. Shares, it's a good option, and the profit is compulsory when you buy shares, provided you know how and where to invest. So you should keep on reading the books and understand, go ahead. So especially when you are buying a shares, see to it that it is a good company which has a market capitalization more than 10,000. Debt should be less, shares, dividend and tax paid should be increasing, and importantly the share of a owner should be there in the company. For example, S Bank or Reliance, if you see the owner itself is reducing his share in the company, it means the company is going to doom. So these are the things, screener.in, where you can see which companies are doing well. You can apply tools like market capitalization and debt. And the next slide, you can see there are around 15 to 20 good companies which are good. So when you are selecting any stocks, just select in a such a way that you are in a safe zone. See, if somebody says, I'll give you 1 lakh rupees and I'll give you 100 hunters, nobody wants. We don't want that money. So money with the peace of mind is very important. There is another website, TradingView. Here you can see the charts, and accordingly you can invest, buy on a dip and sell when it is high. We as a doctor can interpret the ECG. Why not this particular charts? So what we require is little study and donation. We have to invest our time. Maybe once you invest your time, like looking at the ECG, you can say whether it's atrial fibrillation or MI. The same way you can see, oh, this is company is doing well, this is a dip, I'm going to buy. And now question comes, how much to invest? See, you have to, it's a thumb rule, if possible, invest 20% of your revenue, not the income. 20% of your revenue should be invested to have a financial freedom later in the life. Loans are inevitable, but the good loans are the housing loan or the business loan or instrument loan. Avoid personal loan, car loan and credit card loans. And if you have those particular bad loans, just try to close them as early as possible. This is my disclaimer, is like this is my personal experience, but when you are investing, you have to have your own study. Thank you very much. And you must have seen like all my slides are in the form of honeycomb. Why? Like honey takes honey from everywhere. We are the doctors. We have collected enough knowledge, like a knowledge bees. Now, as a money bees, we have to invest and cherish ourselves. Thank you.
About this financial talks, we hear lot, but whatever you have said is practical for all ophthalmologists.
Thank you.
Thank you for this.
I invite all the speakers to come on dais for the group photograph.
Dr. Bijlani, very sorry for handing over the stage to you after half an hour late.
Vardhaman. Yeah, you are right. Okay, good morning, everybody. While this photography session is going on, let me tell you all that today's quiz is a little different from what we've done, because today mainly has been handled by this young man in front of you, Dr. Vardhaman Kankaria. A big hand for him. Yeah. So we've distributed pads to all of you. Please ensure that all of you have one each, and he'll explain to you how it goes about. We have two sets of 20 questions, and then you'll get points accordingly. At the end of 40 questions, 9 of the top whoever's here get some awards, and 5 of them will come forward on stage for the final round, in which there will be 10 questions, and that will be fastest finger first, like we always did for our quizzes. In between, there is an interlude where there'll be some trivia. Okay, I'll just give it to Vardhaman to explain a little bit. And by the way, today's judges will be Dr. OK, Radhakrishan, and Dr. Shashi. Can you please stand up and show them Udaya? And their decisions will be final after the quiz master's decision. They are the judges, they are the jury, and they are the executioners. Of course you do. Extra coffee.
And some chocolates. So friends, first thank you Dr. Bijlani sir for the kind invite, and we are looking forward to have all of you over for this new format of the quiz. Until now we have had quiz when there are teams and the audience is basically participating passively, but now this is the format for the first time in POS, in which each and every of you is going to participate, and this is going to be very, very exciting. This is going to be the best of education and entertainment, what we call as edutainment and infotainment as well. So do you all of you have the keypads? Have you all of you received the keypads? If there is anybody who has not received it, they can take it from the microvision person who is there at the outside, or you can just, yes, raise your hand, they will give you the, yes.
Someone from microvision, there are people here, Dr. Jathar sir, Dr. Kelkar, who don't have it. So किसी को नहीं मिला हो, please आगे आ जाइए और ले लेना. आपने सबने participate करना है, and we're going to have a good time. And while they are setting up, there was some electrical problem. We're just going to be having a short commercial break. Micro, idhar aao bhai. Someone from micro, come here. Your time starts now. 1, 2, 3. See how they run. A commercial break.
Good afternoon, delegates. Good morning. Welcome. Warm regards from Micro Labs. This is quiz session sponsored by Micro Labs. So, with the brand name Prahalub and Aritz. Do join us.
He is too overrun by the occasion, and what he wanted to say was right.
First of all, thanks for Dr. Kankaria and Dr. Bijlani sir giving us an opportunity to participate in this quiz contest. And definitely we are always with the POS, Pune Ophthalmic Society. Always, sir, if you give us any opportunity, we are always ready, sir. And from the makers of Trehaluk as well as Aritz.
Thank you. And Dr. Seema Khere, you're talking about loans and other things and all. You forgot one very, very important thing. You should have mentioned, please participate in quiz. Aaj rokda milne wala hai. So that's, some loan of maybe a very small percentage, but that's how it goes. Next gambling.
Yeah, we can do it from here also. So friends, just to tell you about the rules, you have the keypad in your hand. It has 4 buttons, A, B, C, D. Each question is going to flash only for 15 seconds. And you have 15 seconds exactly after the question is read out. And then you will have to give answer as soon as possible. You are allowed to change your answer till the time the 15-second thing is over. There will be a ticker. And this, actually at the end of this 40 questions, we are going to get the final 9 top players, and they are going to be calculated not only by your correct answers but also the swiftness of your answers. So the time to answer is also equally important, so you have to be very, very quick. So I think we will probably start.
Anyone has got any questions besides asking for what the questions are? You understood how to carry out this thing? You are clear about it? It is time as well as your correctness of the answer, which will finally come into play when we calculate the final 9 top guys who will get that loan reduction installment. And 5 of them will come up and they'll be facing the final round. In between, there'll be a short break for some, different things. Yes? Wait for the question.
Yeah.
Flash there.
So when the ticker starts, that is when your keypads will get activated. So you have to press on the answer that you want to give, like A, B, C, D, whatever you want to choose. You can change your answer till the time the ticker is still going on. So if you have pressed A, but if you feel that no, it is C, you can change to C. So it will be the last answer that it will be given from your keypad. Okay.
Once you change it, once you press a particular button, that will be into the memory of it. Then the next one is started, so it starts all over again. Understand? So then you can't change the previous one. And there's no going back. Nothing doing.
And just to give you the understanding of the prizes, we have Microlabs has been kind to support this event. The first prize is given in the form of vouchers of 5,000 rupees. There will be a trophy given by Pune Ophthalmic Society at the hand of President. There will be a pen drive and a special certificate. The second and the third players will also get the cash vouchers, the certificate by Pune Ophthalmological Society, and a pen drive. And the 4th to 9th will be getting a basically a cash voucher from Microlabs. So, excuse me. Center button. No, I think you don't have to worry about the center button. I believe. Yeah. Don't press the center button. Just press the ABCD. Okay.
So all of you present over here in person and all others there in the virtual world, please join us for this magnificent new format of quiz. And I'm sure you're going to enjoy it. So without much ado, are we ready to start? Are we ready to start? Thank you.
Perfect. Yeah. Can we have the questions and the music? Can we have the music on? Yeah. Once the timer starts. So, I mean, just to give you an idea, so of course, this is one of the questions, but once the timer starts, you will hear the ticker, and then till the time the ticker is going on, you're allowed to answer. So here goes the first question. In A scan for IOL power calculation, the A stands for attenuation, A constant, amplitude, or ascending signal. Okay, so as we can see, majority people have actually given the A, that is amplitude. What does B stand for in B scan? Excuse me. Brightness. That's right. Okay, good. Second question. The next question, please. So what is this addectomy called as? A, basal addectomy, B, Rado's addectomy, C, Undo's addectomy, and D, sectoral addectomy. Okay, I think majority people have given the right answer, which is Andos. Some people have said also basal. So endozyrectomy, as we know, has been described by Dr. Ando, as the name suggests. It is done for the silicone oil, basically in during retinal detachment surgery. That's basically because the silicone oil is going to float upwards, right? So third question, please. Organism that causes angular conjunctivitis is A. Moraxella axenfeld, B. Pneumococcus, C. Gonococci, and D. Adenovirus. What is it? Is it pneumococcus or gonococci? Okay, I think this was a very easy one. All right, great. So the next question, please. What is the type of finding which is the early sign of acanthamoeba keratitis? A. Radial perineuritis, B. Ring infiltrate, C. Hypopion, and D. Corneal neovascularization. What is the typical early stage finding of acanthamoeba keratitis? Okay, so I think majority people have said ring infiltrate, which is not actually the early stage sign. The radial perineuritis is the early stage sign. And why this occurs is basically because the trophozoites of the acanthamoeba have a tendency to sheath around the perineural sheaths, right? All right, the next question, please. Okay. Sands of Sahara is found in A. Interstitial keratitis, B. Nocardia keratitis, C. Diffuse lamellar keratitis, and D. Post-LASIK interface infection. Figure on. So as I've said, you have to be quick and correct. Both the things are equally important.
And of course, you should know it.
Yes. Okay, so I think majority people have actually given wrong answer. So I think all of you need to read more, right? So basically, this is the diffuse lamellar keratitis, which happens after LASIK in the interface, and this peaks at about third day after LASIK procedure. So if you,
it's not an infection.
it is inflammation, it is not an infection, right? So the DLK is the Cretan protocol is the form of A. Retinoblastoma treatment protocol, B. A collagen cross-linking protocol, C. Diabetic retinopathy laser protocol, and D. Vitamin A deficiency treatment protocol. So the Cretan protocol is what? All right, so I think majority of the people have given right answer. I'm very happy about it. So what is Cretan protocol? So the Cretan protocol is when you are combining the transepithelial PTK with collagen cross-linking. Is supposed to give better results than standard resident protocol. So that is named after Crete. So University of Crete. And Professor George Kimionis is the inventor of this technique. All right, next question, please. Which of the following is not a feature of Leber's congenital amaurosis? A. Pupillary reflexes are impaired. B. Anophthalmos. C. Autosomal dominant. And D. It is the most common retinal dystrophy in infants. So which of them is not a feature? Okay, read the question accurately. It is not a feature.
3 out of 4 are. That's what he's trying to say. One is not.
All right. So actually, it is very interesting to see that anophthalmos has been voted as the highest voted answer. It is very important. So when a child walks in with like a mother walks in with a very small baby, and you see that the child seems blind, and he is already doing what is called as the oculodigital sign, and there is enophthalmos, it is kind of a telltale sign that he may be having a Leber's congenital amaurosis, because he's trying to actually excite the retinal stimulus because he's completely blind. So actually enophthalmos is a very, very important sign of Leber's congenital amaurosis, and it is an autosomal recessive condition, not an autosomal dominant condition. All right. How many questions are over till now? 7. Yeah. Next question, please. What is this condition? You can see a fluorescein angiography being done here. What is this condition? A, it is a cystoid macular edema. B, it is a CSR. D, it is a diabetic macular edema. And 4 is, it is a PFT, which is parafoveal telangiectasia. So what is this condition? It has a very typical pattern on fluorescein angiography that you can see. I'm sure most of you should get it. Yes. So what is this pattern called as? And why is there the smokestack pattern? Yes, because when there is a protein leakage, the fluorescein dye is going to float over it. And that's why you get this convection currents causing smokestack. Okay, next question, please. Rhydidectomy is what? It is a surgery for DNS. It's a cosmetic facelift procedure. Surgery. What is rhydidectomy? So do you know what is rhytids? Have you heard of rhytid? Yeah, so I think facelift. And to tell you, rhytids, the meaning of rhytids means wrinkles. So rhydidectomy is a facelift procedure to get over the wrinkles. So basically that is why it is called as rhydidectomy. Very, very commonly used word in the aesthetic world. And I think I see those minority people who are given right answers, maybe oculoplasty surgeons. Good. So next question, please. So what is she testing? A, it is stereopsis. B, it is a dominant eye identification. C, it's a vertical deviation. And D, it's a diplopia, kind of diagnosing diplopia. So what is she trying to test? What is it? This is easy. Yes. Dominant eye identification, of course, used in to identify for monovision approaches in LASIK procedures and also for contact lenses as well. Next question, please. What is gerantoxon? A, it is an embryotoxon in the elderly. It is prominent scleral spur. It's a non-canalized Schlemm's canal, or it's arcus sinalis. What is gerantoxon? Again, a very simple one, straightforward. I think this everybody will get. Okay, majority of them have got it. And the second common answer seems to be embryotoxon in elderly. Okay, which is of course not the case. Okay, next question, please. The example of mixed astigmatism. So this is the very basic question. The example of mixed astigmatism, I'm not going to read it out. Please read it yourself and tell between A, B, C, D, what is the mixed astigmatism? What qualifies to be a mixed astigmatism? Tika, please. Yes, it's very straightforward because whenever the myopic cylindrical number is higher than the hyperopic spherical number is a mixed astigmatism. Next question, please. Name this gadget. Is it an Ahmed glaucoma valve? It's a Zen implant. Is it a glucose shunt or it's an express shunt? What is it? Tika, please. So at the end of the first 20 questions, we are going to analyze who is leading. Okay. All right. Very good. Express shunt. What material it is made of? Stainless steel. It's a steel material. Yes. Next question, please. What is this? I think this is something that all of us should definitely know. Is it a Malyugin ring? Is it a Okinawa ring? Is it a B hex ring, or it's a I ring expander? What is it? An amazing innovation done very recently about, and absolutely B hex ring is the right answer. It's innovated by none other than Dr. Subin Bhattacharjee from Calcutta. Very proud moment, because now, as the way Dr. Malyugin's name is taken in all international conferences, always Dr. Subin Bhattacharjee's name is always there. It's a proud moment for all of us Indian ophthalmologists. Next question, please. He is a pioneer of excimer laser research. A. Rangasamy Srinivasan, B. Manilal Bhaumik, C. Christopher Liu, or D. Harris Goldman. So read the question well. He is a pioneer of excimer lasers research. Pioneer of excimer lasers research. Okay, so I'm amazed by Christopher Liu. Actually, Christopher Liu is a very well-known professor in ophthalmology in UK, and he's one of the keratoprosthetic surgeons. This guy does look like Asian, but he's not. Okay, so he is a American physicist of Indian origin, and his name is Manilal Bhaumik. He was the person who had done the initial research on excimer lasers, but he's not the person who actually thought about applying excimer lasers on the human body. It was done by Rangasamy Srinivasan, and then Steve Trokel got it to cornea, and then the rest is history, as we know, right? Okay, next question, please. Trantas spots are noticed in cases of active trachoma, bulbar spring catarrh, corneal flectin, or vitamin A deficiency. Again, very, very straightforward question. This everybody should get. Dr. Bijlani sir had told me that some questions have to be very easy.
I thought everybody should answer at least one question.
In Tranta spot, anybody can tell quickly? Eosinophils. Yes. So next question, please.
How many done?
Please tell me once 20 questions are done. 16. Okay. Next question, please. Yes. So Copernicus, Galileo, Cruz. These are all studies. So these all studies have been done for which ocular condition? Is it optic neuritis? Is it done for diabetic retinopathy? Is it done for retinal vein occlusions or open angle glaucoma? Copernicus, Galileo, and Cruz studies. I can see Ketan is smiling there. So he definitely knows the answer. What is it? Yes, it's a retinal vein occlusion. The first two were done for Eylea. The last one was done for ranibizumab. Next question, please. Who is he? He's a German-American eye surgeon, one of the greatest inventors in ophthalmology. He established the first animal model for retinal detachment surgery. And a clue is that he belongs to my alma mater. Is he Robert McKemmer, Harry Flynn, Lawrence Januzzi, or Steve Charles? So who is he? I think one of the forefathers of retinal specialty, has done groundbreaking work. Yes, it's Robert McKemmer who performed the first pars plana vitrectomy at Bascom Palmer Eye Institute. Next question, please. Oil droplet, crystalline, and snowflake. these are the kind of cataracts that we see. These are characteristics of which diseases. So we have to see which one is oil droplet, crystalline, and snowflake. So A is diabetes, myotonic dystrophy, or galactosemia. B is myotonic dystrophy, galactosemia, and diabetes, or galactosemia, diabetes, myotonic dystrophy, or galactosemia, myotonic dystrophy, and diabetes. So you have to match oil droplet, crystalline, and snowflake cataract to these diseases. Very good. I think I must say that the audience is great. Absolutely. I think everybody is doing very well. So yes, galactosemia, myotonic dystrophy, and diabetes. So the oil droplet cataract, what does it have? What is the droplet? What is it chemically? Is there anything different? Why this is occurring? Okay, it is because of something called as galactitol that causes the oil droplet cataract. Okay, next question, please. So we are very close to the midway. We are going to know who is leading very soon. Are we done with 20? Yes, okay. So friends, we have done with the first 20 set of questions. We are in the midway before choosing the top 5 people to come for the final rounds. And I think so far people have done well. What do you think, Dr. Dillan?
It's been a very interesting and a mixed response. There have been interesting responses, an interesting audience, an interesting host over here. So all in all, it's been an interesting session so far. So let's continue this interest further.
So I think, yes. So now we are going to see, he's going to look it up, who is currently leading. So let us see what is the current position. So who are the people who are top 3? We are going to see that. And we are going to give them currently some chocolates. Who is student number 50? Okay. So Dr. Paranzabe, Dr. Mandar Paranzabe is currently leading. He gets a chocolate. Okay, and 49. This is, I think, unfair probably. This is, who is 49?
149.
Okay, 140. Sorry, 149. Okay. Sir, you're of 140. Also, one of the judges are actually, he is winning the second one currently. And student number 29. Okay. There is a match fixing, sir. What do you think?
Absolutely, absolutely. For the next 20 rounds, Mandar, you come right here. Sucharita, you go back.
This is the reason.
I mean, this is a husband-wife couple who obviously sukh dukh और questions भी बांट के खाते हैं. Lovely, lovely. Give them one more chocolate, please.
All right, great. So I think, so we take a break and Dr. Bijlani sir is going to take over now.
All right, so now you have 20 you have done and you have the remaining 20 in which to make up for those installments which you wanted to probably pay, but you couldn't get around to do it because of COVID or other reasons. And now it's a short entertainment sort of break. There are going to be questions related to ophthalmology, but not competitive of the sorts. Though, if you answer them correctly, you will get chocolates. Okay? Can you get this off, please? And put on my presentation. And where is that advance ka? वो कहाँ है भाई? Slide advance, sir. Do you have it? Or I'll tell you, you can go on doing it. Slide advancer है क्या? नहीं, manual नहीं है, अलग से नहीं है. Okay, then you do it, I'll tell you. Fine, you're fine. So you have the presentation. I'll tell you next, तब आप next करो. I've loaded it. It's quiz loaded किया है मैंने. I have loaded it that side. Of course. So just play that. Okay, so there are basically there are going to be 10 questions, and read the questions properly. There are some rules which are written down first for you to follow, and then try to follow them as much as possible. I'm not going to be very, very strict about it, but it'll be nice. How are you enjoying this quiz, which Vardhaman has put together? Something different, something more interactive, and then you realize how much you. यहाँ कौन बनने का 1000पति हो गया तो बहुत हो गया. But that's fine, sir. Okay. Yeah. demonstrate that. Start करो. All right. Vardhaman?
Yes, sir.
When I tell you next, you please do it.
All right. Yes.
All right. So this is welcome you all once again and quiz trivia. Let's have the rules, please. Next. All right. The rules. Read them. Please read the questions completely before attempting to answer. Raise your hand to answer. Would appreciate one delegate answering, not a samohik vyavhar जैसे कि सबने एक साथ मत answer दो. One at a time, please. And most important, the last. Hey, go back. Most important, the last one. The above rules can be broken. So we are here to have fun. Okay. All right. Now, please don't go forward unless I tell you who was the Wuhan ophthalmologist who first suspected and reported the viral infection that was different. He was the whistleblower. Ultimately, the poor sod got COVID and died of it. And the answers before you are: 1. Dr. Bruce Lee, Dr. Zali, Dr. Marley, and Dr. Lee Wenliang. Who said that first? Dr. Shashi, give her a chocolate, please. Oh, yeah, huh? Yeah, it is cheating. The rules are to be broken. All right, so it was Dr. Next one.
It is here only.
What the one? Next one, please.
Where it is.
Now, 1 minute. Which animal physically cannot look up into the sky? There is one animal which physically cannot look up in the sky. I want the answer from you. Yeah? Vichare said pig. Are you sure? Okay, that's the right answer. It's the pig. The pig cannot physically look up into the sky. What happened? Haan, to answer he gave. I said yes. Vardhaman, please don't go fast.
Yeah, but I think rest assured. This is for fun. This is not going to be calculated in
Hey,
your.
madam, koi
prize,
chocolate
so
please de
don't
do.
So they're taking it too seriously.
Yeah, enjoy, man. Third one. Vardhaman, take a finger away. Take a finger away. Third one on.
Okay.
Next. How long does the blink of an eye last? A blink of an eye. Palak. 1 upon? Anything else? 1? 1/10. Who said that? Dr. Jathar, please give him a chocolate, sir. 1/10 of a
Yes,
second.
that's the right answer.
The right answer is 1/10 of a palak.
Superb,
चपकते
sir.
ही सब बदल जाता है. Okay, next one. Yes. Which is the only animal that can see both infrared and ultraviolet light? We have this fixed 400 to 700. Which is the only animal which can see beyond and before both? Are you so much affected with COVID? Not the bat. Not the bat. Anyone? Karo, or bat, cat, rat. Anything else? We've got a full animal world
Cat,
ahead of
bat,
us.
and rat.
Eagle and beagle. No, none of you getting it. And the answer is the goldfish. It's the goldfish. Okay, that's the answer. So I don't think anyone got it. Next, please, fifth. What is? Huh? Kya? Ask them. What is dacryphilia? Anyone? What is dacryphilia? This is a little off-time quiz, like. Yes. False start. Anyone else? What is dacryphilia? Dacryphilia. Something to do with the eyes. That's an answer, right? Eyelashes. No. Anyone else? Vardhaman? Anyone? Give the answer, please. So, it is arousal from seeing tears in the eyes of a partner, which is very morbid but sad, but that's how it is. Arousal with seeing the tears. Next one. Bulls are colorblind. True or false? Bulls are colorblind. True or false? Someone said, how many of you say false? How many say true? How many say ki farak penda? The answer is true. So this red color and all doesn't make a difference. It's just the moment that attracts them. So if you're going to be bloody gold, you're going to be gold. You get a move out of it. All right? No chocolates for me only. 1 sec. Name the scientist whose eyes were removed during his autopsy and stored. Morbid na kya karte hain log? His eyes were removed during autopsy and stored. Do you know this scientist? Who said that? Anyone else? Yes? I heard her say Einstein. I didn't hear you say Einstein. She, that lady, give her the chocolate. Albert Einstein in 1955. तुमको बाद में देंगे यार.
So not only the eyes,
His
brain
eyes were
was
removed
also
and they
removed.
were put up for
Yeah.
auction in 1994. Now this who bought these eyes? In 1994 they were put up for auction. After the morbid guys there, but they were put up for auction. Who bought them? I don't know. So we'll find out the answer in the next quiz. I'll tell you. Next, please. Last three now. Why are owls not able to move their eye? Why do owls? They just turn like that. They cannot move their eye. Why? You've seen owls. उल्लू तो देखे हैं. यहाँ पे भी बहुत है. Why can't they move? You know, na? It can't move the eyes. All of you know it. Because because they can't move their eyes, they're moving the neck. The question is, why can't they move their eyes? No, give the answer, please. There is?
Yeah.
Hurry, they have to see. Because they can't do that, they've been adapted to move the neck around. Give the answer, please.
Eyeballs are tubular in shape.
The eyes are tubular in shape. The eyeball is tubular. Okay, it's not a ball as such. That's why they can't move their eyes. That's the answer.
What happened here?
क्या हो गया भाई?
Okay.
Okay. Now this is very interesting. What is the connection between Lewis Carroll's Alice in Wonderland, जब हम छोटे-छोटे थे, यानी बुजुर्गों के सिवाय, and ophthalmology? Alice in Wonderland, ophthalmology. What is the connection? Now, please, this is a good answer. So I want you to put up a hand and stand in your place and then try to answer. Yes? Better. Anyone else? Vichare? Yes, you're trying? Sorry? Yes? No, they would have been here with us today. Anyone else? Lewis Carroll, Alice in Wonderland, and ophthalmology. What is the connection between them? Anyone? Okay, give them the answer, please. Lewis Carroll had attacks of micropsia during migraine, which made him conceive the idea of Alice. Okay, and now the last and the final question. Who is considered the father of ophthalmology? Who is considered the father of ophthalmology? Sushruta is the father of Indian ophthalmology. Sushruta is considered the father of, who said no? The quiz master's decision is final. Too better. Who is considered, even I didn't know this, by the way, I just checked up and then realized that yes, who is considered father of, absolutely correct. Yes, the answer is George Bartisch. He is a German physician who wrote eye disease in the 16th century. He is considered father of ophthalmology. Okay, father of Indian, the Indian father of ophthalmology is Sushrut, and the father of quiz is. Thank you very much.
Thank you,
Back to
sir. It
Vardhaman.
was thoroughly entertaining. Can we have 1 second? Can I have access to my laptop for a second? Yeah. So friends, I think now we have gone through the first half. We already know who are the front runners, and I think it is a good idea to dissociate both of them, right? So I think next question is that diagnose this condition. Okay, I'm not going to read it out because I think it is a tongue twister. Okay, so but you can choose whatever is the best option that you can feel. All right. So ticker, please. Yes, I think everybody gets it right. Yes. Next question, please. Next question. So he was, where is this? He was to suppose, Yeah. No. Audio off, I guess. Audio is off. It is connected. It's connected. No, we had not muted it. One second. Yeah, it doesn't show the thing. It shows as muted from you, actually, not from me. No, it's not muted. ठीक है. Music लगाना है ना? नहीं आ रहा वापस. Next question, please. Can we have the next question? He is the king of crime, a legendary author, and an ophthalmologist who was a big failure as an ophthalmologist. He didn't get any patients. So he turned out to be an author. And that's a true story. So who is he? Sir Arthur Conan Doyle, Sidney Shelton, Arthur Hale, and Dan Brown. Tika, please. No, but chocolate. So Dr. SBK sir gets a chocolate for this answer. President sir, you can, yes. Yes, next question please. So this was a pretty straightforward thing. Name the sign. Is it Munson sign, Stark sign, Rizzuti sign, or Stalker's sign? What is this sign? What is it? Huh? Text. Yes, it is Rizzuti sign where you see on the nasal limbus in keratoconus, especially advanced keratoconus, that kind of reflex. Yes, next question, please. This is the slit lamp finding in a child with ascites and involuntary movements. What is the systemic diagnosis? Is it siderosis bulbi, beta thalassemia, Wilson's disease, or Indian childhood cirrhosis? Please. What is it? So, sir gets one more chocolate. SBK sir gets one more chocolate, and the answer is correct.
Please take the chocolate back from him. He's answering too many questions correctly. Sir, this is a competitive thing now.
So the answer is correct. The KF ring, Kayser-Fisher's ring, and the disease is the Wilson's disease. Yes. At what level of cornea is this deposition? Distant memory. Very good. Yes. Next question, please. Head tilt test to detect the paralysis of extra or cyclovertical muscles goes by the name of modified Krimsky, Hess, the Baumgarten, or the Belchowski. So what is the best answer? Now, this is again a straightforward question. The head tilt test. And the answer is absolutely vast majority have got it right. Next question, please. He is the father of LASIK. What else has he done? Okay, so I think he needs no introduction. He's Professor Palikaris. Invented eye tracing technologies, invented corneal inlays. He is the father of topography or father of femto, PK, penetrating keratoplasty. He is the father of LASIK. We all know that. What else has he done? He has done many innovations, path-breaking. But the answer that probably the least amount of people have given is eye tracing, which is the right answer actually. He is the father of eye tracing technologies. Eye tracing, many of us are using now here in our clinics. So the technology was invented by Professor Ioannis Palikaris. He has also invented AP LASIK procedure, has coined term as post LASIK ectasia, and of course invention of LASIK. Next question, please. A common complaint after FFA is discoloration of vision in the form of what kind of after image? They see what kind of after image. Is it yellow, green, blue, or red? If a patient undergoes FFA, he has an after image. What do you think the after image is in what color? Is it yellow, green, blue, or red? I think this is again something most of you should get, and none of you have got. So only SBK sir has got it again. So the answer is red. Next question, please. Topical anesthesia for cataract surgery. We all say that we are topical cataract surgeons, very, very advanced, very modern, right? But it has been around since 1884. Who was the surgeon who actually used topical anesthesia for cataract surgery in 1884? 1884. Von Graffe, Elschnick, Aruga, or Koller? 1884. More than a century ago, a topical cataract surgery has been attempted, successfully performed. Who is he? Yes, I think many people have got it right. It is Koller. And what anesthetic did he use? Did he use proparacaine? What did he use? He used a cocaine. Exactly. So he used cocaine as topical anesthetist. Okay, next question, please. What is PAC treatment? What do you mean by the PAC treatment? It is one of the latest advancements. Is it an Ologen implant for glaucoma? Is it an intravitreal injection for uveitis? Is it a combination of is it a combination of IV and oral interferon for uveitis? Or it's a cross-linking done for infective keratitis? What is the PAC treatment? Something which is making a lot of buzz recently. What is the PAC treatment? Yes, so I think most of you have got it. Cross-linking infective keratitis. Anybody knows what is the full form of PAC? Does it come in packs? That's why it is called as PAC. Or what is PAC? It is a photo-activated chromophore for keratitis. It's a term coined by Professor Hafezi from Switzerland. Okay, next question, please. The Miate grading system is used for grading what? Cataracts, retinoblastoma, ROP, or intraocular lens glistenings? What is the Miata grading system used for? Again, making a lot of buzz recently. Yes, Dr. Bijlani, sir, right? Yeah. That's absolutely correct. It is the glistening that he has graded. Yes. Next question, please. This American ophthalmologist invented cryo in 60s, played saxophone, and died of lung cancer. Who is he? Is he a Moyles, Charles Kellman, Charles Stephens, or Steve Charles? I think it has to be one of the Charles, right? There are too many Charles in the options. So who is he? What is it? Prince Charles. Still, they didn't get it. So this was a question which had already put up on our WhatsApp group. I think most of you are not looking at WhatsApp, which is a good sign. So, but that was in different regard. So if I had put up who is the inventor of phaco, of course you would have got it. The answer is Charles Kellman, the inventor of phaco, and not Charles Stephens. All right, next question, please. Which is the first full-fledged online virtual ophthalmic conference in India? Is it DOS 2020, MOSCON 2020, UPSOS, which is the Uttar Pradesh Conference 2020, or AIOC 2020? Which is the full-fledged online virtual ophthalmic conference ever happened in India? And it is MOSCON 2020, and it is, I think, proud moment for all of us in Maharashtra. And POS 2021 is the first hybrid conference of Maharashtra. So I think, again, a big round of applause to all POS office bearers. Yes. Great. In fact, this POSCON 2020 has been an invited article by Indian Journal of Ophthalmology as the first ever virtual conference in India officially. Okay, next question, please. Thank you. The blood ocular barrier includes tight junctions between capillary endothelial cells in retina and iris, non-pigmented ciliary epithelial cells, retinal pigment epithelial cells, or all of the above. The blood ocular barrier includes tight junctions between what? Ticker, is it on? Yes, I think majority of you have got it. It is pretty straightforward. Next question, please. Which of the following is a photoactivated substance that can lower intraocular pressure? So what would you like to have? All the glaucoma patients of us, what would you advise them? Is it LSD, amphetamines, heroin, or marijuana? So which drug is going to lower the intraocular pressure?
Aren't you scared of the Narcotics Control Board?
Not anymore, sir. Again, something which is creating a lot of buzz, especially in the US. I think majority of you have got it right, and this is probably not good. Do you know that American Academy of Ophthalmology had to put up an official statement saying that you cannot use it as a treatment, because this was published wide all over the world in newspapers and news news channels. So people actually thought that this might be one of the channels, but American AAO actually came up with the official thing that you should not use it in any way. Okay, next question, please. Which of the following is choroidal rupture? Very classical photograph. Is it A, B, C, D? What is it? Choroidal rupture. Which of the following is the choroidal rupture? So the answer is correct, which is B. I think, has anybody given right answers? Yes, B, yes, that's true. Correct. Next question, please. Dystichiasis is what? Misdirected eyelashes, accessory row of eyelashes, downward drooping of upper lid, upward protrusion of lower lid. What is dystichiasis? This is very straightforward, right, sir? Yeah. That's right, accessory rows of eyelashes. Next question, please. So identify the line which is pointed by the arrow. Is it Stokes line, Sampolesi's line, Shee's line, or Art's line? I'm sure many of you must have seen it while doing gonioscopy. What is it? Only 5 more to go, so I think you have to really look at it. That's correct. Sampolesi's line seen in which condition? No. Yes, it's seen in pecs. That's right. Next question, please. Father of cross-linking. What else has he done? He performed the first epiLASIK, performed the first PRK, performed the first DAL for keratoconus, or performed the first INTAX for keratoconus. Father of cross-linking. What else has he done? Ticker, please. We all know him very well. He is Professor Theo Zeiler from Switzerland, the person who made the cross-linking possible for so many patients around the world. But he is one of the greatest inventors and has performed the first PRK in the world. So he's the person who actually was one of the first people to apply excimer laser on the eye and then to perform the first PRK in the world, not the INTAX. Okay. Yes. Next question, please. Identify the suturing technique. I'll give you a clue. Is it Federer suture, Palikares suture, Lasso suture? or the Marshall suture? What is the suturing technique? I'll show you. The radial things that you see is the RK mark, and the suturing that you see is all going around it. So what kind of suture is this? Federo, Alcaris, Lasso, or Marshall? This is the Lasso suture, not a Alcaris suture. All right. So next question, please. It is done for progressive hyperopia treatments. So to basically kind of compress the gaping of this one. The Duas layer is where? Is it between epithelium and Bowman's layer? Between endothelium and the Descemet's layer? It is important in big bubble technique, or it is present in the midstroma. What is Duas layer? Which is the correct statement? So I think all of you should get it. Professor Dua has been in Pune for so many times. Only 2 questions to go. And then we call upon the best 5 final round. And actually it is important in big bubble technique. It is not between the endothelium and descent. It is actually pre-descetic layer. Yes. So next question. Second last. I think probably this is the last. Mizio-Nakamura phenomenon is seen in what? Is it Oguchi's disease, Stargardt's disease, gyrate atrophy, or retinitis pigmentosa? Mizio-Nakamura phenomenon. I'll give you a clue. The first 2 photographs are light adapted. The second 2 photographs are dark adapted. Fundus of the same patient. It is Oguchi's disease, very true. The dark adaptation, I mean, you see fundus as normal in dark adapted eye, which takes 3 to 9 hours for this picture to arrive. And usually the light adapted eyes, because of very, very high sensitivity of rods, have this kind of appearance. All right, great. I think so. Have we come at the end of 40 questions? All done, all done, all done. So we come at the end of our semi-final, and now we are going to announce who is going to be the top 9 and then call upon the top 5. Here to sir.
Vardhaman, if there is a husband-wife pair who also are in the first 5, do we take them in? I'm not referring to you.
I think the question goes to the judges. I think the judges have to take the call.
All right, let's have the top 5, please. And come forward with your 149, 50, 14, 14, 25, 141. I want these 5 people to come up, please. Give them a big hand. Who's the 5th one? Come on, come up, come up, come up, come up. Aa jao. Sharma mat. Come up, please. Okay, now we have these 5 Maharathis. Come here. Who are going to be fighting for the final thing. I want them to introduce themselves. I'll just get out of the way.
Yeah, I'm Dr. OK Radhaksh, 149. I'm Dr. Mandar Paranspe from Pune.
Dr. Mukesh Paryani, Pune, 14.
Dr. Pratik Surushe, I'm a resident doctor in Navle Hospital.
Hi, I'm Dr. Fatima Siddiqui, a fellow in pediatric ophthalmology under Dr. Nikhil Rishikesh.
Lovely, lovely. So we have these 5 people who are going to make it to the finals. I request 2 of you to sit here and 3 of you to sit there. Okay, you can go and sit there, please. Where is the buzzer?
Buzzer there now.
All right, now these questions are going to be asking 10 questions, and this is the fastest finger first. So we don't have that, light dekho kisne bajaya. Once someone presses it, the other 4 are locked. So only the first one, and you have to answer immediately. Once you answer, you're committed. If you pause for a longer period and start thinking, you're going to be disqualified. Vardhaman, are we giving them negative marks or only positive marks?
So we are going to have a quick round of 10 questions. No MCQs this time. So they have to give direct answers. There are going to be buzzers. So you don't need the keypads anymore. They are going to give you the buzzers. They are special buzzers. So these buzzers have a kind of blockout kind of technology in which if one person is pressing the buzzer, all the other buzzers are going to get switched off. So this is the first come, first serve
and fastest finger first kind of situation. And you have only 10 questions. If you give wrong answers, it is -5. If you're going to give right answer, it is going to be +10. And I'm going to ask Siddhi to calculate for everybody. All right.
Yeah, you're right. And if they give a wrong answer, we give them a -1 point. If they give a right answer, the +1 point. Because what will happen if someone answers 3 and then doesn't matter. Okay, you understand? No. If you give a wrong, once you press it, you have to answer it. If you answer it wrong, you get a -1. If you answer it correct, you get a +1, obviously. So
okay, so it is equal amount of plus and minus negative markings then. Yes. All right, no problem. So we are going to.
And audience, please don't blurt out the answers. This is strictly for these people.
So this is the final round. And here it goes.
There.
1 second. So he will just activate the buzzers before we go ahead. Okay. Is this working? Working? Working well? Everything is okay?
Just 1 sec.
1 second. I think he's just
go
connecting
trial
it.
karo because
Yeah,
they should not throw these things at us afterwards. They should not throw these things at us afterwards. Please try them once.
Yeah, I think he's going to just
He's going to do it at the
He's going to
console
just
over
try it
there.
out.
It's all going to go off. You want these lights off preferably so we can see which one is done.
Yeah. So can we
switch
get
off
this
these top
lighting
lights?
come down, please? Can you reduce the lighting?
No, you can see over here. You don't have a CLO, right?
Can anybody please help us
all of you, please press the center.
to tone out the lights a bit? Yes, thank you.
Press the center one.
So this is a very exciting final round, and we have actually very competitive environment. We have somebody who has in practice for a long time. We have somebody who is in practice for last 5-6 years, and we have also a fellow and a PG.
No. We want you here. Huh? No, we need you here. We need you here. Sir, please.
So it is a interesting mix that we have. Yeah. So as soon as we are
Vardhaman, it's
ready
not
with the
an
buzzers,
interesting. They're all young people, all teenagers, in the knowledge at least.
So he's just checking the buzzer system. Just give him a minute. Yeah. So I hope that all of you are enjoying the quiz so far. Anything new that you have learned today? Yeah. Good. So
1 sec.
are we ready? Are the buzzers turning green, all of them?
नहीं हो रहा है.
Yes. I think we should take their photograph with the green buzzer.
This one is not working.
This one.
This is not green. Oh, now it's green.
Is
now
it
it's
green? Okay, it's green now. Okay, everybody just try. Okay.
Yeah, the others will get deactivated. Only his is working. All green now.
Wonderful.
All, put up your green. Let the audience see that all are green. Make them green, please.
Yes.
No. Abhi press mat. Okay, you want to check it out. Okay, now you do it. Wait. Let it come green.
Okay. Are we?
Yeah. Okay.
Are we ready? Are we set? Huh? Yes. Superb. Very good. Very good.
Make them green, all please. All are green. Ready
So
to go.
everybody is ready. Do not press the buzzer unless you know the answer, because there is negative marking, and sir has already
what is the
increased your
scoring?
negative points. So bacteria which can attack normal corneal epithelium. Okay,
Doctor-
sir. Yes, sir. Doctor, okay, sir. Huh? Excuse me. So look at the picture, sir.
His answer was Corynebacterium, right?
Yeah, which is unfortunately, yeah. So yeah, so it is a gonococca. I mean, it is a Neisseria gonorrhea, right? So basically, I think sir will get probably negative points for this.
-1 for participant number 2. 1, 2, 3, 4, 5.
So next question is, fundus autofluorescence is generated from which layer of retina? Okay, Dr. Mandar sir. RP, that's the right answer. Dr. Mandar sir gets +1.
+1 for
In Dresden protocol for collagen crossing, Dresden refers to? It refers to what? It refers to, what is Dresden? What is Dresden? All right, so we can give it to Mukesh. It is a city in Germany where all the primary laboratory work was done. It is Dresden in Germany. So that's why it is called as the Dresden protocol. So
one sec.
he gets one more point.
1 sec. It's not turning green.
Okay, can you just please check? उनका
not
green नहीं हो
but
रहा.
it's working. No, it ticked. You have another one?
Just change it if it is possible.
Is
So
that
I
working?
think we have 3 answers so far given by 3 different people. Is going neck to neck. All right. So Dresden is the place in Germany. It's a city and a capital of the Eastern
All right, now
German
green.
province in the past. That is where all the research for crossing has been done. Is it okay now?
Yeah, now it's
Yes,
good. Go
good.
on.
So the next question is identify this famous politician who is the ophthalmologist. Dr. Mandar sir? Yes. And what is he? I mean, he's a politician, but at what level? Yes. So he has been president of Syria for last 21 years. He is an eye doctor. His father was the president of Syria before him for the last 30 years before him. So for last 50 years, father and sir have been the presidents of Syria. All
Anwar
right.
Sadat was his father.
Yes. So identify this procedure. All
got
right.
it?
So Mukesh, what is it? No, it's a wrong answer. You get -1. It is a circle software done after the smile procedure. So
Half a point to him.
half a point. Okay. Chalo, half point to Dr. Mukesh.
Thoda match
All right.
fixing.
So circle software is a specialized software which is used to convert a smile into a flap. So if you have any issues, then you can convert the smile into a flap and then treat it. So, okay. Identify this iris condition.
Yes,
please.
Mukesh.
Melia. No, that's a wrong
No,
answer.
No, it's the wrong.
So
It doesn't go on to
although
anyone else.
nobody else gets a point, but anybody else knows?
You can try, but no points for it.
Yeah.
You can,
Kogan's iris nodules.
Excuse me?
he says Kogan's.
Kogan's. So these are leash nodules
Leash
seen
nodules.
in NF1 neurofibromatosis. All right. These are the leash nodules, very classical picture and one of the most popular quiz slides.
He loses
Okay.
one
What is
point.
the full form of APM-PPE? Yes, Dr. Mandar sir. Interesting.
Speak into the mic if you have one there.
Yes.
It's multifocal pigmentary epitheliopathy, but I'm not very.
Okay, he's partly correct.
Partly correct.
Partly
Yeah,
correct.
partly
So,
correct.
1/4 देना है कि half देना है?
So judges se पूछना
Judges.
पड़ेगा actually. So what to do, judges?
Prabha, what do you think? Half?
Half point. Okay, half point to Dr. Mandar sir. It is APM-PPE, which is again acute posterior multifocal placoid pigmentary epitheliopathy. That's right. Okay, identify this ophthalmologist who is currently the cabinet minister of a country and he has been very popular in the current times, frankly. I think you should be able to get him. And I can also tell you that he is of Indian origin and very, very prominent figure in international political circle. Yes, Dr. Mandar sir?
I don't know his name, but he's from Singapore.
Okay. Yes, that's right.
South Indian.
No. You have to tell the name. You will not get a point. Though your answer is correct,
Okay.
but you won't get a point for it.
Although no points, but he is right. So he is from Singapore. His name is Dr. Vivian Balakrishnan. He has been having various different, let us say, portfolios as minister and is extremely well represented in international political circles. So this question is which actor?
Okay. Bardhavan, nothing there. No display.
Okay. Can you please get the display on, please? We have last 2 questions to go, so I think all of you should.
What is the scores like? Till they set it up. What are the scores like?
Siddhi, what is the score? Huh?
Who? Mandar is
2.5.
2.5.
Dr. Mandar has 2.5. Yes. B has -1. C has 0.5. And D and E have not opened their scoreboard yet. Okay.
Just
So
a
D and
difference
E,
of two.
Vakab,
Answer
B,
the right,
D and
right
E.
two,
Chalo.
and you can get it.
Very, very good. Now the next question is which actor in Bahubali is one-eyed in real life?
Okay.
Yes. Rana Dugubati. Very true. So he gets 1 point. D gets 1 point. And what exactly has he undergone? Any surgery? He has undergone a corneal transplant at LVPEI. Yes. And he's one-eyed. So in the eye that he sees, he has undergone the transplant. That's his only seeing eye. All right. So this is the last question. Identify this condition seen after 1 week of LASIK procedure. Look at this OCT images. This is seen 1 week after the LASIK procedure. Identify. Yes, Mukesh? Yes. So it is the interface fluid syndrome because of the PISC. That is absolutely correct. So here we come at the end of our final round, and we will look at the final scorecards, please. Siddhi,
No, tell the scores.
scores, please. So Dr. Mandasar with A, he has won this quiz. Big hand to him. Who is at second position? So Mukesh is in second position with 1.5 marks. And D, what's your name again? Pratik. Hi, Pratik. So Pratik, our friend who is a resident, is at third position, or all of three of them are winning the POS quiz. So to tell you the first 9 people, okay, can you flash the first 9 people's just names here? We will call them later on to give them the prizes. The first 9 people get the cash voucher from Microlabs. The first winner is going to get a special trophy from POS along with a certificate and cash voucher. The second one is going to be Mukesh, is going to get the certificate, pen drive and a cash voucher. And third one is going to get again certificate, cash voucher as well. So thank you again. Thank you everybody for being here and being part of this exciting quiz. So we are very, very thankful to Microlabs. They have done a lot of hard work in organizing this quiz, organizing this high-tech keypad system. So thank you so much. Thank you. Please return the keypads after this session. There is one more session to go. After this session is over, you have to return the keypads to the volunteer outside. All right. So, and me and Dr. Bijlani sir, we again hope that you have enjoyed the quiz.
Dr. Nikhil.
Hello, everyone. So after this excellent quiz session, let us start with this very interesting session on refractive surgeries and phaco. So the first talk will be by Dr. Vardhaman Kankriya, and he'll be talking about his preferred approach for laser vision correction.
Hello, hi Vasily. Have you joined on Zoom? Yes, you are there, no? Okay, so then we can start with you only.
Welcome, Dr. Udayan Dikshit, sir, since you're joining us online.
Yeah, I was seeing the quiz, yes. Okay.
Slight change in plan. Since Dr. Vasilios Diakonis is online, welcome, Dr. Vasilios.
Thank you for having me.
And he'll start his talk on refractive surgery in keratoconus. Please go ahead, Dr. Vasilios. Would
Thank
Dr.
you.
Vardhaman want to introduce him first?
Yeah. So, hello, friends. Friends, can we have your attention, please? Right. So we are starting with a new session on keratorefractive surgery, and we have one of my very good and very close friends, Dr. Vasilios Gekonis. He is from Greece. He has been trained with Professor Palikaris. He has done his PhD in mitomycin C in surface ablation. He has done fundamental and landmark work on cross-linking, especially the confocal microscopy in cross-linking, has done his cornea and refractive fellowship at Bascom Palmyra Institute, and is currently also the visiting professor at the Bascom Palmyra Institute. He's going to talk to us about the refractive surgery in keratoconus. Over to you, Vasilios.
Hi, Vardy. It's nice to see you, even though I'm not there.
Yeah.
I chose the background to remind you of our time in South Beach in Miami with the palm trees. Thank you for having me. I've been to Pune in the past with Dr. Kankaria, and we're going to talk a little bit about cross-linking and refractive approaches. So let me see here, share. Okay, so we're good. I have no financial interests on this. Cross-linking, as in your previous quiz was introduced in Dresden about, I think now 20 years ago by Dr. Zeiler after a visit to his dentist. And the initial idea was that there is some kind of stiffening effect due to the fibrils created between the collagen fibers. Has anybody seen them? The answer is no. We tried in the US to create some kind of an image with Vardaman, but we couldn't do that. So has the theory been proven? Yes, I can say it has been clinically. And also, we also did a study there with an atomic force microscopy that we checked elasticity of the cornea by micro or nano indentation. And the anterior stroma gets significantly more or less elastic, more stiff. So we trust our data, clinical. The problem with most of the studies, the clinical studies, is that is the keratoconus actually progressing or not? So if it's not progressing and you do cross-linking, then yes, you have excellent results. And the goal is to create a stiffer cornea. The actual problem with this is it's a joke. It was given to refractive surgeons. So refractive surgeons are very used to creating humans that do not need spectacles or contact lenses. But you have to remember that the people that we usually treat for that have normal corneas. Now we have diseased corneas. And a few years ago, if you would say to an average ophthalmologist that you would actually do some kind of a refractive procedure with an excimer on a cornea that has keratoconus, they would probably crucify you, and they would actually be correct. So the aim, everybody knows, is stabilize the condition and then have our patients see the best they can see. And many people started exploring that era. At the beginning, of course, nobody wanted to do excimer laser because it was something that was forbidden. So people started using old tricks that they had, we had and we knew, like conductive keratoplasty. That thing didn't work because, again, we had regression of the result as we had in normal corneas. Other people used intracorneal inlays to reshape the cornea and provide a better refractive result. Again, this was not very good because we have non-predictable results. And then we started using intraocular procedures like the ICLs to reduce the myopia and the astigmatism. But because we have irregular astigmatism, the actual refractive results were not very good. So then we started experimenting with sequential treatments with PRK. And we did cross-linking, we let the cornea stabilize, and then we excised tissue. That was not very smart, I would say, because the anterior 1/3 of the corneal stroma has been cross-linked, and then when you start removing that afterwards, you weaken the cornea. Then another idea was to do simultaneous PRK with cross-linking. But the problem with the topo-guided approaches is that you actually have to remove a lot of stroma, a lot of tissue, which is not very smart when you're talking about thin corneas that have keratoconus. And that also is not probably the best idea, especially for progressed KCN. And then, as Vardaman mentioned before, we had an approach which took advantage of nature. We did a PTK and then cross-linked the cornea. And I will say why this was a smart approach. If you consider this to be a schematic of the cornea, and this is the epithelium, and this is the stroma that's apexing here, nature has already thought about that, and the epithelium on top of the apex of the cornea is thinner in order to mask this irregularity, making probably a more physiological cornea, so we have a better means of an optical medium. So if you do a PTK on this cornea, what will happen is that you will remove in the areas where you don't have the cone a lot of epithelium, but over the apex of the cone, you will shave off probably 10, 20, or 30 microns, and then you will end up having a more regularized cornea. So taking advantage of nature, you're creating an approach that probably offers a more regularized cornea. And this is now easier to do and think about even before surgery, because we do have imaging like OCT that gives us an epithelial mapping, and we can probably offer this surgery and plan this surgery more accurately of how much PTK you want to do. So there was a study in Crete, and then the Cretan protocol derived, where we compared an approach where we remove the epithelium the normal way, and then we remove the epithelium with PPK. And we followed up the patients. What we saw was a statistically significant improvement in the uncorrected distance visual acuity and the corrected distance visual acuity when you compare this to the manual debridement of cross-linking, where there was an improvement because always there's some kind of a stiffening effect that flattens the cornea, but this did not reach statistical significance. Also, there was more percentage of patients that gained a line of CDVA. This is spectacle corrected, of course, not with contact lenses. When you compare it to less percentage of patients that gain one line of CDVA with a mechanical debridement. Also, the astigmatism was improved, as you see, from a -5.84. We went to a -4.31. This was statistically significant when you compare it to the mechanical, which there was no statistical significance. For both surgeries or approaches, there was no endothelial cell density alterations. So with this trick, taking advantage of the masking of the epithelium, you could say that you can produce better refractive and visual results for patients. You have to remember that this is not a normal cornea. This is a sick cornea. So you try to remove the least possible stromal tissue. And if you, in your practice, can do cross-linking and you have an excimer laser that you can do a PTK, this could be an option for you for up to a level of like medium KCN cases. Vardaman, it's always a pleasure to see you, and I hope that soon we will get together again. Hopefully, and I have promised that I will come to India and visit you in Pune in your new clinic. It's not new anymore, but hopefully I will come and visit you. This is a picture of a conference in Crete, a lot of old friends, and it's always nice to see you, buddy. Thank you.
Thank you so much, Vasilios. I think this was amazing, and I know all the hard work that you have done to, to have all these studies going on, and it is always a pleasure to partner with you in research as well as our clinical fellowships and the times afterwards. And congratulations for all the success that you have in Athens and also in the US. All right. Thank you again for actually waking up early for us, and sorry for the delay that is there because of the schedule. Thank you again. Enjoy your Sunday. Thank you.
Bye-bye. Thank you.
Thank you. Thank you, Vasilius. Thank you. Bye.
Yeah. So Dr. Vardhaman Kankriya will continue with his talk on his preferred approach for laser vision correction.
Thank you very much. So friends, I'm going to talk to you about my preferred procedure for refractive surgery as such, which is the Relax Smile surgery, which I've been fortunate to be doing for the last now 6 years. This surgery has definitely added a lot of advantages to the already rich portfolio of options that are there. We all know that the first LASIK was done by Professor Ioannis Palikaris. It was done in early 1990s, and this is the first ever video of the LASIK surgery done on a Greek female. You can see it seems very, very crude. Of course, this is the first ever historic video of the first ever LASIK done in the world. But this surgery completely revolutionized laser refractive surgery because of in situ stromal ablation and very, very quick recovery. But the issue with this procedure was that it required creation of the flap. And in those times, the flaps were created with mechanical microkeradomes. Although the mechanical microkeradomes improved over time, but the femtosecond lasers definitely brought in many other advantages, including much better precision, much better smoothness of the flaps, much better customization in the flaps, and lesser contribution of the pre-operative keratometry on the post-operative outcomes. So the femtosecond lasers added so many advantages, but still the flaps remained. Because the flaps did remain, there were still micro and macro striae, there were still flap dislocations which were possible, and epithelial ingrowth which was evident in those patients. So as Thomas Edison says, there is always a better way to do it, and we have to find it. The use of Visumax laser as the Relax Smile tool has been revolutionary in refractive surgery lately. As you can see, this is the Visumax, which is a 500 hertz laser. This works on the principle of femtosecond laser. That means it works on the principle of photo disruption. When there is a photo disruption done, you will see there are ultra short infrared laser pulses which are precisely focused into the intracorneal tissue, where you can actually create a cut of any shape and size the way you would like to have. You can completely customize it. When you place all these pulses and the bubbles next to each other, you can create a pattern of your choice. So the first thing that was designated to be done was how to get rid of the excimer laser itself, because the excimer laser can also have its own issues in high or low humidity in terms of temperature regulation, and especially induction of a lot of aberrations in very high intensity ablations. So first thing was to creation of the flap with the femtosecond laser, which was immediately followed in this case by creation of a lenticule. So this was the first case which was done with what is called as a flex. Flex is femtosecond lenticular extraction procedure. So this required still a flap, but now there was no excimer used. So there was this peeling of the lenticule that you can see, and the flap was put back. This was the precursor of what is the current generation of SMILE procedure. What is SMILE? SMILE is basically an acronym of small incision lenticular extraction. So in this case, the same lenticule that we have seen in flex is created and then extracted, not after a flap creation, but after creation of a small lenticule with the femtosecond laser. You can see in the animation on the left side, and also one of the live surgeries that I've done in the center, that these are the pulses which are being fired. So, and at the end, there will be a small incision which will be created, through which we will remove the lenticule which is formed. Now you will see here that this is the primary cut which is done in the center. This cut is the posterior cut. It is done with the help of the femtosecond laser, as we discussed. In femtosecond laser, always the first is posterior and the second cut is anterior. Then there was a side cut of the lenticule, and now this is the anterior cut which is being formed to the cap. This is the cap formation, and at the end you're going to have a 2 millimeter incision. Once this 2 millimeter incision is created, then you have to go in and make sure that you very nicely dissect the lenticule very, very gently. This is called as the escape bubble sign, in which once you enter, you will see that all the bubbles are vanishing. That means your dissection is going to be very, very straightforward. Typically, this gives rise to very, very good wow effect on the first day itself. This is the specialized spatula that you have to use when you have to dissect the lenticule. Here we are going just above the lenticule here, and this has to be done in gentle fashion. And then once the dissection is done on the cap, we have to go under the lenticule and then dissect it out. You have to go all the way to the other side, and then very gently in sweeping motions, you have to make sure that you are very gently separating the lenticle without leaving behind any tags. So once this is done, you can see this can be done within less than a minute, or actually about 30 or 40 seconds. Then you go inside, and with the help of a forceps, you just remove this lenticle, and then the procedure is done. The advantage of this surgery, of course, is having completely flapless outcomes. Dan Reinstein has published a lot of work on this from UK, and he has shown that in terms of the refractive outcomes with SMILE, it has to be quite predictable, safe, efficacious, and also in terms of the first postoperative day vision has been at par with the femtosecond LASIK procedures. But SMILE does bring out several other advantages over femtosecond LASIK. Number one is that there is no flap to get displaced, no microstriae to form, and of course the chance of epithelial growth is very, very minute. Currently, there are only 3 or 4 cases around the world which have demonstrated epithelial growth after SMILE, as against thousands of cases which have, or even more, after LASIK procedure. This is also seen that the centration of the treatment is much better with SMILE because your centration is on the visual axis. So you have to ask the patient to look at the central target, and that is how the centration is achieved. As against in LASIK, you know that the centration is usually on the pupillary center of the moving eye, which is tracked by the pupillary tracker. This has been also shown by various publications. So this you can see the publication which has shown that the SMILE actually achieved much more central ablation as compared to the femtosecond LASIK. Not only the centration, but also the extent of the treatment is much better in SMILE. You can see the real or the effective optical zone that you get in SMILE is much bigger than in LASIK. And of course, the amoeboid appearance of the peripheral pulses, which happens in LASIK, doesn't happen with SMILE, so gives rise to much, much better extent of the treatment. It has also shown to induce less amount of spherical aberrations because of the same reason, because you have a much, much larger optical zone. And this has been shown by a variety of publications. But one of the most important advantages in current times is, of course, that it induces less amount of dry eye. In SMILE, you can go well below the subepithelial nerve plexus to remove your lenticule, so preserve most of the subepithelial nerve fibers. As against in LASIK, you are creating a flap and you are actually denuding not only the subepithelial nerve plexus, but you are also going to ablate even more. So that leads to more amount of corneal neuropathy. This has been shown by a variety of studies. This is a one landmark study which is published by again Dan Reinstein. You can see after LASIK, the corneal sensations, they drop to almost 10% immediately, and takes almost a year to go to about 50%. But as against in SMILE, the corneal sensations have dropped by Cauchy-Bonnet spatiometry to only 40-50%, and it improves much more faster. That's why these patients are definitely much, much more comfortable. Not only the corneal neuropathy, but also the objective as well as the subjective dry eye parameters are much better in SMILE as against the femtosecond LASIK procedure, which has been now well proven and published by a variety of studies. One of the best studies have been by Wilmer, which is by Dernier et al. And theoretically, the SMILE is supposed to give rise to much better corneal biomechanical maintenance of biomechanical strength, but this is very controversial, and possibly this is something that we don't buy into yet. And the hypothesis here is that we are going to actually have much stronger fibers anteriorly, which we try to preserve. But I think whatever has been seen in the world so far in terms of literature, the results are equivocal. So currently, I think your selection criteria for SMILE and LASIK has to be the same. Do not consider SMILE to maintain more corneal biomechanical strength as against the LASIK procedure. The other benefits are no stromal exposure, no need of interface irrigation, so possibly less amount of DLK, much faster single-step procedure. And this lenticule that you're removing, you can use the same lenticule as a fili for hyperopia or also for keratoconus. Of course, currently the hyperopic treatments are not possible with this, but what we have seen so far is SMILE is a great marriage of all the advantages that we have seen in surface ablation, such as no flap, better stability, and of LASIK, such as fast recovery, no pain, and no haze. And this has given rise to a great monumental improvement in terms of the procedures, right from the arcade days till today's day of smooth butterfly, which is RELAX SMILE. Thank you very much for your kind attention. Thank you. Thank you.
Dr. Vardhaman, thank you for a lovely talk. It was very, very illustrative. May I invite Dr. Parikshit Gokte sir for his talk on control of astigmatism in SICS.
Pankaj, yours was a really professional talk, and many of us must have learned many new techniques from you. Thank you so much.
Well, after such a high-tech talk by Dr. Vardhaman, it is a bit intimidating to speak on something which is very simple. No, it's equally important. So I'll be speaking on the management of astigmatism by manual small incision cataract surgery. अच्छा, तिकडनं नाही चालेल का? Good afternoon. At the outset, thank you to Dr. Tekavde, Dr. Rojita, Dr. Sanjay, Dr. Bijlani for giving me this opportunity, and that too having an SICS talk at a relatively prime time. We always think of astigmatism as something that is bad or something that needs to be managed or taken care of, and it's like the byproduct of surgery, which is not always good. Thank you. So managing astigmatism in manual small incision cataract surgery. So it's always good to speak in front of the home crowd. Well, we all know phaco is today the king of the cataract surgery. And of course, there is FLACS that has come up, but still phaco is the one that rules the roost. But manual SICS still is a royal and a great surgery in its own right. About 8-9 years ago, we had done a meta-analysis comparing results of manual small incision cataract surgery and phaco, and we had compared them across 11 parameters. There was a difference in only 2 parameters. One is, of course, if you look at unaided vision at 6/9, where phaco definitely gives better results because it's a smaller incision. So for driving standard without specs, phaco is definitely better. And when we look at astigmatism, all these studies had shown that the astigmatism in phaco is much lesser than the astigmatism in SICS. Because of course, a 2.8 millimeter incision and a 5.5 or a 6.5 millimeter incision. But if we look at near vision, we found that 81% of SICS patients had unaided near vision better than 6 and 18 as compared to just 19% in the phaco group. So all of us do phaco, and the next day we see the patient is able to read the 6/6 line. We are very happy, but then patients sometimes complain, oh, I could see my mobile earlier, or I could read the newspaper earlier, and now I am not able to do that. And we tell them, oh, wow, we have done fantastic surgery, you're 6/6 unaided. So phaco definitely gives, with a monofocal lens, good distance vision, but poorer near vision, because it gives lesser astigmatism. And unaided near vision is important not just for people like us who read and write, but even for illiterate communities, rural people, for needlework, cooking, cleaning, answering mobile phones, differentiating currency. So while astigmatism is an issue differentiating the two techniques, it does not seem to have a great impact on functional vision because everybody does not drive a car or ride a mobile. So this was the famous ad of Surf Excel, kuch daag achhe hote hain. So similarly, astigmatism is something like that. It is not a blot. Astigmatism is something that we can manage and something that we can use. Because scleral tunnels are very, very kind and forgiving. They are secure, they heal well. It's an economical surgery. And as in the audience, we have so many people who play on the cornea and play with the cornea. I'm sure they'll all agree that it is a tissue that is less forgiving, and it is a tissue that can give rise to a lot of problems if not handled that well, which is not the case with sclera. So these are Dr. Boramani's so I'm sorry, there's something wrong. The image seems to have shifted. If we get our what shall we say, incision on the sclera, posterior and posterior, and lesser, then the astigmatism that we give becomes less. So this is true with superior straight incisions. It is more true with superior curved incisions, because if we have it in the astigmatically neutral funnel, then if there is a perfectly shaped U-frown incision, technically there is absolutely no surgically induced astigmatism. And temporal SICS, like temporal phaco itself, has a place. We had done a large study in Nashik of more than 2,000 cases, and we had found it to be completely safe. And the Arvind Eye Care system, which does most cataract surgeries than any other place in the world, also rely on temporal SICS. So temporal incisions give less astigmatism. Temporal curved incisions give even lesser astigmatism. So when we look at incision type and surgically induced astigmatism, we can have the astigmatism almost comparable to phacoemulsification. And this is a publication by Dr. Nikhil Gokhale. The site of incision definitely matters in manual SICS, and we can actually change astigmatism with that. So if we take the astigmatism on a steeper meridian, like we routinely do when we do phacoemulsification, if we do that by SICS, we can use that astigmatism, we can play with it. So if the nose is in the center, we get almost 180 degrees in both the eyes to have our scleral incision on and give the best kind of results to our patients. So we use the Dr. Hill's SIA calculator. So if you look at the pre and post-op corneal topography with a small U scleral incision, it's almost same. In fact, if there is a high astigmatism, say 3.5 diopters, normally we would put a toric lens in a private practice setting. But then if we take a large superior incision, a scleral tunnel, with the astigmatism that the scleral tunnel is going to induce, we can actually do away with the pre-existing astigmatism that the patient has. So this can also be used to put in multifocal implants. So if there is a high astigmatism and we want to put a multifocal implant, but we don't want to put a toric multifocal because that greatly increases the cost, and managing torics has its own headaches, then again, doing a straight large superior-nasal incision can save the day. And the post-op refraction, of course, can be 6.6 N6. So even premium lenses, multifocal implants can be done. And I'm not saying toric implants, because toric implants are not needed because this astigmatism can be managed with a scleral tunnel. So it's not surgically induced astigmatism. As Dr. Boramani has said, let's call it surgically corrected astigmatism. And this is not exactly small incision. So let's call it customized incision cataract surgery rather than SICS. Can I have 2 minutes? The timer was late. So we need reference marking and axis marking properly. But also we have to understand that there is a trade-off between lesser astigmatism, that is smaller incision size, and corneal clarity, endothelial cell loss. A lot of us want to get our incisions smaller and smaller. But in this case, in phacoemulsification, the machine helps us to break the nucleus into parts, and that is done in the bag. In manual SICS, either the nucleus is removed in toto or it has to be broken in the anterior chamber, which is closer to the endothelium. So there are chances of endothelial injury. So we have to be very careful. And astigmatism has been used by many Indian surgeons, Dr. Raut from Pune, Dr. Pratyush, Dr. Sudhir Singh, Dr. Amulya Sahu, all of them hoping not just to give unaided 6.9 for distance, but also N8 or N6 for near. I will not go into the smart SICS thing because that is a topic in its own right. But astigmatism in SICS is something that is not a bane, it's a boon. So if we plan our surgery well, we can give our patients equally good vision, both for distance and near, by doing manual small incision cataract surgery. Thank you. Thank you for your hearing.
Thank you so much, Gokhale sir. Wonderful talk. May I now invite our president, Dr. Sanjay Tekode sir, for his talk on phaco slice for nucleus management in different cataracts.
साउंड का साउंड
Very good afternoon to all of you. And once again, I take this opportunity to thank all the delegates who have participated in such a large number. Friends, due to shortage of time, I will just show the video of my technique that I have devised for management of cataracts, management of nucleus basically. This is a video, no financial interest. Basically, what we do normally is try and slice the nucleus rather than chop it. So this, you can see in the animation, you're holding the nucleus, and then with the instrument that I have devised, we slice it into small pieces before emulsifying it. So this is the instrument. On the left-hand side, you can see it's a horizontally oriented instrument. On the right hand, you can see the regular chopper. I will show you some cases. This is a soft nuclei. So after doing your routine CCC, here you do your regular CCC.
CCC, we use the instrument that we have devised, the slicer, to gradually slice the nucleus into small pieces. We hold the nucleus and slice it horizontally and then aspirate or emulsify the small fragments. Notice the major portion of the nucleus is firmly held back into the capsular bag by the slicer, thus protecting the porcelain capsule all the time and preventing the fragments to shatter in the anterior chamber and cause damage to the endothelium. The slicer also manipulates and reorients the nuclear fragments to the phaco tip, thus preventing chasing of the nuclear fragments, keeping the probe all the time in the center and minimizing the use of phaco energy. This horizontal slicing protects the endothelium and the porcelain capsule, as you can see here. we present a posterior polar type cataract. Here it is again difficult to chop the fragile nucleus. After the CCC, we do a gentle hydro delineation as seen here by the golden ring. Then the slicer slicing the nucleus stage by stage into smaller pieces. As you cannot rotate the nucleus, the central portion is first tackled and then gradually we move towards the mid-peripheral nuclear portion, finally the epinuclear part, and then once the whole nucleus and the central hard core is sliced and emulsified, here you see the second half of the nucleus being sliced and emulsified piece by piece. Notice how the slicer holds back the piece in the bag, protecting the posterior capsule all the time. We need not change the parameters for the last piece as the slicer is oriented horizontally and it prevents any damage to the posterior capsule during any surge. The posterior polar part is then taken care of. Finally, we present a white, intumescent, brittle cataract, wherein it is difficult to hold the brittle nucleus and chop with a regular chopper. After completing the capsular axis, which sometimes is difficult in these cases, we hold the nucleus with a phaco probe and with the slicer in the left hand, we slice small pieces and emulsify them in the center. Here you can see each piece being gradually sliced and fed into the phaco probe. This prevents shattering of the fragments and keeps the remaining part of the nucleus firmly into the capsular bag till the end of the procedure. See the ease with which the fragments are being sliced requires very minimum energy, which is friendly to the endothelium. These type of cataracts have very minimum epinuclear cover, so the horizontal instrument is friendly to the posterior capsule in case there is any surge.
Demonstrated this during our live surgery on Friday. And I'm thankful to Dr. Srikant Joshi who allowed us to use the facilities of the Nath Mangeshkar Hospital. We had about 10 live surgeries and they were all of different varieties. So I thank DMH and its team for it. Thank you.
Thank you, sir. I invite
Sanjay,
all the
your-
speakers to be on dais. Dr. Vardhaman. Dr.
Sanjay, your
Vardhaman.
videos were classic. Thank you.
Dr. Vardhaman, Dr. Parikshit, sir, please. Thank you. I request everyone to join us for the lunch. We'll be starting next session sharp at 2 p.m.
video button बघू का?
Hello. Hello.
लिंक होता है ना, इधर ही ऐड कर देता हूँ मैं। लैपटॉप है मेरा, if you want.
Hello, hello.
Hello. Good afternoon, everybody. We'll now start cataract and refractive surgery session 3. I would like to invite Dr. Sandesh Doshi, sir, chairman of the session, then co-chairman Dr. Shashi Prabha Prasad, ma'am, and moderator Dr. Nirupa Timle, ma'am. Thank you for coming. Hello. Hello. I'll request Dr. Nirupa Timble, madam, to start the session. Thank you.
Hello. Hello, good afternoon, everyone. We'll begin our cataract and refractive session. And I'll request our first speaker, Dr. Kishore Pahuja, who will be speaking on optimizing capsulorhexis. We will have 8 minutes per speaker and we'll give intimation after 6 minutes.
Hello, 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 hello. Hello, yeah. Am I audible? Yeah, okay. At the outset, I thank US and the scientific committee for giving me this opportunity. And as in a post-lunch, I hope that I'll do an justice. The topic given to me is an optimizing a capsulorhexis. So I'll just give a few talks about it. If you look at the capsulotomy, which has ever-changing in a cataract surgery, I mean, initially it had no role. I mean, you used to do an intracap cataract extraction. Then there was a crude opening in the intracapsulotomy. So, just to take out the nucleus out. And then we thought of it, I mean, some cystotomes or forceps to create a different shapes of a capsulotomy to give an IOL support, like the can opener and this. And then the continuous coronal capsulorhexis, which we call as an CCC today, for both anterior and posterior capsule to hold the IOL, or to be the IOL in the bag. Now we have many devices from lasers to metallic thermal instruments like femtolaser, Zepto, and the thermal thing. And so just to have a consistent central capsulorhexis. IOLs are being developed also to conform to the capsulotomy. Now the credit goes to all these three scientists, which actually they started. The gimbal started with a continuous capsulotomy, and then Shimizu said is in a curvilinear, and Nihon said is in a capsulorhexis. So the term from all three was generated as in a continuous curvilinear capsulorhexis. Now, if you see the advantages, this most important step on a cataract surgery, and CCCH also reduces the chance of a tear during surgery. and continuous edge of a cortical cleaving heterodissection. So if you want to do a heterodissection, if it's circular, then I mean there is no fear of an tear. And it also facilitates the cortical cleanup at the end of the surgery, and you can put an IOL in the bag. And also, if you do an optimal size of an capsular axis, it's suppose IOL, suppose if you have an PC tear or something. So I mean, if we see so many advantages of a capsular axis, why still we being discussed about it? The reason for that is completing a case without an obvious complication is no longer enough for a refractive IOL area, because you do an aspheric, toric, multifocals, trifocals, and all that. And so reproducible and stable long-term results are just as crucial. So, I mean, achieving a consistently sized, well-centered circular capsular axis is now essential. If we look at the studies, the effect of capsular axis size in posterior capsular opacification, 1 year study which they said the large capsular axis were associated with a significantly more wrinkling and a posterior capsular opacification as compared to optimally or 5.5 millimeter. The another was an effect of in the bag intraocular fixation on the prevention of an PCO. So that also said that in the bag PCIOL fixation is required to constantly reduce the incidence of an PCO. Thorough removal of an lens substance, including heterodissection, assisted cortical cleanup, and in the bag PCIOL fixation seem to be most important factors in reducing PCO, regardless of a surgical procedure or an IOL type. So that means this is important. So if you look at this, now the first thing that we talked about is the size of a capsular axis. So if you see, there are different devices. Then like this is the marker. So this is an square marker along with a central thing. And then you have a Varian assisted capsular axis, and then also you have an Zepto and Femto assisted capsular axis. Now, the next comes as a technique. Anterocapsular axis is stand with a trypan below, and use cystodome to scrape a tear in the anterior capsule, and then continue with that. And if you feel it's going to extend, then remove an cystodome with an side and replace with a capsular axis, forceps, and then one of the flap, and you pull over briskly 180-degree opposite. So I'll just show you in the videos that how we do that, and continue to grab flap about 1.5 millimeter away from the tear point. So you can just pull it and continue shearing in a circular motion. So we are going to apply a tear and shear forces. So if you see this, now this is an indication where we say that this capsule is leg. So you have to be very, very careful when you start with that. See that, then you have to be careful in pulling in the center, because you're just going to pull the zonules also. Now, if you're going to do a multifocal IOL, in that, this is really, really important that you do a mark on the cornea, and then you move in the thing. The important thing here, if you want to really control that, the flap has to be, you have to every time see that the flap has to be over the capsule, because if you pull into that, you are going to, this is a tearing force that we say is you tear it, but suppose if you extend it, then you just pull it on, that is called as a shearing forces. And if you feel the chamber is becoming slightly shallow, just put a visco into that. Don't push too much into that, and don't allow that AC also to be shallow. If you have an optimum, then you have a good control on that. Now this is another thing that when we talk about that, suppose if you feel that you have done in a capsular axis and you feel that the size is not optimum that you have planned is, then you just continue that and given a nick along with a scissor.
2 minutes.
Yep. I'll finish it. Right, suppose you see that now this CCC is slightly less, it's about 4 millimeter. So what you have to do is just push on a high density, Helan or something, given a nick, and then within a forceps, you just extend that and just bring it to an optimum size of that. This is when you hold it, you feel that suppose if you want to extend to the periphery, you have to lift it up and then pull it. And suppose if you want to just only move it straight, then you just pull it down and then keep on a capsule around that. And then here you just continue with that. And when you feel that, suppose if you feel that now is going to extend it, go from an opposite direction and pull it, because you need to pull it. I mean, you need the shearing force also along with a tearing force. And this is here you just pull this. This is a force that you're going to give it opposite 180 degree. I mean, opposite to that. Now, suppose if you have some tear in that, then what you have to look into that, you have to be very, very gentle into that. And then this when you want to pull it, it's slowly, you have to just move that. Now, if you see that there was a tear when we extended, there was a tear in the anterior capsule. Go forward. Yeah, so you have to be very, very gentle because there is a tear at the natural clock position. I can't go forward here. Okay, so and the thing is, if you feel there was a tear into that, now this CCC supports you to put on a lens in front in the sulcus, and then do a capsule capture. Right, this is you do an anterior vitrectomy and then push on a viscoat or Helan, and then push this lens and tuck it into the bag. So what size goes? Suppose if it's large, you have a positive dysphotopsia, position of IOL is anterior push, so your IOL power changes and decentration of an IOL happens. And if it goes small, it's a difficult surgery because you have a small CCC, capsular phimosis happens, and subluxation of a bag IOL complex. And once it becomes opaque in the post-op period, then you have an issue in peripheral retinal visibility, negatively affect the results of an aspheric IOL because it works for the periphery. And if you have a multifocal, so you lose the peripheral vision into that. And a negative dysphotopsia also is a matter of origin. Thank you very much. If you have any questions, I'll be happy to take it.
Any questions? Thank you so much,
Thank you.
Dr. Pahuja. It was a wonderful presentation. Now the next speaker is.
Now we invite the next speaker, young and dynamic Dr. Ridhima Bhagli. She will be speaking on management of complications of smile surgery.
Thank you very much, sir. Respected dignitaries on the dais, seniors, and my dear friends. I'm thankful to POS for this opportunity. I'm going to speak about challenging situations that one might face during Relax Smile. So Smile, I think over the last few years, it has proved to be consistently effective and predictable in correcting myopia as well as myopic astigmatism with a favorable profile in terms of corneal biomechanics as well as corneal sensations. However, it is a technically demanding procedure and it has its own share of challenges. The profile of challenges is different. Usually the challenges or complications relate to the learning curve that the procedure involves and relates to the surgical experience. And all of them can be managed with a very good visual outcome. So just to start off with the basics, there are 4 cuts that the laser does in Smile. The first is the posterior or the lenticule cut. The second is the lenticule side cut. The third is the anterior or called the cap cut, which is a millimeter larger. And the last is the cap opening incision. So the commonest challenge is a suction loss that can happen during these cuts are made at any of these 4 steps. And the management would then depend on the stage at which the suction loss happens. The posterior cut is the first cut. And if the first posterior cut is less than 10% complete, which happens very rarely, then we can start a new procedure taking a new license. If the posterior cut has been made more than 10%, but the side cut has not been reached as yet, then we have an opportunity to convert the procedure to femto LASIK. I hope this, yeah. So I have shown, there's a video of there's a lag in the play time. I'm hoping it plays. You exit now. So I'm going to play the videos from outside the presentation. So management of suction loss in SMILE. If the posterior cut, there's a suction loss wherein the posterior cut has been almost made. This is the first cut. And if you see that a suction loss happens at this point, the laser machine will guide you further. And there is an opportunity to convert the same, using the same license, we can convert it into a femto LASIK procedure, wherein we can choose whatever depth of flap, side cut, diameter, hinge size, and the procedure still can be completed successfully, but converting it into a flap. Usually the machine will guide you as to what needs to be done next. The second situation where the suction loss happens at any point after the posterior cut has been made, you can still resume the procedure. So here the side cut was made and we have redocked with the same contact glass, same license, and it will continue. The anterior cut has been made and the final opening incision has been made after that. Common time when the suction loss can happen is during the cap cut or the anterior cut, because that's when the green light blurs, when there are two passes of laser that are made. And if this happens, again, it's more challenging at this point to redock at the same place, but you can take a break in between for the air bubbles to resolve. But usually with the same contact glass, it is possible at the same footprint for the docking to happen, and the cap cut is remade from the beginning, and then the cap opening incision is made, and then the procedure is more or less the same without any hindrance in dissection. Here is a video of an incomplete suction loss. That means the laser did not stop firing at all. That means that the back cut has happened, the side cut has happened, the anterior cut is happening, and there was an incomplete suction loss. The patient moved, but the laser is complete. And you can see that the opening incision is fortunately on the lenticule, and it is still possible somehow to access the anterior and the posterior planes of the lenticule. And it was quite easy, in fact, to separate, because the anterior cut is like a millimeter larger than the posterior cut. The posterior cut was fully made in its entirety. So it was possible to easily retrieve the lenticule without a problem. So most suction losses can be managed without any visual complications. So I'm just going to show you all the videos now, since they are not playing in the PPT. The next one is, commonly the challenge can be with black spots happening at the time of the procedure. Any debris or a dry ocular surface, if there's any fiber or water droplets, the laser may not fire adequately in that particular area, and then there may be an issue with dissection in that particular area. As you can see here, there was a water droplet in the interface between the cornea and the contact glass, and in such a situation, the laser firing in that area, maybe this is quite drastic. Usually black spots may be quite tiny in the middle of your dissection if the surface of the cornea was dry. So usually I recommend wetting the surface before starting the docking. But here you may need to manually dissect both planes, not just the anterior, but also the posterior plane, a little bit manual dissection to ensure that it's fully separated. And like a rexis kind of movement, you peel out the flap, but ensure that it's entirely removed the lenticule along the edges as well. So this is another challenge that mostly these challenges happen, as I said, in the learning curve of the procedure, and they relate to the experience of the surgeon. Lenticule getting stuck. So as we know that we have to honestly like separate the anterior flap first, followed by the anterior cut, followed by the posterior. But when you're operating on a low myopia where the lenticule is thin, here I am hoping that I'm in the anterior plane and I have dissected it entirely. But when I try to, when I try to go behind, there is no posterior plane. So the I have dissected the posterior plane first, and I then need to use like a longer, sharper, blunt instrument and go above the lenticule and find the anterior plane. This can be a little bit challenging for beginners, but it can be done. But this commonly happens in low myopes where the tendency is to enter the posterior plane first. So it can be challenging initially, but however, it is successfully possible to complete the procedure. Another challenge can be similarly in low myopes. One is the lenticule getting stuck to the roof, and the other is the lenticule being so thin that it can tear while extracting it. This is again in low myopes, and you have to ensure that you're entirely separating both planes before attempting to extract the lenticule. So I was pretty sure that the anterior plane here has been entirely separated 360 degrees. And this is the posterior plane being separated entirely for 360 degrees. And as I went and grasped the lenticule to get it out, I've even like gathered it in the center. I extracted it and I saw that it had torn. So there's a small piece there, and it's not possible for it to remain behind unless it was attached at a particular point over there. So I've removed the entire lenticule, but I go back in to dissect and see that the anterior as well as posterior, any edge left behind has been separated above and below in its attachment before going in and peeling it off like a rexis movement again with a forceps, and that now it's completely removed. So being careful in thin lenticules is again important. Smile, another challenge is usually retreatments because we don't have a flap to relift like in LASIK, and making a deeper cut is not always possible because the cap diameter and the lenticule diameter are different. So our options are either to go ahead with a surface ablation, or then this is the Circle software video, wherein if you have access to the Circle software, it creates just a circle rim around your initial cap cut, and this is the flap side cut being made. So the Smile procedure can then be converted to a flap, and you can lift the flap and treat the area. Or in case the other option for retreatments are usually in case you've had a big cap initially, like 130 microns, you can do a thin flap LASIK after that if you do not have access to the Circle software. But this video demonstrates converting the cap cut, which was the anterior cut of the lenticule, that has been extended into a flap and side cut. And now you can see the flap is being lifted for treatment of any residual errors. So other than these, the common post-op complications can be like ectasia, and we have to be careful, just like with LASIK, with Smile, with patient selection. But usually there are no flap-related complications or dryness. Epithelial ingrowth is quite less. So I think that should conclude my presentation on the challenging situations that one might face. Thank you very much for your attention.
Good afternoon, everyone. I will be talking about, first I wish to thank the BOS Society for giving me this opportunity. Simple steps to avoid complications in LASIK. Yes, so there is no financial interest in this. So if you can't do great things, I can do small things in a great way. So refraction, doing the correct refraction is the most important step in getting
Check one.
Yeah, I thought somebody was speaking. So a thorough refraction is very important. You have to, and you must repeat refraction on the day of the surgery itself. If you start with a bad data, how can you get a good outcome? Then you have to stick to the nomograms, and if required, you can make your own nomograms depending upon your experience. So data entry, this is also a very important thing because we usually rely upon our optician or optometrist or somebody assistant to feed data into the machine. So it is always better to cross check whether the data entered into the machine is correct or not. Second thing, which is important, is the ocular surface. So you have to rule out meibomitis, blepharitis, or any lid abnormality. Always check for dry eye. Assess and treat the dry eye first. So studies have shown that dry eye is one of the most transient side effects of LASIK, as common as up to 98% in the first week of surgery. And patients who have DED preoperatively experience more severe symptoms like tear dysfunction after LASIK. So it is always better to assess and treat that condition first before going in for a LASIK procedure. So you can do that by pre-op and post-op lubricants, eyelash scrubs, hot fomentation, and oral doxycyclosporin drops. So this will help in preventing BLK, dryness, and glare. So keratitis, the studies have shown that most percentage of times the keratitis has occurred within 7 days of surgery. So the most likely cause is something has happened during the surgery. So steps to prevent that is your eyelid examination pre-operatively for any MGD or other complications. OT cleaning, clean lashes before surgery, advised to scrub 2 days prior to the surgery, and pure and contamination-free water to clean instruments. Use of fresh blade and gloves, avoid lashes in the surgical fluid, wash surface meibomian secretions thoroughly, wash the bed after laser ablation, and pre and post-operative antibiotics. Look for uncommon things like epithelial defects, history of any previous viral keratitis, avoid use of colored contact lenses or eye makeup after the surgery, and watering and sac syringing if necessary if there is continuous watering. Now, flap-related things, the review articles of IGO has shown that suction loss occurs only in 0.06% to 4.4% of the cases, and incomplete flap can occur in 0.3 to 3.6% of cases, and flap pair is very rare and it is more common in femtosecond LASIK. Then there could be buttonholing of the flap, and free caps is observed in only 0.01 to 1.8% of the cases. So pre-op, what you can do is look for any corneal scar if the eye is deep set or prominent brow, nystagmus, and topography if there are flat or steep K. Intraoperatively, you can avoid paracan drops in both eyes simultaneously. Put one after the other because the other eye can become dry because of the use of paracan eye drops. Then select the correct ring size, mark for alignment, and scleral show. See that with your ring is properly centered and there is a proper scleral show. And avoid eye exposure and should have a proper head position. So to avoid all these flap-related complications, you have to see if the suction is proper, or otherwise it could lead to incomplete or free flap or buttonholing of the flap. Reposition or ironing of the flap is very important so that you don't get any striae afterwards. Avoid bandage contact lens, or you have to use it in the opposite direction. And prevent squeezing of the squeezing while the speculum is removed, and prevent rubbing and protective eyeglasses to prevent flap dislocation. So I don't have any experience about femto flap, but there is what is documented is a vertical gas breakthrough corneal. If there is any corneal scar or Bowman's membrane abnormality, and opaque bubble layer occurs if the docking is not proper. So exam-related complications could be like clear the stromal interface debris prior to the laser to prevent any central islanding as shown there, and see that if there is a pupil proper centrations and the ablation is taking place in the central zone. Epithelial ingrowth could be another complication. So it occurs in 0 to 3.9% of the cases, and in the primary cases, and in 10 to 20% in retreatment of cases. So if there is any corneal problems like Bowman's membrane dystrophy, you have to check it properly pre-operatively, proper flap apposition, and if people with type 1 diabetes mellitus are more prone to this complication. Icteria incidence report is only 0.6% cases, so your topography has to be very good, and you have to check the topo parameters properly. So it's a symptomatic complications like some people experience abrasions. So to prevent that, we have to see the centration of the ablation zone or the optical zone is correct, and prevent ablation over the flap. Glare, if to prevent glare, this thing pupillometry should be done, especially if in high refractive error cases. So refraction, ocular surface, and patient counseling will help you in preventing any complications during the LASIK. Thank you.
Thank you, Dr. Nitin. We have really stuck within the 8 minutes time. Thank you very much. Any questions? Next speaker is Natasha, Dr. Natasha Pahuja. She'll be speaking on topography for cataract and refractive surgery.
At the outset, I would like to thank POS and the scientific committee for this wonderful opportunity. I'm going to try and do justice in the next 8 minutes to a topic which the SST took 1 day to cover. We're going to look at corneal topography in a slightly different perspective. Essentially, why do we need corneal topography is because the kind of patients that we are getting, they're so demanding that they already know everything, and they'll come and show you the reports and tell you that now you tell me what kind of IOL should I choose, or should I go ahead with corneal wavefront guided or topo guided or Contura. So these are the kind of patients that we are seeing these days, and the only warrior weapon that we have is our corneal topographer. There are multiple kind of corneal topographers based on different principles. Essentially, let's just try and break it down and understand what kind of corneal topographer has got what positive points, and we need to exploit them. Essentially, if you look at a placido-based imaging, any kind of placido-based imaging, what it gives is a very robust anterior curvature data. So if we need surface treatments, a placido imaging is much better than elevation or shine plug imaging. It also picks up surface irregularities much well, and it is the only topographer which is affected by tear film. So if the tear film quality is not good, you don't need an ocular surface analyzer. A simple topographer will be able to tell you that the surface needs treatment. Shine plug, on the other edge, gives you a pachymetry, very good elevation data, although it's simulated. More than that, it gives you 3D anterior chamber imaging, and it gives you ray tracing aberrometry as well, which is also quite robust. But what would be really good is if we could combine both placido and shine plug imaging, and that is possible in 2 main topographers. I have no financial interests. One is a Cirrus and the other is Galilee. So principally, these two are the topographers which have best of both worlds. Now, why do we need elevation in the first place is simply because if you look at these 3 spheres, they have the same radius of curvature. But this radius of curvature is what gives us the sagittal map or the curvature map. So it gives you absolute values of 43, 44, 45. Now, if we put a reference plane to this, if you look at these spheres, they have different sizes now. This is what is given by the elevation map. So what we essentially need is elevation for primarily refractive surgery. And this is represented by different colors. Needless to mention, anything which is steeper is in warmer colors, anything which is flatter is in cooler colors. Now let's just look at a case example in this case. Which do you feel, which of these patients needs corneal collagen cross-linking? Yes. So I'm seeing pointing of hands to the right, to the left bottom one. If you look at the absolute values, they are essentially the same topography. What I've essentially done is just change the color scale. So when a map comes in front of you, do not just look at the color scale. You also have to look at the absolute values. If you look at the steepest point here is 44.9, which is normal. It's just that it's a slightly irregular cornea with a decentered apex, but the topography is absolutely normal. So what we need to do is look at the color scale, try and keep your color scale. If you're looking at patients progressively, try and keep the color scale constant. How you can do is go and click on the color scale map and right click or double click and you can change it. If you have pentacam, try to stick to the universal standard scale because that is what everybody uses and it's very easy to publish with that. Now let's just look at certain specifications. We don't need to get into the details of it. What you need to understand is if you have 25 frames per second, that is wonderful. It gives you decent map, but if you're looking at very subtle changes, shift to 50 frames. The time taken for the scan is slightly longer, but you get very, very good subtle details that can go missed in 25 frames. Now, the other factors that we need to understand in topography is the applications. What any topographer will give you a quad map or a multi-map. Most importantly, we don't need to get into the details of these maps. What we need to understand is that have we actually captured the image properly? How do we do it is if you are imaging the patient yourself, just make sure that the cross coincides with the Purkinje image. So this is basically a well-centered scan. If you don't have decentered scans, you won't find surface irregularities, and most often than not, the cornea is quite regular if the scan is centered. The other way how you can do it is ask the patient to close the eye that is not being scanned and look straight into the light. That also gives us very good scans. What is even more important is just look at how much is the coverage. If you're planning for a refractive surgery, now in this case, if you look at the Placido coverage, it's almost 86%, which is decent. Anything above 85% is decent. Also look at the SSE check, which is the cyclotorsion check, which is again very important if you're planning for astigmatic corrections. Moving on further, this is just a statistical data that is given. The summary is given. What are very important factors are the angle of alpha angle intercept, which gives us if the scan is decentered or not, or is how you're going to plan the refractive treatment. Thickness of the cornea, the thinnest point is very important if you're planning for surface ablation or any of the other refractive procedures, depending on how much is the thinnest corneal thickness. Also important to look at the anterior chamber depth, because if the patient is not fit for corneal refractive procedures, the patient can be considered for phakic IOLs. At the end of the day, if you do not have a topographer, the best is if you just get a printout of this quad map. That is all that matters. It gives us an anterior elevation, posterior elevation, pachymetry, and the statistical analysis. What is very important here, if you get a quad map, is look at the red flags. Any topography which has got keratometry more than 46 is a red flag. Elevation more than 12 micron is a red flag. Elevation, posterior elevation more than 18 micron is a red flag. And the thinnest point, if it is decentered, it is a red flag. What is even more important is if the steepest point on the anterior elevation, posterior elevation on the sagittal map and the thinnest point, if they coincide, that means it is a suspicious cornea, and do not go ahead with refractive treatment in such cases. Another passing remark in this is if you look at the comparative map, if you have called the patient back after say 6 months, yes. If you look at the comparative map, now you see here in the blue zone in the right extreme corner, you feel that the patient is progressing. But if you actually look at this image, these two topographies are taken at least probably 30 seconds apart. So what I'm trying to say by this is that there is a test-retest variability. Every patient that you're considering for either a premium IOL or refractive surgery, you have to image these patients at least 3 times in the same scan. So the test-retest variability has to be ruled out because this is just about the repeatability issues. And we have published this data of the range of test-retest variability that is there with different topographers. Again, just a passing remark that we need to look at is that when we're looking at the keratometric indices, we also need to look at what the refraction is coming from the ray tracing. So most topographers will give us abrometry. They will also derive the refraction. If you're planning for a refractive correction in such patients, just look at the Zernike map. It will give you the refraction as well, and just compare it to the subjective acceptance of the patient. It's very, very important if you're considering for refractive surgery. Now, just a passing remark again on cataract surgery that is planned post-refractive surgery. This is what we're getting a lot. This is what our expectation is, but the reality is we get patients like these with highly irregular corneas and decentered ablations. What we need to do in such cases, like this is one example where the patient had a decentered ablation. Look at the ray tracing again, which was done in eye trace. If you just remove the cataract, you are not essentially correcting the quality of vision because the cornea is still irregular. So in such cases, it would be very, very important that we address the cornea as well. This is done by customized treatment in terms of topo-guided treatments. Again, one remark that we need to look at when we consider these patients for refractive or cataract surgery is look at the histogram here. If it has got a smaller base, that means it is a good histogram. You can consider premium IOLs in this, and you do not need to choose a monofocal IOL for such cases. I'm just going to jump. So also look at the distribution of keratometric reading across different pupil sizes. So look at the pupil size here. In the center, if you look at a 3 mm, it looks like a very decent histogram, can be considered for a premium IOL. But as soon as we increase the optical zone, which is 4 mm, 4.5 mm, the base of the histogram increases. Also, there are 2 peaks, which means this patient is not ideal for a multifocal IOL. And you would probably choose a toric IOL. Even though the toric value is smaller, you would choose a toric IOL for this patient and not a multifocal IOL. Here's another case example, again, a very wide based histogram here, as we can see here. And if you look at the distribution of keratometric readings, it's quite erratic. Although the topography looks very, the topography in the right bottom looks extremely regular, but you would not choose a premium IOL in this case, and a monofocal IOL would be a better option. Yes. Just a passing remark, it is important to look at pupillography and the aberrometry in such cases. Here is something that we can objectively classify or quantify, is looking at the densitometry. If we are not able to look at how much is the grade of cataract, the densitometry is something that gives us the grade of cataract objectively, and this is easier to convince the patients then. Just a last case example. Now, if you have a topography like this, it's steep. On the posterior elevation, there is some amount of elevation noted. Although the standard deviation is 1.56, which is not too far away from suspicious cornea, which is 1.60. In such cases, look at the tangential map as well, which basically gives us that there is a localized elevation. Do not consider these patients for refractive surgery. And if you get a topography like this, where there is the keratometry is very good, but the posterior elevation shows some changes, the keratometry is in fact flat. So such cases is something that we need to look at in terms of the posterior changes that comes from the endothelium. So in cases of failed endothelial pumps, you'll get a flat cornea with a decent pachymetry. And this is what is something that we need to look at, especially if we get localized isolated posterior elevation changes. So this is the patient with specular microscopy such, whereas a corneal topography was normal, apart from the posterior elevation changes that was there. So to summarize, we are trying to make a difference into our clinical practice. What is very important here is a corneal topographer, which gives us a lot. We just need to understand it better and apply it to the maximum possible. Thank you very much.
Thank you, Natasha. We have next presentation from Dr. Anurag Mishra. He is not available, but he has sent his presentation. So we'll just show this presentation. His talk is on case presentation on Nepafenac 0.3%. Question.
As I take up my topic on a few important atypical case presentations on post-operative inflammation control with Nepafenac. Now we know that Nepafenac is a very potent non-steroidal anti-inflammatory agent, but what we are discussing in this particular segment is whether or not we can use this agent as a standalone anti-inflammatory medication in the post-operative period. So it's interesting as a concept. We know how it acts. It inhibits the cyclooxygenase pathway. There's no effect on phospholipase I2, so phospholipase A2. So some of the inflammatory markers are not prevented from being produced. It doesn't have any effect on the cellular response as well. That's the reason why corticosteroids are said to be more potent. And it also doesn't have any effect on the cytokines, bradykinin system or complement cascade. But let's look at the inflammation that occurs in the eye. And do we actually need steroids to control that? It's a very localized inflammation. We all know that. It's a very localized inflammation. We just want to give coverage for a breakdown of blood-aqueous barrier and intraoperative tissue handling. that happens during surgery and the endothelial stress. So there is no cellular element involved. And there's no way it has been recommended that you should taper the agent, the corticosteroids that you're giving topically. Topical corticosteroids don't need to be tapered. All these came to our minds, and we initially thought that we could use NSAIDs as a solo agent in the post-operative period. We tried that in a few uncomplicated cases where not much of intraoperative difficulty was encountered. And the CD, the cumulative dissipated energy on the phaco machine, was less than 10, and the surgical time was less than 4 minutes. We tried that in 200 initial cases. 5 out of those patients did need an add-on topical steroids, but 2 out of them were for allergy and not for any inflammation. There were no symptoms. The most important thing that I observed with this was the surface of the eye was very, very healthy. And there were occasional cells in the AC, which is common in the first 1 to 2 weeks. However, they were not having any clinical significance whatsoever. Now we have a new baby on the block, Nepafenac. I used without any financial interest whatsoever. The one that I used earlier was Nevanac, but now we have the OD formulation of the same, which doesn't have preservatives. It's even better tolerated. There is a very good dose compliance. 9 p.m. in the evening, everybody in the family is back home, so you don't have anybody else's assistance, and the patients do not have to self-medicate themselves. The surface looks even better, and the occasional prickly sensation that the patients used to complain of when they were giving steroids, they were being given steroids due to the preservative response, has been reduced down to a minimum. We've done 300 surgeries with that, with the same prerequisites initially, and we have got excellent results. Now we have expanded our horizon. We are not looking at cases which only have uncomplicated outcomes inside the OT. We're not looking at a CD of less than 10 or a surgical time less than 4 minutes. More and more atypical cases included in the list, and it has become a staple regimen in our hospital unless decided otherwise. So some of those atypical cases are what we are going to see right here, right now. So this is one patient who had a hypermature cataract and a small pupil. The pterygium has stayed over the years, so nothing needs to be done about that. The keratometry is pretty fine. This is a technique, I call it aqua sweep, wherein I sweep with the irrigation cannula to liberate the milky cortex from the capsular bag. And then on, I continue with the capsular rhexis. There are a few capsular plaques which are preventing a smooth, rounded movement of the CCC margin. However, I did have a crazy idea at the beginning of the surgery not to use any pupil stretching device in this case. No reason why I did do that, but it's just like that. You can look at the IOP, which is set at 30, and you have modern day machines which perform extremely well under low fluidics conditions. The dynamics actually takes over, and the supreme dynamics that is installed in these machines actually helps you break even the hardest of the nuclei, while the PC is located at a safe distance away and you have no chance of catching it. So I keep on chopping segment after segment, cartwheeling the nucleus in the bag safely. I'm quite certain that none of the ocular tissues are going to come inadvertently and get engaged into the phaco needle. Now, after the chopping is complete, we go down to the quad mode and continue chopping it. At some point in time, since the energy used in this particular case is more, so we just stop and refill the anterior chamber. The basic reason why we do that is to coat the endothelium, because there's no answer to an endothelial stress if it's more corticosteroids have to be given. Since we want to cut down on that, we have to protect the endothelium mechanically. So we stop midway or 2/3 and put in some dispersive viscoelastic and carry on with segmentation of the rest of the nucleus. The CD here is a little high. So we give prednisolone acetate 6 times a day only for a week. Suddenly stopped it, continued with Nepafenac in the OD formulation dose, and the patient did fine. So that was the crux. We did an endothelial cell count post-operatively as well, which was not very bad. And the inflammation part was aptly taken care of by Elevro along with Predford, just given for a week. This is another patient who had a long-standing history of rheumatoid arthritis. You can look at the eye. Multiple attacks of iridocyclitis have resulted in this. After doing a synechial lysis all around, these are not pupils which actually stay like that. This patient has been given Nepafenac ahead of the surgery because you want to have a good mydriasis maintained as well inside the operation theater. And of course, you also need the prostaglandins to be kept at bay because these patients are very likely to have postoperative cystoid macular edema. There's nothing in the nucleus, though, not very hard to manage. So pretty choppable and pretty emulsifiable cataract after the pupil behaves properly. The only crux in this particular situation is that we have handled the iris. Actually, we have put in a bulky instrument which keeps the eye pupil dilated. And for us to complete the rest of the procedures, after the bag is free of all the nuclear fragments and the epinuclear plate and the cortex, the IOL goes in, sits comfortably inside. We dial the rest of the haptic in and simultaneously dislodge the Huygens ring, which has been in place. So one by one, the scrolls come out. This also would need some amount of handling. You can see a bit of bleeding as well, which has basically happened because of the synechia in the earlier part. This is a long-standing synechia. The Malugan ring is placed into the plunger. This patient received soft steroids, fluorometholon, 4 times a day, just for a week. Then it was stopped, and the rest of the postoperative information was carried on with single dose. The patient had a lens-induced glaucoma, a phacolytic glaucoma. You can see the milky fluid escaping and the iris trying to come out. The iris is just trying to come out because of the intralenticular intumescence, actually, which is pushing the whole thing anterior. Because these patients do have a hard eye. This patient was given mannitol. The IOP had softened. But once we create a smallish opening in the anterior capsule, which we have to do, this patient's capsular rhexis would be extended in 3 phases, actually, as you would see. So once a small opening is made and the mid-peripheral fluid pockets are broken, essentially the intumescence is gone. And once the intumescence is gone, the iris, we would see in a while that the iris also starts behaving more appropriately. Now you would see that the iris is behaving more appropriately. While we create a nick from the side port, we have to extend this opening of the capsule because this does not give us a sufficient enough window for us to go ahead and chop and remove the nuclear fragments. So this is too small a CCC at the moment. So the microrhexis forceps, this is actually a membrane peeling forceps, not rhexis forceps in proper. I love this instrument more than the toothed one coming in because they withdraw while you're trying to oppose the 2 blades. So we go from the opposite end side port, grab the capsule. All the while, it's a little difficult to maneuver instruments in these sort of eyes because the anterior chamber is relatively shallow. But we finally get a grab and extend the CCC. The rest of the procedure is not that difficult because the nucleus is not very hard. And then on the nucleus, we put in the IOL, and then comes the third part of rhexis extensions. So the patient did not have any bothersome handling inside the AC. It's just that multiple bouts of viscoelastics have to be put in. Tissue respect has to be maintained all the while long. So we did that, the last part under the cover of BSS. No viscoelastic was put. This patient was not given anything postoperatively, just steroidal anti-inflammatory agent, no steroid. However, we did top it up with a bit of hypotensive agents, but no corticosteroids was given. This patient also did fine. So the carry-home message that I would like to give is when you reduce the dose formulations, the drops that you give postoperatively, apart from the practice at your setup being premium, that also gives your tag of premiumhood. You're just giving 1 drop at 9 p.m. in the evening, and throughout the day, she's just putting lubricants, by and large, nothing more. If you have intensive course of therapy, that also lasts for a week and no further. So this is a total preservative-free regime. The surface behaves very well. The patient feels premium, and you are happy when you go to sleep in the evening. Thank you so much for your attention, ladies and gentlemen. Here I remain. Thank you. Regards from the land of Lord Jagannath, as I take up my topic on a few important atypical case presentations on postoperative inflammation control with Nepatanac.
Thank you. Thank you, Dr. Anurag. And the last speaker of this session is Dr. Mukesh Paryani, and he will be speaking on status of surface ablation today.
Good afternoon, everyone. Yeah, so I'll be talking on surface ablations. Once they put up the slide. Yeah, so I'll be speaking about surface ablations. So we have seen today the smile surgeries we have with the LASIK covered, and now comes the surface ablations. So we know it has a huge history, the surface ablations, and certainly it's making a big comeback in the refractive surgery practice today. Why do we need a surface ablation today? Because when we have some cases which are like a pachymetry of around 470, not so high refractive error, or in cases where the flap making itself is a risky thing technically. So perhaps these are the cases where we perhaps prefer to do surface ablations. So surface ablation, what's the basics? We remove the epithelium. Removal of epithelium can be done through different methods, and then we ablate the surface using an excimer laser. Either I remove it mechanically or using an 20% alcohol. There's some use of brush as well. While in LASIK, we use alcohol and then perhaps reposition that epithelium fab that we make. In epiLASIK, there's an epikeratome where we make an epithelial flap using an epikeratome. It's hardly done now with the advance of the transepithelial PRK. Now, what are the advantages of PRK? Certainly, no flap-related complications at all. You don't require a microkeratome. It is biomechanically much stronger, and I'll be showing some of the studies which prove that. And much lesser chances of ectasia because it's pretty much stronger biomechanically. But what are the factors in our mind? So these are the factors that every now and then I also think whether to go ahead with PRK or not is because they have development of corneal haze, very important factor. There can be regression chances a little more. The pain post-operative, one of the major factors here is the post-operative pain, and I cannot correct higher range of myopia or hyperopia with a PRK. And obviously, because you're taking off the epithelium, there are chances of corneal infections as well. Now, the two major factors I'm going to discuss, which kind of, as of now, limit our practice for doing more PRKs, is the corneal haze. We all know that subepithelial scarring is a well-recognized complication of PRK surgery or the advanced surface ablation, but with mitomycin C, all things have completely come down. What are the factors for developing corneal haze? Deeper ablation, ultraviolet light exposure, high astigmatism, and certainly a prior corneal surgery. These are factors that actually can cause higher chances of haze in patients with PRK. Now, this is a patient this was a study published which shows that higher we ablate, there are higher chances of development of haze in PRK or the advanced surface ablation patients. That's why we kind of limit our surface ablations to around -4 to -6 diopters, because beyond that, there are higher chances of development of corneal haze. So mitomycin C is certainly inhibits the haze formation and improves the visual acuity outcome in surface ablation patients. And it has been proven beyond doubt by multiple studies. Now, what if at all you develop a still in haze? This was a patient who underwent PRK surgery with mitomycin C, came back after 6 months. He had developed some typhoid fever, following which he developed diminution of vision. Well, it requires a lot of patience. We did absolute conservative treatment for him. We did topical steroids for a short term, around 6 weeks, and cyclosporin, and obviously loads on loads of patients for 1 year. I treated this patient, and the same patient with haze completely gone after 1 year. He also developed some amount of residual refractive error, which I did not touch much. There are some future molecules that are in pipeline and will may be available very soon with us to reduce the haze. So mitomycin C is an effective tool here to reduce the haze in patients with PRK. And obviously, let's limit our surface ablations to around -6 diopters. Then that way, the chances of haze development will be fairly less. So what the factor that we have taken care of is a corneal haze. And what's the answer? The mitomycin C. The second thing, dreadful thing, is the PRK, pain management in PRK. And one of the cause that we tell the patient, ki, when you're going to go home, you are certainly going to have pain. It's there are multiple modalities of reducing pain. There's a list of them. But what we kind of use now is, this was a paper published by Narayan Netralaya group, which says a bandage contact lens soaked in a ketorolac solution, 0.45, which is can be used as pain reducing measure. So earlier, the no financial interest, AccuVail used to come, and it was fairly potent drug. Then AccuVail went off. Now the Entod product has come with a similar efficacy. But what I have done is we have increased the soak time to at least half an hour before the patient is being taken. So as I said, the range of diopter, if we keep it up to -6, we use the mitomycin C, we make sure that the pain management is taken care, then perhaps PRK is certainly biomechanically safest procedure of refractive surgery. I have some quick 2 videos to show, and I've fastened it by around 2.7 times. So it's not very time consuming. This is the one where I am using an alcohol well to remove the epithelium. Care has to be taken that alcohol doesn't spill beyond the well, and it's kept usually for around 20 to 30 seconds, following which alcohol is again taken using a Mirasil sponge. The epithelium easily scrapes off after that. Comes out very nicely, very easily, and then the ablation is performed. This was a time when we never used to have epithelial maps, so I used to stick on to using an alcohol. But if you have an epithelial map, the best answer is doing a transepithelial PRK. Apply mitomycin C in all the patients. 10 seconds per diopter is what the protocol we use, and you'd have to do a copious wash and put the AccuVail or the ketorolac soaked bandage contact lens for pain management. If we are not doing the alcohol assisted, this is the one that I use now because we now have the epithelial map, and we do the transepithelial using the same platform. Just dry up the surface very nicely, and then the PTK also, where you do this particular first step in the PTK mode where the epithelium is removed using the PTK mode, following which you are going to just ablate the corneal stroma using an PRK mode.
Last 1 minute.
Yes, ma'am, I'm finishing, yes. So there are no significant difference in the outcome of single-step transepithelial PRK versus the alcohol-assisted PRK. And also it has been proven by various studies that PRK or the advanced surface ablation are the biomechanically safest modalities. There are some additional roles of surface ablation. We know post-LASIK, post-SMILE enhancement can be done. Post-flap related complication, post-keratoplasty refractive errors, that we can do a PRK extra and TPRK with a C3R as well. So conclusion, surface ablation has a viable role and it's here to stay. And case selection is most important thing. Use of mitomycin C in all the cases, longer topical steroids, and a careful follow-up. Thank you so much for your kind attention, please.
Thank you, all the speakers. We have finished our session within time. So we invite the next session.
my photos, so she wants to take a photo. I
Good afternoon. Now we'll start our next session, that is on facial aesthetics and oculoplasty. Dr. Ashok Kumar, can you come on the dais, please? Colonel Ashok Kumar. Okay. We'll start with Dr. Sonal Yadav. She'll be talking on ocular surface lesions, when to be alarmed. Dr. Sonal. Yeah.
Thank you so much, sir. Thank you for the introduction. Feels good to be back on the podium after a long break. All right. So we are going to go ahead and learn about when to be alarmed regarding any ocular surface lesions after hearing intriguing talks about corneal topography, surface ablations, and all customized LASIK that we all are aware of. Let's move on to some of these rare or not so rare conditions and see how to differentiate them from each other and when to be actually be concerned. So a little quiz, just show of hands, how many are PG students or fellows around here in the hall? All right, great. So everyone is going to tell me regarding these three lesions. What do they feel? When do they want to, which one do they want to observe? Which one do you want to treat? And which one do you want to go ahead and investigate a little bit further to get a final diagnosis? So figure number 1, how many of you want to observe? Just a show of hands. How many of you want to observe? All right. All right. How many of you want to treat the first lesion? Okay. How about the second? How many want to observe? How many want to treat? How many want to investigate further? So what do you want to do about the second one? Yes, ma'am? Observe. All right. And how about the third? Do we want to treat it? Do you want to investigate it further? Investigate further? Very nice. All right. So we are going to go ahead and know why exactly are we going to do that. So yes, I think as we rightly went ahead with the majority, the second one you do want to observe. First one you can go ahead and start treating. And you do want to definitely investigate the third lesion and see what it is about. Talking about ocular surface lesions, so broadly the lesions are epithelial, including both melanocytic as well as non-melanocytic, stromal, which include your vascular, fibrous, histiocytic lesions, caruncular lesions, as well as metastatic or secondary tumors. Let's start with the non-melanocytic epithelial lesions. So I think by now we all know, because of all multiple webinars and multiple explanations. So this is ocular surface squamous neoplasia, the most common primary epithelial neoplastic lesion found on the ocular surface. Can involve both corneal as well as conjunctival cells, epicenter being the limbal cells, never to forget. So morphologically speaking, OSSN can be placoid, either gelatinous, leucoplakic, papilliform, or velvety, as seen in our examples over here, or they can be nodular or diffuse. Surface characteristics: presence of keratin, dilated feeder vessel, intrinsic vascularities, any corneal extension, and positive vital rose bengal or staining can give you a definitive clinical diagnosis of OSSN. ASOCT or high definition OCT, if available, we do now have criteria to differentiate these lesions from their benign lookalikes, which include a thickened epithelium, hyperreflective epithelium, and an abrupt change in transition. Ultrasound biomicroscopy, a very important ancillary test when looking for depth of invasion, can look for angle blunting or increased thickness of uvea. I'm not going to spend too much time on OSSN. defects. So when to be allowed commonly seen lesions, formous papilloma of conjunctiva kind of looks like a papilliform OSSN. But however, why do we need to know that it is not the neoplastic condition? Because if we go ahead and start treating this patient with topical chemotherapy, we might not get the expected results and outcome, because being a papilloma, it is not going to be as reactive as a neoplasia. So these can be taken care of nicely with the help of a wide excision, and histopathology will clear up the diagnosis confusion for you. Similarly, you have pseudoepitheliomatous hyperplasia or actinic keratosis as more commonly seen lesions. These are UV radiation damage to the ocular surface. Here you can definitely miss the prominent dilated feeder vessels as well as the episcleral fixity. These lesions can be safely observed with a scheduled monitoring protocol, and any change or any growth noticed, then you can go ahead and start treating them. How about this limbal lesion? However, every limbal lesion might not be an OSSN, or might not be actinic keratosis, might not be a neoplasia. Look at the other eye of this patient. Look at the overall profile. So this is actually a severe verval keratoconjunctivitis. And the limbal lesions, what we can see are the limbal manifestations of VKC over here. Similarly, in a quaint condition, also a bilateral presentation like this is a limbal manifestation of verval keratoconjunctivitis. So do not suspect OSSN, or do not go ahead and start treating these patients with unnecessary chemotherapy without knowing a proper diagnosis. Some rare cases like this, a 60-year-old gentleman who was being treated for presumed chronic blepharoconjunctivitis for his left eye for almost 1.5 to 2 years without any kind of a relief. But when we did a complete examination, we can see a thickened posterior eyelid margin, loss of eyelashes, loss of marginal architecture. When you go ahead and get a conjunctival map biopsy, this actually turned out to be a pagetoid spread sebaceous cell carcinoma. So while taking care of these ocular surface lesions, be wary of these bulls in sheep's clothing. Looking at melanocytic condition, not all of these conditions are the same. Are these two pictures the same diagnosis histopathologically? Do we have a consensus? Oh, so they are similar in histopathological diagnosis. So these are both the manifestations of a conjunctival melanocytic nevus, defined or ill-defined, but your diagnosis finally is going to come back after a complete histopathological analysis. What helps you making the decision between observe and treat immediately is presence of these cysts, which can be seen morphologically or on OCT. Presence of clear cysts gives you an idea about the benign nature of the disease. However, not all cysts are benign. Any hemorrhage or presence of fluid in those cysts might be an indication of changing nevi or a malignant potential. So be wary of those. So when do we want to excise those nevi? Onset in middle age or later for natural or palpebral conjunctival involvement more than 10 millimeter in basal diameter. Again, the feeder vessels, intrinsic vascularity, absence of intralesional cysts or presence of hemorrhagic cysts. Another commonly seen conditions. This is the primary acquired melanosis, PAM, or the intraepithelial melanocytic neoplasia. These are non-elevated, diffusely pigmented lesions, can be seen unilaterally or bilaterally. Again, needs to be excised when documented progression or any solid distant nodule is present in one of these lesions. Why do we need to be wary of these conditions? Both of these can be the pre-existing conditions for a conjunctival melanoma development. Also, again, be wary about the pigmented OSSN. Not all melanocytic lesions are only melanomas or nevi. Your OSSN can still be pigmented as well.
Dr. Sonal, can you sum up?
Yes, sir. So going on to malignant melanocytic lesions. So these are your conjunctival melanomas. The pigmentation is neither conjunctival nor your corneal. However, this is a surface lesion, but these are the episcleral pigmentation. And if you look at the patient's face, this is actually a oculocutaneous melanocytosis or nevus of ota. And on thorough examination, the patient also has an association of nevus of ota, that is the choroidal melanoma. Going ahead with this picture, sir, just half a minute, I'll summarize. With this picture, so we did, our consensus was to investigate. So on detailed examination, this was actually extrascleral extension of the choroidal melanoma lying underneath. Moving on, we do have a variety of stromal tumors, vascular lesions, most commonly can be treated locally or observed. Only point of alarm would be if any connection with rest of the orbital architecture is seen, like in this condition, the conjunctival lesion is actually an extension of orbital varix. HIV positive patients, Kaposi sarcoma can be a vascular tumor. All right, so going on, so a thorough clinical evaluation usually helps in diagnosing all of these various ocular surface lesions. They can range from benign to pre-malignant to malignant. The management can vary from observation to further investigation to excision and adjuvant therapy. So meticulous examination, full use of all the handy ancillary testing definitely help in picking out an appropriate line of management and optimum outcome. Thank you for your patient listening.
Thank you, Dr. Sonal. That was very good pictorial slides that you showed. Now I invite Dr. Namrata Gaikwad, who will be talking on lid and adnexal pathology, not to be overlooked. Dr. Namrata. I request all the speakers, if you can load your presentation before at that preview counter there, we'll save a lot of time.
Good afternoon, everyone. How do I? Okay, that's fine. So, good afternoon, everyone. All of us as clinicians are very well versed about this algorithm of giving the best to our patients and getting the best favorable outcomes, both clinically and surgically. But in this evolving era of super specialties, definitely it is the need of the hour as well. All of us are moving towards a tunnel vision, maybe any of the super specialties. So I, being a oculoplastic person, thought of jotting down few things that have to be taken into consideration, especially while considering a patient for an intraocular procedure, if it is an elective or an emergency procedure. So to begin with, the very first one, lid infections and inflammations. These obvious squamous ulcerative blepharitis are infective diseases, and these have to be managed very well before we take up a patient for any intraocular procedure. While the chronic meibomian gland dysfunction and meibomitis, yes, you consider them for a conjunctival culture, and then if it comes out to be negative, we can plan under a cover of antibiotics about the intraocular procedure. Acute infections like an internal hordeolum or an external hordeolum, preseptal cellulitis, acute dacryocystitis, and definitely a blepharoconjunctivitis, these are very clear and no one would have a doubt before considering them for a surgery. Yes, with a marked increase in refractive surgeries, the analysis of tear film and dry eye form an integral part of their protocol, because abnormalities in these can hamper the outcomes, the refractive outcomes in those patients. So these should be looked carefully for. Benign masses like these, which are periocular cysts, a cyst of mole, cyst of Zeiss, milia, angry looking comedones, but these are actually benign. These lesions are nevoid lesions and xanthelasmas. Yes, these are not most of the time foci of infection. These are benign, and these can be taken care of later if the patient is actually cosmetically concerned about them, and you can easily go ahead with a planned procedure. Sebaceous horns and lid warts, yes, sometimes they need an excision prior to an intraocular procedure, but then sometimes you can just go for a culture And if it comes out to be negative, you just take up the patient for a surgery. Let malignancies definitely change our protocol to some extent, because if it's not an emergency intraocular procedure, these are angry looking lesions. And here the concentration is not just on doing good for the eye, but then you have to get rid of these lesions, do a proper systemic evaluation, and then accordingly treat the patient in order to save the life of the patient. So that becomes a priority here rather than just doing an elective intraocular procedure. Ptosis, yes, there have been different consensus on this, but most of the patients, they have to be counseled properly. They have to be told that they would be having difficulty in the field of vision, which can be improved after the intraocular procedure. If they would want to go for a ptosis surgery first, that also can be done. Lid malpositions like entropion and ectropion definitely need an early intervention in sense before the surgery, because then the lashes in case of an entropion, they are rubbing onto the surface and they are a constant source of infection. While in case of an ectropion, there's an exposure of the conjunctiva, and again, a needles of infection could be there. So for emergency procedures, we could go for simple everting sutures. While if there's an elective procedure, we could go for a surgery like this. This is a very simple, I hope this please. Very simple surgery for lower lid entropion, a Weiss procedure, wherein after giving local anesthesia, you mark a subtarsal incision, give a full thickness incision there. And then attach, you can see the lower lid retractors, and we attach the lower lid retractors to the inferior border of tarsus with the help of 3 horizontal mattress absorbable sutures. And this gives us a very good correction of the lower lid entropion. Let this wound heal for a duration of almost 15 days to a month, and then you can go ahead with your planned procedure intraocularly. These conditions, ectropion, just as we discussed now, the serious ones like these, this patient, they have to be dealt with a lower lid retractor reinsertion and tightening and shortening procedure, like a lateral tarsus strip procedure. Inadequate lid closure or lag of ophthalmos is also a matter of concern, because then again, the eye is not closed properly. Either you have to tell them if it's an emergency cataract surgery or whatever, you have to tell them how to tape the eye properly post-surgery, or if it is being planned, then yes, you can consider them for some lid closing procedures and then go ahead with your surgery. Acute and chronic canaliculitis, you have to be careful. You have to carefully examine these patients and treat these first before taking them up. Acute dacryocystitis is quite an obvious thing. You have to treat it. But chronic cases, yes, these patients with typical Roplas positive signs, they have to be taken for a SAC surgery, preferably a DCR. Now, in our parent institute, Arvind, we had a standard protocol which we used to follow, the duct evaluation. If the duct was not free with mucoid or mucopurulent regurgitation, or if it was partially free with a mucoid regurgitation, we used to take these patients up for a SAC surgery, DCR or DCT, depending on how early the intraocular procedure has to be done. And if it is not free with clear fluid, we would go for a culture. If the culture comes out to be negative, you would take the patient for a temporary punctal cautery, and the very next day we would post them for a cataract surgery under cover of, or whatever intraocular surgery is there, under cover of antibiotics. While if it is partially free with clear fluid, a culture just would do. And then if it is negative, you can go ahead. If it is positive, you can treat them for a duration of 15 days or so, and then repeat the culture and take them for a procedure. Lacrimal gland masses, yes, the smaller ones like a dacryops are sometimes, missed, but then they are not a direct threat for an intraocular procedure. But yes, wherever needed, they should be taken care of by referral or by doing surgeries. Orbital inflammations like a dacryoadenitis, idiopathic orbital inflammation, thyroid-related orbitopathy, these are quite obvious. And even if these patients have resolved, an important thing to be considered before taking them for an intraocular procedure is these patients require a higher cover of steroids prior and after the procedure, because they tend to have more intraocular inflammation after the procedure. That has to be kept in mind. Ocular surface malignancies, as Dr. Sonal very rightly said, they have to be picked up at the right time. Here, again, the focus is not on the eye, but then treating the aggressive malignancy and directing our treatment towards healing the patient as such and not just the eye. So being little cautious saves a lot of hassle for all of us as a surgeon, and we get the expected outcome of surgery so that we could have a good night's sleep back home, because none of us as clinicians would want to have results like these. Thank you so much. And I would like to thank POS for giving me this opportunity. Thank you.
Thank you, Dr. Namrata. Those tips were very good for comprehensive ophthalmologist, because we all need that. Yeah,
thank you,
good
sir.
presentation. Now I invite our next speaker, Colonel Nitin Vichare, who will be talking about socket problem, diagnosis and management.
Good afternoon, everybody. At the outset, I really thank Pos for giving me this opportunity. Socket has taken a leading role in last few months with the corona and COVID-related mucormycosis. Most of the people have seen rhinoorbital mucormycosis, done the exenteration, done the destructive surgery. But hopefully that is a thing of past, and cosmetic reconstruction of socket will take its place. What I will be talking today is socket problems which generally present to the OPD patients, and most of the ophthalmologists have the inhibition to tackle eruphthalmus, secondary implant, or giving the cosmetic rehabilitation to the patient. I will just touch upon the exenteration such, but mostly I will be speaking about the socket surgery. So cosmetic rehabilitation is the most important and challenging part of the socket management, and it has to be tailored according to every patient. Exenteration and subsequent socket management of COVID-related mucormycosis is another topic, and it is more of a destructive procedure than the cosmetic procedure. What I will talking about with the socket, and mainly the anophthalmic socket, where there is a absence of the globe and ocular tissues from the orbit. Majority of the ophthalmic socket which we see are following the post-trauma, post-enucleation, or post-evisceration. So it can be congenital or acquired, but mostly what we see is post-enucleation and post-traumatic acquired cases. Congenital are truly rare, and maybe because of remnants of the underdeveloped vestigial eye tissue. Here again, we require a orbital implant, and there with the face growth, we require a progressive size increase in size of the orbital implants. So historically, as today, if you see the quiz, the father of ophthalmology, what we say is Bastich, was the one who first recorded the enucleation, which was more of a destructive procedure. The Mule's implant, which are still which we are using, is what is a PMMA spherical implant. There were other semi-buried and integrated or non-integrated implants were there, but procedure of or the choice as per the cost and other thing is concerned is the Mule's implant. We have to have the satisfactory central implant, adequate epithelial line socket, and well-fitted prosthesis. All these factors will enable the good transmission of motility to the overlying prosthesis. So what are the challenges? It is not just the socket which is there is without the eyeball. When you remove the eyeball, or because of the enucleation or visualization, there are multiple things which happen. There is since there is no tissue, eyeball inside, the LPS SR complex drops. There is a appearance of the space between the LPS and orbital roof. All these changes are permanent. So what we have to see is there are the appearance of the space where this because of the lack of the eyeball, and this space causes the formation of the superior sulcus deformity. Along with this, there is a tendency for the inferior rectus to rise. Then the fat also tends to collect inferiorly, and there is a orbital contents undergo progressive atrophic changes. So as you can see in these cases, there is a even if the prosthesis in situ, there is a superior sulcus defect is there. So the main feature in such cases is basically a superior sulcus deformity, enophthalmostosis, and ectropion because of the lower lax tissue. Also, along with the prosthesis which is there, because of the weight, it causes the progressive laxity of the inferior socket. So as you can see in this case, this is the prosthesis which has been used by the lady patient for a long time. So there is a progressive atrophy of the contents, formation of the superior sulcus deformity, and drooping or the dropping of the ocular prosthesis. So basically, there is a subsequent, and all these changes tends to increase over a time. So as you can see that the drop socket appearance causes the ocular prosthesis or artificial prosthesis to tends to tilt backwards and downwards. As in this case, the prosthesis tends to look down. So how are you going to manage this post enucleation socket? So all the changes needs to be reversed or needs to be stopped. So basically orbital volume replacement, along with that lower lid tightening, correction of the shallow fornix, and ptosis correction needs to be done. Adequate orbital implant, for a choice of implant is again the Mule's implant in such cases from my side. You can also go for the integrated implants. But wrapping material use of more of a made for implants are more suitable in such cases. Along with that, if there is a trauma, then orbital floor needs to be repaired so that the prosthesis and the intraocular implant tends to comes into the normal position. As you can see in these cases, we had a post-traumatic. This is the ocular prosthesis in situ, and there is a Mule's implant. However, because of the orbital floor fracture, it is tends to drop down. So there is a how can you augment with the fat injection? And what we generally do is the fat injection from the same taking from the patient rather than going for the synthetic material. So this is the procedure what we generally do. What we have done, taken the with the help of general surgeon, and we have injected to. As you can see, it tends to rise. The implant tends to rise. You have to over inject so that there is about 20 to 30% loss of the fat over a period of time. You can also use synthetic material, but we generally don't advocate because it tends to cause the localized reaction. Then other things like shallow inferior fornix, go for the inferior fornix formation suture. If there is a ptosis, you can do the ptosis correction where you can do the ptosis surgery, LPS plication. Even you can give the sling in such cases. There are you can use for the prosthetic correction where the ptosis shelf. These are in literature, but we are not doing that. We are basically going for the surgical correction for such cases. Problems with the implant, there can be exposure, extrusion, infection, and a late exposure. All these things needs to corrected where the implant needs to be removed. Specifically, it occurs if there's a porous made for implant which is there. So in such patients, you need to clean the socket, remove the implant, extrude the implant, wait for the infection to settle, and then you again go for the secondary orbital implant. My choice is we had few cases with the infection with the made for implant. Mule's implant tends to give the quieten socket. Socket contracture is what we generally get because the patients don't use the artificial prosthesis for a long time. They discontinue. So you need to give that formation of the socket as well as you need to go for the surface reconstruction. I will just show the two photos. Like grade 4 socket contraction, you go for the buccal mucosal grafting. You can go for the multiple graftings in such cases. Also, post blast injury, there is a grade 4 or grade 5 contracted socket. Multiple surgeries can give you some cosmetically acceptable prosthesis retention. In children, as I said, there are cases are rare, but we need to go for the implant which will has to increase in size over a period of time. What are the malignant socket? You generally get the cases closed injury. There are multiple socket reconstruction have been done. You are not able to do much things. Also, post exentation, which we are going to get such cases where the patient is not able to afford a customized prosthesis. We can go for the spectacle mounted prosthesis with the help of the ocularist, or if he is not there, even the dental prosthodontist can help you out. Orbital is just touching. So though it is a surgical excision of the globe and other soft tissues, it's more of a mutilating surgery. We have done cases. So now cases are coming back to us with the socket is now healing. What we are going to plan is either silicone prosthesis or spectacle mounted prosthesis in such cases. So what I wanted to say, take home message is socket, post-traumatic anophthalmic socket. It is not just surgical intervention, but you have to give the cosmetic rehabilitation to the patient because that goes on to increase his confidence to face the world. Thank you.
Very good presentation. Dr. Nitin, I want to ask you, you talked about integrated implants, that is hydroxyapatite implant. Medpore is, I think, one of them. And you also spoke about silicon and PMA. So what is the essential difference of outcome between these two, like integrated implant and a regular implant?
Sir, regular implant, mules implants are cheaper, easy to put. The chances of migration of the mules implant is more, but it gives the better cosmetic result. For Medpore implant, what I have used, it is more of integrated. Vasculation takes place, but pegging is not what we are doing. We are not doing the pegging. So if you are putting the Medpore implant, better to use the covering, or hydroxyapatite, you say the covering, but even Medpore implant, you can put the cover. And those are costlier, and infection tends to be there in such cases. Patient always complains of heaviness and pain. So my choice is Medpore implant. Medpore hydroxyapatite implant.
Yeah, that's right. I also use quite a few of these Medpore, and only thing was with this Medpore, or I'm not talking about any no financial thing, but about hydroxyapatite implants.
Brittle.
They never migrate. You never see them come out, but the chances of exposure was a bit high.
Yes, because of continuous localized infection, the exposure is more. Hydroxyapatite implant do migrate inferiorly, but you can easily manage with the floor implant in such cases.
Otherwise, they are very stable.
Yes.
Secondly, I was worried about the infection part, since they are porous, whether that will attract more infection.
Yes, sir. Even Medpore implant do have more chances of infection than other PMA implant, and basically the pain component is still there with the patient.
So only advantage because we used to also do those customized, I think we used to peg them. We used to drill a hole and put a prosthesis. So that was an advantage. But as you say, the cost was high.
Yes.
And one more thing is you spoke about empty socket syndrome. So basically, what is the role of serial expanders in this?
Serial expanders are there. Even we can inject the fluids in the children. I have not personally used the serial expanders, but what I have done is for a child who had already had a small PMMA ball implant, I have replaced it with the larger size implant.
Right.
So that is more feasible and achievable for any surgeon. There are other implants where you have a tube outside. I have seen it in other big training institute, where you inject the 0.2 ml fluid progressively over a period of 6 months. But then the taking care of such tubes is more very difficult. And again, what I wanted to just point one point is hydroxyapatite implant, though it is done seen everywhere, they are very brittle. If you are don't have the expertise how to handle them, when the moment you open and you try to manipulate, it just breaks in your hand. So you have to have a sclera ready before you try to manage it.
We used to use donor sclera for that.
Yes, donor sclera. We use that only.
Thank you, Dr. Colonel Nitin. It was real good presentation. Now I invite
thank you, sir.
Our own Dr. Ramesh Murthy. He'll be talking on ptosis. Ramesh.
म्यूट करनी है आप वीडियो प्ले करेंगे ना तो मेरा वॉइस कनेक्ट
Ramesh, did you have a word with Dr. Deepak about his?
online. He's online. I message him. He's ready and he's online. आपका ही पहले है ना क्या आपका है ना
डायरेक्ट पेन ड्राइव ने चालू करा. बघू.
Ramesh, with your permission, Ramesh, I think Dr. Deepak is there online.
Thank you, sir, for you inviting me for this meeting. And congratulations to you, sir, and the entire team of POS for holding a physical meeting in spite of the ongoing corona pandemic. So I'll be talking to you about ptosis surgery. So ptosis as such is a big challenge because many cases come in the very young age when evaluation is difficult and they need surgical intervention because of amblyopia. And levator techniques are very difficult to master in the initial stages. So any case of ptosis which comes, we classify it as congenital and the acquired. The congenital could be simple or it could be complicated. Complicated have got some kind of extraocular muscle problems or like double elevator palsy or superactus underaction or sometimes jaw winking, etc. And sometimes there could be other problems like blepharophimosis syndrome. Neurogenic could be cases like third nerve palsy, or they could be myogenic like chronic progressive external ophthalmoplegia, or mechanical like this case of neurofibroma, or the aponeurotic variety seen in the older age group. So the history is very important in these cases. We have to take a history of ocular surgery. So in this picture, you can see that this patient has had previous ocular surgery. So if you do ptosis surgery, the lag of thermos will increase. Whether there's any history of craniofacial surgery, whether there is any history of trauma, which could give rise to third nerve palsy, jaw winking has to be elicited in every child. And we also need to look at complex conditions like capillary hemangiomas or Faces syndrome, which could be associated with third nerve palsy. The most important thing in a child is we want to know whether it is associated with amblyopia, whether there are any other neurological deficits, whether there is any history of allergy. Photographs are the biggest clue for all of us in case of ptosis to understand the nature of the ptosis. So this patient is a patient between 20 to 30 years of age. And in his childhood, maybe when he was 10 to 12 years of age, he had open eyes. And progressively, this ptosis has increased. This is a case of chronic progressive external ophthalmoplegia, where ptosis surgery has to be done with caution. So as regards the examination, we need to look at the patient from a distance, see if there's any chin elevation, whether there's any frontalis overaction, and if the patient is having any head tilt. Visual function is very important. People, again, when we want to look out for third nerve palsy, motility examination again for third nerve palsy. Bell's phenomenon is important because we have to ensure that it has to be good. Otherwise, post ptosis surgery, we could have exposure keratitis. And the amount of lag of ophthalmos has to be known before because this is going to be increasing after the ptosis surgery. And always we need to take photographs. We need to do the eyes test even in a child because myasthenia can occur in both children and adults. The measurements are standard. We look at the vertical fissure height, the margin reflex distance, the margin freeze distance, and the levator action. The levator action is the most important criteria for us, and we classify the ptosis as mild, moderate, or severe depending on the level of the upper eyelid. Severe being about 4 millimeters drop of the eyelid from the limbus. So the levator function is what guides our surgery, and we look at good levator function, which is better than 8 millimeters, and less than 8 millimeters is fair or poor levator function. Always look out for pseudotosis, and we should not get fooled by this. So this patient is having facial nerve palsy on this side, and so this lid appears to be elevated, and this appears to be ptotic, but actually he's got this problem here, which you can see here clearly that he's got a difficulty in lid closure. Hypotropia is a very important feature which we need to look at. So every case of ptosis, one must do the ocular motility evaluation. In ophthalmos will also give rise to appearance of ptosis, and sometimes you have rare circumstances like tumors which can give rise to ptosis. So management. Again, as I said, any patient, any age, always look out for myasthenia. Don't get fooled and go ahead with ptosis surgery. So in a child, when to operate? If there is a risk of amblyopia, we do brow suspension even at 3 months of age. But normally you would like to operate when the child is older if there is no other issues. Because what happens is if you operate earlier, then most likely it will get undercorrected over time, and then you have to go for a repeat surgery. Now, choice of surgery depends on the levator function. If the levator function is poor, then most likely we'll go for a brow suspension, especially if it's less than 4 millimeters or 6 millimeters levator function. But if the levator function is good, we can definitely go for an aponeurotic surgery. If there is severe ptosis, and if there is a mild or moderate ptosis, we can go for a muellerectomy surgery. Our muellerectomy also depends on the response to phenylephrine. So if there is good response to phenylephrine, there is more than 2 millimeters elevation of the lid, we can go for a direct muellerectomy. If there is poor response to phenylephrine, we can go for a levator muscle surgery. Now, fascicular cervical surgery, not personally prefer the surgery because it is physiologically not good, because we are cutting off a portion of the lid, even though it is very predictable, and we can use it to correct ptosis with good levator function with 2 millimeters of ptosis, Horner's syndrome. In such case, we can use it. So we are removing a portion of the tarsus and the conjunctiva. Muellerectomy is a good surgery if there is good response to phenylephrine, there is mild ptosis about 2 millimeters, and there's less chance of lag of ophthalmos. Here, what we do is we invert the lid, we hold the Mueller's muscle in the muellerectomy clamp, and then we pass sutures and remove a segment of the Mueller's muscle. The anter-approach levator repair is a very useful surgery which we most commonly do because we can correct the lid crease problems. We can have symmetrical lid crease. If there's levator disinsertion or aponeurotic ptosis, we can use this. And in this surgery, if it is very good levator function, then we can definitely go for an advancement of the levator. But if there is not so good levator function, it is good, it is fair, then we can go for a large levator resection. So how do we decide how much of the levator to resect? This depends on the amount of levator excursion. That is the levator function that we have measured initially, the appearance of the muscle, whether the horns have been cut, and the lid position on table. So in congenital ptosis, and when the patient is under general anesthesia, we can use the Berkey's criteria for intraoperative lid height adjustment. If the ptosis, the levator function was 7 millimeters initially, we can leave the lid about 2 millimeters below the limbus. If the levator function is very poor, we take the lid much higher. And if the levator function was better than 7 millimeters, we can leave the lid a little bit lower from the limbus. So this is a small video of a levator resection. So what we do is we'll try the video a little later. What we do is we take a skin lid crease incision and go ahead and separate the orbicularis muscle, expose the tarsal plate. This levator muscle is then tagged on sutures, and then it is resected and secured back in a new position. Sometimes we can do an adjustable levator adjustment also. If like this patient had 5 previous surgeries from Nepal, and so we did a adjustable ptosis surgery for him, so he got a good outcome. Sometimes you can also combine a blepharoplasty with the anterior approach levator resection if you want to get a good outcome, as in this particular patient. Now, brow suspension or the sling surgery is performed when there is very poor levator function or in a very small child, where we usually use the autogenous fasciolata or the silicone sling. The fasciolata problem is that it doesn't work because we are going to do 2 surgeries for the patient, so it is not so much in vogue now. We do the sling, which is a very easy surgery and gives very good results, and it's also not having many complications. We try to play the little later. So the material which you can use is in a child, we can use synthetic material like silicone, and in older patient, we can always use a facial atta. But definitely sling with silicone is now the favored material. Now, whether to a unilateral surgery or bilateral surgery, parents are not accepting a bilateral surgery easily. So unilateral may be more acceptable. So we have to involve them in the surgical decision, and then we have to go ahead. And the ideal lid position is one where the child does not need to use the frontalis to elevate the lid. In blepharophimosis, we need to correct the epicanthus and the telecanthus, and then we can go for the ptosis surgery. So here we have done a CU plasty and a YV plasty, or we can also do a transnasal wiring to get rid of the medial problems. In congenital fibrosis syndrome, there are multiple problems, not only ptosis, but also tight muscles. So here it has to be on an individual basis. So we work on the squint first, and then we go ahead for the ptosis surgery. Again, any kind of myogenic ptosis with any kind of extraocular muscle weakness, we go ahead with the squint evaluation, squint surgery first, and then we go for the ptosis surgery. In jaw winking, there is always a big confusion about whether we should do one eye surgery or two eye surgery, whether we should do levator excision or we should do a sling or a levator resection surgery. So we need to do a careful counseling of the patient, the parents, and then we have to go ahead with the decision. Even unilateral surgery will do pretty well in these cases. Third neuropathy, again, a problem of squint first, which has to be tackled, and then only we go for the ptosis. Many times we may not do ptosis surgery if there is Bell's, poor Bell's, and then we go ahead and give them crutch glasses. Again, same in neurogenic ptosis like third nerve palsy. Mechanical ptosis because of a presence of a tumor or a mass on the lid, and this has to be tackled, and this will clear the ptosis. If there is traumatic ptosis, then it is best to go for immediate correction of the ptosis at the time of the primary wound repair, especially if there is aponeurotic involvement. If it is neurogenic, we wait for 6 months for any spontaneous improvement. Thank you.
Ramesh, can you ask Dr. Deepak to join, and can you introduce him, please?
Dr. Deepak, are you online?
Yes, I am. Can you hear me?
Can we get him on the screen, please? So Dr. Deepak Ramesh is a very dynamic and young oculoplastic surgeon who does a lot of cosmetic oculofacial surgery. He has done a lot of work in thyroid eye disease also. He's also at the most prestigious Wills Eye Hospital in the United States. And I have heard his talks many times, and it is a pleasure listening to him. Thank you, Dr. Deepak Ramesh, for joining all the way from US at this odd hour. And we'll be delighted to hear your talk. Thank you. Please start.
Thank you for having me, and it's good to speak with everyone. Hopefully, I can meet more of you in person next year as things go on. I was asked to speak about recent advances in the management of thyroid eye disease, which is a disease that's always kind of close to my heart because of the, not only because of how interesting the pathophysiology is and how much we can change the lives of our patients, but also because of how many changes we have had in the management of thyroid eye disease. So as everyone is familiar, thyroid eye disease is an autoimmune disease of the orbit that's related to autoimmune thyroid hormone disease. So you have the orbital fibroblast at the center, and this orbital fibroblast can grow, it can secrete cytokines, and it can cause adipose tissue growth, muscle growth, and lead to the clinical manifestations that we note, such as proptosis, strabismus, eyelid changes. And as we're learning more about the disease and its underlying molecular biology, now we have specific targeted treatments for thyroid eye disease that can help us be more effective in not only reversing the functional consequences, but also more of the aesthetic consequences of the disease. So I'll spend my time talking today about two areas where we've had large paradigm shifts in how we treat thyroid eye disease patients. The first is in medical management, so the advent of biologics, And secondly, surgical management and how we are focused more on aesthetic indications for surgery and aesthetic techniques in comparison to prior techniques. So there are a few biologics that have been studied for thyroid eye disease. The first was rituximab, and rituximab is a little bit confusing because there were two randomized controlled trials that were published in the same journal, the same issue, one after another, and one showed that rituximab helped thyroid eye disease, and one showed that there was absolutely no difference. So up at the left here, we have the American study from the Mayo Clinic, where they found that rituximab was no better than placebo in treating the clinical activity score. And on the bottom right, we have the European study showing that rituximab was actually indeed better than placebo, or better than methylprednisolone at 24 weeks. So how do we reconcile those two differences? Well, the first thing to understand about thyroid eye disease studies is that a lot of them use clinical activity score as a primary endpoint. And clinical activity score is a composite of how inflamed a patient's eye socket is. It gets scored out of 7, and it includes such things as whether the patient has pain, whether they have pain when they move their eyes, whether they have eyelid redness, conjunctival redness, conjunctival injection, conjunctival chemosis, or eyelid edema, or edema of the caruncle. So if they have one of any of those 7 things, they get 1 point, and the points are all added up. And patients who are red and inflamed and swollen have a high clinical activity score, and patients who have no inflammation have a very low clinical activity score. And as you know, since thyroid eye disease is a somewhat self-limited disease, and over time, patients tend to improve even with no treatment. Patients with no treatment have improvement in clinical activity score as well, which is what you see in the American study. We see that patients who received placebo instead of rituximab still had an improvement of about 3 points in the clinical activity score, which is no different from rituximab. So why does one study show positive results and one study show negative results? Perhaps the inclusion criteria between the two groups differed. The authors suggested that perhaps in Europe, the patients were included earlier on in their onset, and early patients, if you treat them sooner, may have a response, whereas patients who are treated very late in their disease course may not have a response. But there's also something different about how the studies are conducted, because when you superimpose the results of the two studies, you see that even the at the bottom, even the patients who have received placebo are different in the pre-treatment group compared to the patients who received IV methylprednisolone or rituximab. So the numbers don't quite jive, and it's hard to know what to make of these results. But for these reasons, rituximab really hasn't taken off as far as a medical treatment for thyroid eye disease. Tocilizumab, which is an IL-6 inhibitor, just had a randomized controlled trial that was published, and the patients were found to have improvement in the clinical activity score, and they also had some mild improvement in proptosis by about 1.5 millimeters. And these are some of the typical results from the paper that you can see here. The most paradigm shift that we've had is the advent of teprotumumab in the United States, which is an IGF-1 receptor inhibitor, and that really has been a game changer. It's really changed how I practice and how I treat my patients. And this is why. So the IGF-1 receptor here, which is in blue, is co-localized on the cell surface membrane with the TSH receptor, which is here in teal. So the two receptors sit next to each other and they touch on the cell surface of the orbital fibroblast. So the teprotumumab molecule, which is in bright green here, blocks IGF-1 receptor. So even if you have thyroid hormone stimulating TSHR, the IGF-1 receptor is not able to produce cytokines to cause the downstream effects. And again, in this slide, in slide A, green is TSH receptor, red is IGF-1 receptor, and in C, when you superimpose, we see that the IGF-1 receptor and the TSH receptor really live at the same spot on each of the cell surface membranes. So blocking IGF-1 receptor, even though it doesn't have anything to do with thyroid hormone, negates a lot of the downstream effects that we see. And from the randomized trials that we had in the US, where we compared teprotumumab to placebo saline infusions, what we found is that by 6 months of treatment, patients really had a significant improvement, not only in proptosis, but also double vision. So this is paradigm shifting for me because we've never had a treatment, a medical treatment that can improve proptosis on average by about 3 millimeters, which is somewhat equivalent to a single wall orbital decompression. We've also not had a treatment that has had improvement in double vision of over 70% of patients. So, sometimes people have talked about orbital radiation or steroids. Those really don't have a meaningful diplopia response. So for a new thyroid eye disease patient with strabismus, I think it's almost mandatory now for them to be on teprotumumab because there's no other way for me to treat and soften up their extraocular muscles. Now, these are pictures from the study, and we see representatively that at the top we have placebo, and this patient really had no response. In slide B, we have a patient who got teprotumumab, and this patient really had a significant improvement in injection ecchymosis. And at the bottom, we have a coronal MRI where we see that the extraocular muscle size is reduced after teprotumumab treatment, suggesting that this is how the diplopia is better. And if you compare rituximab versus tocilizumab versus teprotumumab, we see that the clinical activity score improves in all of them, really not that much different from each other, suggesting that natural history of disease is for clinical activity score to improve. But proptosis really has a pretty significant change. And this is why I feel like teprotumumab is superior to the others and why it's changed our treatment. Now, these are some of my own patients. The top is pre-treatment. The bottom is just after 2 doses of teprotumumab, 2 out of 8. And we really see that the proptosis is better, injection is better, lid retraction is better. This is a result that would have taken me maybe 2 years to achieve in the pre-teprotumumab world, where I would have had to wait for the patient to become inactive and then do decompression and eyelid surgery. Now, after 2 doses of medicine, which is essentially 6 weeks, we really have a tremendous improvement. This is a patient who had optic neuropathy and corneal decompensation on the right eye, and I performed emergent surgery on the right side. And because of her advanced age, I left the left side alone. But one thing you can see is that the right eye improved after decompression and the neuropathy improved. And then after 4 doses of teprotumumab, we see that not only does the neuropathy improve, but the hypotropia in that eye is actually somewhat better, and the eyelid retraction in that eye is somewhat better. And then the fellow eye, which was not operated, the left side, also has some improvement in proptosis. So this is a very nice treatment so that this patient could avoid decompression surgery on the fellow eye. This is a patient after 4 doses of teprotumumab. We see not only the changes in the eyes themselves, but we also see global changes in the face. We see reduction of the brow fat pads, the lower eyelid fat pads, overall facial edema has reduced, and buccal edema has reduced. Just another patient, a nice result after 8 infusions. And after 1 infusion, even, we can see that the amount of periocular fat has really reduced after teprotumumab infusion. So, I make a big deal about the fat because patients, as some of the other speakers have rightfully mentioned, care not just about the functional consequences of their disease, but also the aesthetic consequences. So the second topic I'll talk about is how surgical management has changed. Now, prior to the 2000s, patients were really only operated on for orbital decompression if they had very severe proptosis. And indications included congestion, exposure, neuropathy, very severe things. But now, cosmetic orbital decompression, where patients either have a little bit of proptosis from thyroid eye disease, or they have proptosis from shallow orbits, high myopia, mid-facial hypoplasia. All of these are, aesthetic indications for orbital decompression, or even to just get the lower eyelid up. Lower eyelid tightening alone in a prominent eye patient will not, achieve elevation of the lower eyelid. So sometimes we have to not only set the eye back, but also move the cheekbone forward to achieve overall facial harmony. Older approaches to decompression include the inframedial, the Ogura-Walsh approach. And this was done because Ogura and Walsh were ENT surgeons. So they did what they did, which is to attack the problem through sinuses. but this has a quite high rate of postoperative diplopia, almost up to 64% in even some cases, which is not acceptable risk for the aesthetic patient. The technique that I reach for 99% of the time was introduced by my mentor, Dr. Goldberg, where we drill out the greater ring of the sphenoid, the deep lateral wall of the orbit, not the anterior wall, but really the deep bone that's axially posterior to the globe. And my own modification where we actually drill it back even until we expose a nice osteotomy overlying the temporal lobe. And this bone is directly behind the eyeball. So rather than moving the eye to the side or down into the sinuses, the deep lateral decompression really moves the eyeball straight back. So we have a powerful improvement in axial proptosis without the risk of double vision. So this is an intraoperative video where I'm, drilling out that greater ring of the sphenoid. And, as you can see here, you can also do a little bit of intracorneal fat reduction, some orbital liposuction, and get improvement in the axial proptosis. And if we do that, again, we have a nice improvement in proptosis with a risk of double vision that's about 1 to 2% now, which is vastly superior to a risk of 30 to 60%, which is in the inframedial approaches. So I strongly feel that the deep lateral approach is much, much safer, especially in the aesthetic patient. So these are some patients who had that type of aesthetic decompression. They have improvement in scleral show, globe position, and corneal exposure. And these are patients who didn't have thyroid eye disease, but they still had proptosis and a negative vector, and improving their globe position with an aesthetic decompression not only improves their appearance, but also improves their lid closure and their ocular surface function. And in the post-teprotumumab era, where patients are already getting proptosis reduction from a medical treatment, the last 1 to 2 millimeters that they need, I can do with surgery, but I can focus not just on trying to push the eye back into the face as much as I can, but I can also focus on facial harmony. So balancing the eyeball and the cheekbone, not only setting the eye back, but bringing the cheek forward either with implants or facial fat transfer. So this patient who had long-standing thyroid eye disease, not only did I do a decompression, but I also did blepharoplasty, and I transferred her abdominal fat to her midface to build that up. And we get a much more harmonious result where the eye and the cheekbone and the eyebrow bone are in alignment sagittally compared to an overhanging eyeball over a shallow cheekbone. And now we can actually look at global facial improvements. So this patient, I performed not only bilateral orbital decompression, but I lifted her brows endoscopically. I took out buccal fat, which also grows in thyroid eye disease, and I transferred that buccal fat to her lower eyelids and midface, and subtracted volume from down here and put the volume back in her midface to kind of give a global aesthetic improvement, as well as a chin implant to improve the anterior projection of the chin. And all of these things really provide overall facial harmony that is much superior to the old techniques of really just trying to get the eyeball back. And you can see in the side profile that on the left, preoperatively, the eyeball is in front of the brow and it's in front of the midface. And on the right, it's really in harmony. It's sitting in an appropriate position just posterior to where the eyebrow and the midface are. And even in younger patients where they have proptosis or they have buccal fat, prominence, facial fat growth due to the disease, doing a decompression not only improves their scleral show and their exposure, but the aesthetic improvements such as the buccal fat that I removed from this patient slimmed the face and reduced the fat overgrowth that has happened as a result of the disease, and overall provides a nicer overall aesthetic improvement that nowadays patients are looking for. So I thank you for your time. I'd love to answer any questions if you have any. Thank you so much for inviting me.
Thank you, Dr. Deepak, for your wonderful talk. I have one question for you. We have come across some patients where the vision is severely impaired in spite of doing endoscopic medial wall decompression, flow decompression, giving them IV steroids, intraorbital steroids. So what would be the next step in these cases? Just one moment, please unmute yourself.
Sorry. Is the vision impairment from optic neuropathy?
Yes, it's optic neuropathy.
Okay. So optic neuropathy that has failed surgical decompression is a tough situation. Now, the orbit is a singular compartment. So just because the patient has optic neuropathy doesn't mean that you need to do an inframedial decompression. You can actually do a lateral decompression or a roof decompression, any decompression to expand the orbital compartment and also improve the the overall volume. So just because the nerve comes from medial doesn't mean you have to attack the problem that way. So if they've already had bony removal all the way back to the anterior face of the sphenoid, as I'm sure you've done if you're doing it endoscopically, sometimes in those medial decompressions, the anterior face of the sphenoid sits in front of where the orbital apex actually is. So sometimes you need to do actually a sphenoid resection, which gets into that, kind of the anterior cavernous sinus area. Alternatively, if you go laterally and you remove the whole greater wing of the sphenoid and expose the temporal lobe, there's a bone called the sagittal crest, which separates the inferior and the superior orbital fissures laterally. And that bone can be removed until you see the cavernous sinus laterally. So both of those areas are places where you can get apical decompression quite posteriorly, really back to the cranial fossa. Apart from that, in the US, I would use teprotumumab. I know it's not available yet in India or overseas, and that's a kind of a safer way that a lot of people can get involved instead of doing more of these aggressive surgical approaches.
Thank you. Thank you.
Thanks, everyone.
To this session, before that, we have to felicitate Colonel Vichare, Dr. Murthy, and Dr. Gaikwad, and Dr. Sonal Yadav. Yeah, please come on the stage. And for the delegates, we have tea served outside. So please have your tea and join back for the next session.
We'll be starting the next session maybe in 5 minutes. So in case if anybody wants to have a quick tea, you can do that.
Hello, good evening everybody. I'm going to start glaucoma update session. I would like to invite chairman of the session, Dr. Subhash Bijlani sir, co-chairman Dr. Satish Kumar Srivastav sir, and Honorable Dr. Medha Prabhu Desai madam. Please come on the stage. Thank you.
Where are the things?
While this is going on, one very small announcement. All the current speakers are going to be here. We know you are thankful to the Pune Ophthalmological Society for inviting you and giving you this opportunity to talk. So don't say all that. Start with your talk, whatever it is, right away, because we are running desperately short of time. So I thank everybody. On behalf of all of you, I'm thanking the POS for giving all of you the opportunity to talk over here. Okay. We'll save a few minutes there. Thank you.
Good evening, everyone. This is an interactive session. So all those who are attending online as well as in physical, I would like to have some few announcements for this session. Can you please put up the slide? Yes, so this is a different session. We will have 3 MCQs. Each faculty will present 3 MCQs and 10 to 15 seconds would be given to answer for each and MCQ for the delegates. Delegates used to send their answers in the format question 1, whatever answer is there, question 2 and 3, that would be A, B, C, D. On the each topic, the numbers are like 976-200-7699. You should just register with this number, or 7758903741. So we would be assessing the answers through this, and name of the delegate with fastest first answer will be announced in the session after each topic, and there are some gifts waiting for you also. So let's start with this. I would like to request Dr. Tejaswini to come first, and
You just please save those 2 numbers on your phone. One belongs to Dr. Nitin Prabhudesai and one belongs to Dr. Bendare. Those 2 phone numbers. Dr. Nitin Prabhudesai and Dr. Bendare, they are here. Those 2 numbers belong to them. If you already have them, save them. Otherwise, we will read them out for you once again. SMS, WhatsApp, preferably SMS. So you have those numbers. Send it to either of the numbers with your ABC, whatever the way Dr. Mehta told you. Yeah.
976-200-7699 is Nitin's number, and Dr. Pankaj. I have not memorized. Okay, so everyone.
Including you, people can also send. Tejaswini, please.
So good evening. We'll start directly with the question. Question number 1. Which of the following factors influence measurement of intraocular pressure? Genetics, anesthetic drugs, tobacco smoking, and all of the above. Your time starts now.
15 seconds for the 3.
Okay, next question. What is the diagnosis? The gonioscopic photo, pigmentary glaucoma, first option. Second option, pseudo-exfoliation glaucoma, angle recession glaucoma, and none of the above. Your time starts now. Coming to third question. Identify gonioscopy finding, iris processes, peripheral antria synechi, pigment clumps, and none of the above.
So now we will start answers and justification for each answer.
Okay, so we'll start with the first question. The first question was, which of the following factor influence measurement of intraocular pressure? And the answer is all of the above. So genetics, how genetics, it was studied that intraocular pressure can be studied as a quantitative trait. According to Blue Mountain Eye Study, a major gene contributed to variants of IOP. Several chromosomes are linked with the intraocular pressure, but no IOP genes have been reported to this date to these chromosomal regions. So genetics is definitely responsible, and it may vary the intraocular pressure measurement. Tobacco smoking causes transient rise in intraocular pressure, possibly through a mechanism of vasoconstriction and elevated episcleral venous pressure. And general anesthesia, we all know that it's usually associated with reduction of intraocular pressure, except ketamine. Ketamine is not associated with reduction in intraocular pressure, and we have to keep in mind that anesthesia-induced alteration of IOP is, we have to keep this in mind in evaluation of infants and children in congenital glaucoma and in patients with ocular trauma and ruptured globe. That this study, Depolarizing muscle relaxants like succinylcholine and suxamethonium causes transient rise in intraocular pressure, and laryngeal mass airway causes less IOP risk compared with tracheal intubation. So this is of clinical importance, and we have to keep this in mind. Coming to question number 2, what is the diagnosis? The diagnosis is pigmentary glaucoma. To justify these large, big arrows, it shows the dense homogeneous pigmentation of trabecular meshwork, which is the characteristic of pigmentary glaucoma. In pseudoexfoliation glaucoma, the pigmentation is irregular. And secondly, there is a heavy pigment accumulation on Schwalbe's line. And pseudoexfoliation glaucoma, we get a white flecks deposited on the trabecular meshwork. And one clue I have given in another photograph, this is a Zenta-Meyer line, which is also called as a sheath stripe, which is a pigmented line on posterior lens capsule on insertion of zonules. And it is also one of the characteristic of a pigmentary glaucoma. So the answer is pigmentary glaucoma. Coming to third question, identify the gonioscopic finding. These are peripheral anterior synecdoche. The explanation is, if we compare the peripheral anterior synecdoche and iris processes, PAs are broad, iris processes are fine. Peripheral anterior synecdoche extend beyond the scleral spur, iris processes extend into the scleral spur. Pars obscures the view, iris processes underlying structures are seen. Peripheral anterior synecdoche reduces the movement, iris processes moves with the indentation, and peripheral anterior synecdoche breach the concavity of recess, iris processes broken with angle recession. And one more thing we have to remember, high peripheral anterior synecdoche are the characteristic of a iridocorneal endothelial syndrome. These extends beyond the Schwalbe's line. Thank you. Answer we have, winner we have to announce. Okay. Winner is Dr. Sachin Bodle. Congratulations.
Stay on till the end of it, and you'll get some award at the end of it. Okay, now Rupali, can you please come up? Thank you, Dr. Tejaswini.
Sure.
It is a mask. Tejaswini.
Same method, same procedure, different speaker, same numbers.
So, I'll read out the first set of questions. Where is a 10-degree field useful? To determine which patients are at a highest risk of visual impairment in early to moderate glaucoma. To better monitor progression in advanced glaucoma. To determine if there's a fixation threat, or all of the above. Your time starts now. Let's go on to the next question. Which of the fields shown here is most likely to be glaucomatous? Next question. What progression definitely requires escalation of treatment? And we are talking about perimetric progression in terms of decibels per year. Any progression at all? Progression of 0.5 decibels per year, progression of 0.5 to 1 decibel per year, or 1.5 to 2 decibels per year. Time starts. Okay, let's go on to the answers. So the first question was 10-2. It is all of the above. So the 10-degree field nowadays is done along with the 30-degree or the 24-degree field in practically any person who has a perimetric glaucoma, because the test in 10 degrees is usually 2 points apart. Two points are separated by a 2-degree field, while in 30-2 it is 6 degrees apart. So that means a closer mapping of the central 10 degrees is done. And this is useful because smaller defects can be picked up here. Also, defect which is closer to fixation is more likely to be progressive. Therefore, it is important to pick these up and to find out if there is a progression also. If it is happening, you are detecting a closer area, you're likely to pick up progression earlier than if you're looking at a less or a more sparse area. The 10-degree field equivalent, if you look at it, any point in the four points closest to the fixation, if any of them are affected with a sensitivity of 0 or less than 10 also, a fixation split or a threat is defined. The second, the answer is D again. So the first has abnormal points in the superior arcuate area, but typically they run more on the periphery. So the superior peripheral field has less sensitivity. It could be because of a recessed eyelid, because of a droopy eyelid. It could be because of a prominent brow. And therefore, unless and until it is mainly involving the arcuate area, we tend not to give it as much importance. The second is a well-defined uniform constriction, more likely to be retinitis pigmentosa or similar. The third, the inferior edge is probably a edge artifact because of a thick lens rim or when the patient has tilted back during the test. The fourth follows what is the classical arcuate pattern and therefore is most likely to be glaucomatous. The third is also D. So any progression does not merit treatment. If it's really a glaucoma, most of the glaucomas will eventually progress. A progression of 0.5 to 1 decibel per year is a relatively slow progression, and you can modify the same line of treatment rather than escalating it. But a progression of more than 2 decibels per year is a fast progressor and needs urgent and escalation of treatment. So if you're using medicines, you might want to go on to surgery to prevent severe irreversible visual loss. Thank you. Okay. Winner for this round is Sachin Bodle as well.
Sachin, did you meet these people earlier? Thank you, Rupali. Thank you very much. Our set of questions is going to be on ONH and imaging.
Good evening, everyone, and I'll go to my set of questions. This is based on optic nerve head and imaging. So my first question is the optic nerve head shown over here is glaucomatous because the disc is large and therefore proportionately the cup disc ratio should have been small. This mandates glaucoma workup as the cup disc ratio is more than 0.5:1 ratio, and this needs evaluation owing to presence of a notch. D, pallor is out of proportion to the cupping. Your time starts now. So my second question is, this optical coherence tomography image of the suspicious optic nerve head shows advanced glaucoma with distorted ISNT rule and severe RNFL loss, inferior, superior, inferior nasal areas in the right eye, and in the left eye, superior, inferior areas. I don't have a corresponding optic nerve head image over there. The second option is myopia, myopic ONH with red disease, the myopic ONH with tilted optic nerve head, and option D is myopic optic nerve head with peripapillary atrophy, zone beta. Your time starts now. So we go to the last question. This is based on the imaging. Anterior segment OCT is useful in glaucoma to study. Option A, mechanism of angle closure disease, thickened or rolled iris, plateau iris configuration. B is quantitatively, I'm sorry about the numbering. B is quantitatively, it measures the angle opening distance. C is to detect cyclodialysis cleft as angle pathology. D is all of the above. The time starts now. Yeah, there's a lettering mistake. I mentioned that. Yeah. So we come to the answers. So my question number one was this optic nerve head deserves a glaucomatous evaluation, because of which options it deserves an evaluation because of the presence of a notch. And as you can see from the photograph very clearly, there is a corresponding to the notch, there is also an RNFL defect, which I marked out with the black arrows on the right side. On the left side, you can see that there is a disc hemorrhage. So always compare the two eyes, look at the disc size. So when you evaluate an optic disc, always go to the other side, look for symmetry. And when you look for the disc overall, look at its shape, size, and margins. The second thing is when you evaluate the neuroretinal rim, always look for the cup size, the contour, and the color of the rim. And lastly, go on to the peripapillary areas and the RNFL defect. In this way, you will not miss out on the basic evaluation of the optic nerve head. So over here, you compare the two heads. Shape should be oval or round. Contour of the disc, contour of the rim, color of the rim. The pallor should be in proportion to the cupping in glaucoma. In non-glaucomatous findings, it is always out of proportion to the cupping and disc hemorrhages. So my question number 2 was optic coherence tomography image of a suspicious ONH, which was the option over here is myopic optic nerve head with red disease. We should be aware of, if you look at the optic nerve head shown in the photograph, clinical picture of it, the neuroretinal rim is very normal, it is healthy, and it shows some peripapillary changes. These are all, the rest of the option all gives you clinical findings, whereas the red disease is typically an artifact picked up by optic coherence tomography. So not just the imaging features, one should always be aware of what are the drawbacks or what are the artifacts which any imaging tells you. And one should always evaluate any optic nerve head. Any imaging should be reported along with the clinical findings, not in isolation. So my last question was regarding ASOCT. In ASOCT is useful in glaucoma to study mechanism of angle closure disease. Lot of studies being done in vivo studies in dark and in dim light. And they have found out different mechanism of angle closure. We are only aware of pupillary block. They have found that in certain patients, the iris thickness is a lot and it rolls up and blocks the iris. In certain others, the angle morphology is such that the thickened rolled iris, though it is very close to the Schwab's, there is difference between the area of Schlemm's canal and the thickness of the iris. Quantitatively, it also measures angle opening distance, and other quantitative measures can be done to detect cyclodialysis cleft. It is always not possible to clinically evaluate gonioscopy because in cyclodialysis cleft, you will get soft eyes and you'll not be able to visualize the cyclodialysis cleft directly. So in this question, all of the above is the answer. So the first picture over here, marked in red, shows the angle studied for angle closure. On your right-hand side, it shows the plateau iris, the double hump feature. The middle picture with all the values shows the angle measurements done using the ASOCT. And the last picture, which I showed on the question, was a cyclodialysis cleft. And this is a clinical picture of the cyclodialysis cleft. Not very often are you able to successfully do a gonioscopy in a hypotenuse eye. So thank you very much for the patient hearing. And this session's winner is Dr. Devashri. Congratulations and thank you.
Thank you, ma'am. Now I call upon Dr. Kalyani, ma'am, for the medical management aspect of glaucoma. She is going to deal with.
My first question is, 3-year-old male child brought by the parents to the OPD with the concerns of enlarged eyes with tearing. With the tearing and intolerance to the light, and was diagnosed to have a ophthalmia with IOP of 26 in the right eye and 28 in the left eye. The child is planned for the filtering surgery. Before the surgery, to control the IOP, which medication has a poor safety profile? Yeah. So dorzolamide, brimonidine, latoprost, and timolol. Your time starts now. The second question is, a patient was started on the anti-glaucoma medication elsewhere and presented to the OPD with this complication. Yeah. Which of the following anti-glaucoma medication caused this complication? Latanoprost, netasudil, brimonidine, and pilocarpine. The time starts now. Question number 3 is, 46-year-old male with a chronic history of diabetic macular edema developed corneal edema after the cataract surgery. The IOP is 26 millimeters of mercury. Patient is on eye drops, brimonidine and timolol. What will be the additional drug of choice to lower the IOP in this patient? Netasudil, travoprost, ripasudil, and dorzolamide. Your time starts now. The first answer is brimonidine. The brimonidine is relatively selective alpha agonist, which reduces the intraocular pressure by decreasing the aqueous production and increasing uveous scleral outflow. It passes through the blood-brain barrier, potentially causes CNS toxicity. They have the reports of bradycardia, hypotension, hypothermia, hypotonia, and apnea in the infants after the topical brimonidine usage. So the weight and age of the child are more important factors to give the brimonidine in, because it causes excessive sleep and lethargy. The safest drug what you can choose in the children is carbonic anhydrase inhibitors and the beta blockers. Relatively, they are safer in the children. The second question, the answer is the corneal verticillata. It is also called as vortex keratopathy. There is a pattern of golden brown or a gray opacities in the cornea. These are commonly located in the basal epithelium of the cornea. In the inferior paracentral region, they are non-elevated, so not much of the visual impairment is seen in those patients. Some of the systemic drugs which can cause this complication also we should know. Chloroquine, hydroxychloroquine, amiodarone, endomethasone. The answer for the third question is repasudil. It is a selective Rho kinase inhibitor. It is approved. It is approved in the, for the treatment of ocular hypertension and open-angle glaucoma. It acts by inhibiting the inhibitors increases the blood flow by vascular smooth muscle relaxation, and also it has the neuroprotective action, and it directly acts on the trabecular meshwork by reducing the contractile tone of the trabecular meshwork, and also it decreases the deposition in the trabecular meshwork. It also decreases the oxidative stress and prolongs the RGC survival. The baseline IOP reduction with this drug is 37.5%.
Yes, thank you, ma'am.
Thank you.
We have the new winner this time, and she is Dr. Amrapali Bobde. Where are you? Just stand up. Congratulations.
Hello. Now I would like to invite Dr. Pankaj Bendale for his talk on an MCQ on lasers in glaucoma.
His MCQs are on lasers in glaucoma. Afterwards, Dr. Vidya, your MCQs will be on
lasers in glaucoma. So my first question is, most important thing for successful YAG iridotomy is: one, finding a good crypt; two, prior pilocarpine 2% application; C, optimum laser energy between 2 to 5 millijoule; all of the above. Now, the second question is SLT. Yeah, the second question is SLT is indicated as a primary therapy, as add-on when single medication is not sufficient; C, when surgery has failed to achieve target IOP; and D, all of the above. Yeah, and third question is mechanism with which YAG-PI lowers the IOP: decrease aqueous production, increase TM outflow, pupillary block by just creating a communication in anterior and posterior chamber and avoiding peripheral iridocorneal contact, and thereby indirectly increasing TM outflow, and D, increasing uvascular outflow. Yes. So here is the first question. All of us, we do the iridotomy, and doing successful iridotomy requires finding a very good crypt which is in the periphery where the iris thickness is least, and we require much less energy. So finding a good crypt is the first case. In fact, whenever we advise YAG-PI, we always look at the slit lamp, where are good crypts between 10 to 2 o'clock location, which are the ideal location for doing the YAG-PI. Pilocarpine is the eye prior 2%. In fact, apply the drop 3 to 4 times half an hour prior. That makes eyes, this pupil very nicely pilocarpinized, tight iris, which requires very less energy to do the YAG-PI. And immediately go on increasing the energy if thick iris is found. Because if you keep giving low energy burn at same spot, no, there is inflammation and then you can't penetrate. In fact, good side also get wasted. So as you give the first energy burn and you find there is no reaction on the iris, then go on increasing the energy to the sufficient level where with the minimum shots you can achieve the penetration. Otherwise, with the multiple low energy burns, that side get wasted. So always find the optimum energy. As soon as you give the first burn, you understand this is a thin iris or thick iris, and give the optimum energy. You can step up by 1 millijoule to go to the best energy level to penetrate that iris. Give the repeated burn at the same location. That's how then one good side doesn't get wasted. Otherwise, there is a lot of chairing, and then sometimes you can't penetrate at that location and you have to abandon that site, or maybe you have to do then follow up at the next visit if there are too thick iris and you can't achieve the good penetration. So doing a good PI requires all these things, where find good crypts, pilocarpinize prior, use optimum energy. That will give you a quick and good peripheral iridotomy, and then you can achieve the good success there. Yeah, SLT is very effective when used as a primary. That is one good thing, but it can be used add-on in multiple situations where single drug is not sufficiently controlling the IOP. Patient has a problem in putting the morning dosage of medications. Working patients, when morning doses get missed, someone who has undergone surgery but still target IOP is not achieved. In all this situation, you can use SLT as an add-on thing. And that makes medical management more comfortable for the patient. And that's what we talk about when we say quality of life with the disease. So if you just give one medication plus SLT, that also controls target IOP very well. So SLT fits into various location, various situations where it can be used as a primary therapy also, as an add-on when the nighttime HS medication like PG analog is not sufficiently controlling the IOP, or as an add-on after surgery also to again achieve additional 3 to 4 millimeter of mercury. That makes a big difference even in the advanced glaucomas also. And now the last question, how the PI works. Now, many times people try and attempt the PI despite its open angle, and they feel as if PI is IOP lowering procedure. No, peripheral iridotomy is not a directly IOP lowering procedure like trabeculectomy. It just communicates between anterior and posterior chamber. It reduces the relative pupillary block, or sometimes when the pupillary block is there because of vitreous or something. So what the PI does, if PI just does one thing, to give aqueous access to the trabecular meshwork. PI will be very effective when TM is functional. If TM is dysfunctional, if TM is under functioning, then despite good PI, you will not achieve the good IOP reduction. So peripheral iridotomy is not a directly IOP lowering procedures like trabeculectomy. It just communicates between posterior and anterior chamber. It gives access to aqueous to reach to the trabecular meshwork. Obviously, it will give more effect if TM is healthy, and it will give much less effect if TM is grossly under functioning or having any other issues like cynical closures or trabecular sclerosis, or it is not functional. So many times I have seen the open angle patients that still someone attempts PI to control the IOP as if it is IOP lowering procedures. No, it has a role only when there is a relative pupillary block, only when it has the issues like aqueous is not reaching up to TM, and it will give more effect if TM is healthy, and it will give less effect if TM is not healthy. Thank you.
Thank you. Thank you to Pankaj. Thank you very much. Easy set of questions, I think, like, because even we answered them correctly, and Sagar answered immediately. So I would give the questions to him, but since his phone is locked, just give us a minute and we'll announce the winner. And in the meanwhile, oh, she's already here, Vidya.
Sorry.
Surgical management. Thank you so much.
Good evening, everyone. Yeah. So my questions are on the surgical management of glaucoma. My first question is, a 65-year-old male patient with advanced primary open angle glaucoma undergoes a uncomplicated trabeculectomy. On the first post-operative day, it is seen that the pressure is very low, 4 millimeters of mercury. Patient has this kind of a slit lamp appearance, where you can see the anterior chamber is uniformly shallow. The bleb is also noted to be flat. The retina and choroid are normal in appearance. So what is the most likely diagnosis in this situation? Malignant glaucoma, excessive filtration, choroidal detachment, and bleb leak. So your time starts now. So moving on to the second question. Again, following an uneventful trabeculectomy, this patient complains of severe diminution of vision in the next 2 to 3 days. On examination, the bleb is well formed and elevated, but the intraocular pressure is again low at 2 millimeters of mercury. There was no, patient did not have any pain. Fundus examination revealed the following finding, as you see in the picture there. So what is the most likely diagnosis? Malignant glaucoma, post-operative retinal detachment, choroidal detachment, endophthalmitis. Your time starts now. The third question. A 1-month-old baby presented to our department. The mother complained that the baby does not open the eyes, avoids light. There is constant watering, but there is no discharge. So what is the most likely diagnosis and the treatment plan? Neonatal conjunctivitis and treatment with antibiotics. Congenital glaucoma, treatment with goniotomy. Congenital glaucoma, treatment with trabeculotomy and trabeculectomy. And congenital nasolacrimal duct blockage, treatment with syringing and probing. Your time starts now.
Okay, the answers now. So the first question, the answer would be a wound leak or a bleb leak. And the test which will help us to know this is the Seidels test. So this is a wound leak is a common complication of trabeculectomy, especially seen on the first or second postoperative day, actually very early in the postoperative period. So this may occur because of some conjunctival trauma during surgery or due to loose sutures and then on a post conjunctiva. And it can be diagnosed, as I just said, with the help of a Seidels test, wherein you put fluorescein into the conjunctival cul-de-sac and observe under the blue light where you can see the aqueous trickling down from the wound. So the treatment involves usually conservative management will help, and it involves giving a pressure patch, and in very severe cases only a bandage contact lens is required. If it does not, usually it improves in 1 or 2 days. If it does not improve, we can observe up to 72 hours and then think of resuturing or repairing the wound. The second question here, post-operatively low intraocular pressure in this kind of fundus appearance, and the B scan also is showing the diagnosis. The answer is choroidal detachment. So when the pressure falls down to very, very low levels following trabeculectomy, sometimes it is seen these patients develop choroidal detachment. This further aggravates, the patient continues to have a hypotony again, and usually it resolves on its own. It is again treated with the help of oral steroids, and just the steroids or even topical steroids are continued. And usually it improves in 3 to 4 days. But if it does not improve after a week also, then it is wise to drain this choroidal detachment through an external approach. The third question, the answer would be a congenital glaucoma, and the treatment would be with the trabeculotomy and trabeculectomy. Here, because there is a constant watering, it is also possible that it could have be just an infection, but infection can be seen, and the discharge and the other things, the clinical appearance can give us a clue. Excessive watering, blepharospasm, photophobia are the classic triad seen in congenital glaucoma. In this case, goniotomy is not possible because of a hazy cornea. So hence the procedure of choice would be trabeculotomy and trabeculectomy. And one thing to remember is congenital glaucoma is a surgical disease. So it is prudent to perform surgery as early as possible, as soon as the child is fit for general anesthesia. Thank you. Now the winner is...
Thank you, ma'am. Thank you, Vidya ma'am.
Thank you.
For results, MCQ, lasers in glaucoma, Dr. Sashi Prasad. And then for this one, which was MCQ recently, Dr. Mukesh and Dr. Mandar.
Morning quiz winner. For the last session, for the last set of MCQs, Medha is already here. Medha, the recent advances.
Yeah, I'll be talking on recent advances, and there are interesting MCQs on this. You see, yeah. So what is this analysis called? The first answer is anatomic position shifting APS analysis. The second is RNFL and ONH analysis. The third is Hood's report with maculocentric analysis. And the fourth is forum structure function analysis. Your time starts now. The second question, which procedure is done for this patient? Zen gel implant, intracameral drug implant, eye stent, or hydrous microstent? Your time starts now. Third question, ROCK inhibitors decrease intraocular pressure by decreasing episcleral venous pressure, relaxation of trabecular meshwork muscles, norepinephrine transport inhibition, and all of the above. Your time starts now. Okay. So the answer for the first question is Hood's report with maculocentric analysis. So this is anatomic position system on your left side. This is ONH RNFL analysis, and this is structure function analysis here. So what is maculocentric Hood analysis? This is a Hood report given by Topcon, Sweatsource, OCT, Triton, and also Heidelberg Spectralis. This is an improvement over OCT analysis till now. So we get a single field cube, which is a wide scan, and after that this scan is produced, or this report is produced, where you get a derived circular scan, and here the visual field points are superimposed on the probability plot. So you know where in the visual field you would be getting the defects in the perimetry. So this helps us to determine whether the defect is actually because of the RNFL, that is glaucoma, or not. So this is displayed as NSTIN and not as a TISNIT map. So because central 50% of RGC is also important. So this is a TISNIT map which we were getting, and this is a nestin, what we call. So this is nasal to nasal. So the macular fibers are given more importance, which helps us in identifying the glaucoma at a very early stage. So this is one patient where you can have a nasal thinning, and even in 10-2, you can see that the pattern standard deviation is showing some defects. So you can diagnose or at least monitor these patients at an early phase. The question number 2 is which procedure is done for this patient? And the answer is intracameral drug implant. So this is these are all other choices: gel implant, eye stent, and hydrous microstent. So this is a Durista implant which is designed by Allergan. This has a pellet which is sustained release drug is there, and it is indicated to reduce pressures in POAG and OHT. It is a sterile implant. This is of bimatoprost. This is a single-use implant, and a biodegradable pellet is there which releases 10 micrograms of bimatoprost into the eye over 4 months. The IOP reduction is very good. In up to 1 year, there is 40% reduction, and up to 2 years, almost 28% patients didn't need any additional treatment. The third question is ROCK inhibitors decrease IOP by. So the answer is all of the above. We know all the mechanisms which ROCK pathways have, and they decrease the aqueous humor outflow resistance by altering the cellular components of the trabecular meshwork and Schlemm's canal. There is a relaxation of trabecular meshwork which increases the aqueous outflow, and this decreases intraocular pressure. Also, there is NET inhibition which causes vasoconstriction, which reduces the blood flow to the ciliary body, and there is decreased formation of the aqueous. They also lower episcleral venous pressure significantly and increase the trabecular outflow by 35%, and they decrease EVP by almost 10%. So there are some additional benefits also, like neuroprotection, increase ocular blood flow. They also preserve corneal endothelium and protective effect in even diabetic retinopathy and macular edema. So these were today's questions. Thank you for being here with us and attending this interactive session. Thank you all.
Thank you, Dr. Mehta. For Dr. Mehta Prabhu Desai's MCQs, the winner is Dr. Amrapali Bobade. Once more. Huh? Yeah, I know.
Okay, so we have a pre-recorded talk of Dr. Arvind Nilkantan, who was my colleague and now he's practicing in Texas. He is a very good friend of me, and we keep meeting at various conferences, and he has given us a prestigious volume. Yeah, yeah, no, volume of this. Volume. Okay. And he does various sorts of, like what we don't have in India, like various eye stents and even trabeculectomy surgeries. So he is giving us a talk on new horizons in glaucoma surgery, which would be very useful in our practice in the future.
Hello, good evening. Actually, good afternoon from Dallas, Texas. I would like to thank Medha Prabhudesai for inviting me to speak at the Pune Ophthalmic Society meeting. It's my pleasure to be here today to speak to you. So my talk is based on newer surgical procedures for glaucoma. Over the past several years, there are multiple choices when you consider surgery for a glaucoma patient. I'd like to divide them into three categories. One is where you can take the patient's own drainage system and try to improve that, versus creating a bypass drainage system, versus trying to decrease the amount of aqueous production so as to balance out the intraocular pressure. When you try to improve the existing drainage system, that group of surgeries has now been called MIGS, or minimally invasive glaucoma surgery. They're essentially divided into two categories again, wherein you could have an indwelling device placed into the trabecular meshwork versus a trabecular meshwork stripping procedure. When you come into creating a new drainage system, essentially you're bypassing the trabecular meshwork and transferring the fluid from the anterior chamber into the subconjunctival space. Now, we've been doing this for many, many years with trabeculectomies and glaucoma drainage tube implants. Of late, there have been some technological advances, and there are two products in the market that may help us to do that. One is a Zen gel stent, the 45 micron, and the PreserFlow, the microshunt, which is currently not FDA approved in the United States, but it's available in Europe. Both these are flow control devices so as to avoid hypotony and still conduct the aqueous into the subconjunctival system. We can also decrease the aqueous production. We have an internal cyclophotocoagulation probe internally, or you can do it externally transscleral with a continuous diode laser with the G probe, or more recently, the micropulse diode laser. So as I said, three major outflow targets for mixed procedures, essentially the Schlemm's canal, the iStent inject, the hydrus, and you have the trabecular meshwork stripping procedures, which include the trabectome, the Cook dual blade goniotomy, the gonioscopy-assisted transnumeral trabeculotomy, which was invented in Dallas with a cat. You can viscodilate the Schlemm's canal called ab interno canaloplasty, and also the Omni device so as to strip the trabecular meshwork for 180 degrees. The supraciliar space has been explored. The CyPass implant by Alcon was unfortunately recalled a few years ago due to problems with endothelial decompensation, or at least concerns for endothelial decompensation in about 5 years. The iStent Supra by Glaukos is currently awaiting FDA approval, and it sits in the same space, the supraciliary space. When you get into the subconjunctival space, we'd already talked about the Zen and the PreserFlow. I like to refer to the subconjunctival space procedures as less invasive glaucoma surgery rather than minimally invasive glaucoma surgery, given that you have to use a fair amount of mitomycin C to get these procedures to work well long-term, and that comes with its own caveat and side effects of long-term use of mitomycin. So we've known for many, many years the Schlemm canal empties in about 30 collected channels, and then into the scleral plexus, the episcleral plexus, conjunctival plexus, and the aqueous veins of Astor. And you can see this beautiful neoprene cast by Ashton from the 1950s. And there seems to be an increased presence of the collector channels within the nasal anterior chamber angle. What we're lacking right now is a reliable method to evaluate these collector channels downstream. So if you open up the trabecular meshwork and let the aqueous access the collector channels directly, which is what these mixed procedures are doing, some of them don't work sometimes, and you wonder why. And the reason being, we really don't know what the status of the collector channels is, what is the status of the conjunctival plexus, the aqueous veins is. Maybe there's a blockage down there. So we really don't have a reliable method of imaging the collector channel system currently, and that's a limitation to the mixed procedures. So why consider mix, right? So we all know trabeculectomy, we've been doing it for 50 odd years. We know the pros and cons. It's the only surgery that really works well long-term to control intraocular pressure in the low teens to help patients. But not all patients need pressures in the low teens. There are some patients who do really well with the pressure in the mid-teens. So the question is, why subject them to the risk of long-term mitomycin blebs like endophthalmitis, bleb leaks, et cetera, et cetera, et cetera. So these procedures seem to work well with phacoemulsification through the same incision. And again, if this procedure fails, the conjunctiva is intact to perform more aggressive filtration surgery. So my first thing I'm going to talk about is the Glaukos iStent. The first generation stent was a snorkel made of titanium, implanted ab interno into Schlemm's canal. When you implant these procedures in the Schlemm's canal, you use a modified Swan-Jacob gonioscopic lens, as you will see in some of the videos down the road. In the first paper that came out comparing the iStent alone, iStent with cataract alone to cataract by itself, clearly the stent plus cataract group came out way better than the cataract no group, both in terms of reducing intraocular pressure under 21 millimeters of mercury and reducing intraocular pressure of more than 20% from baseline. To me, the take-home message from this that was surprising was, even with phaco alone, over 50% of patients had a reduction in intraocular pressure. Going on to 2 years, it still seems to maintain the intraocular pressure lowering, whereas in the iStent and cataract group seems to do better than the cataract alone group. Multiple trabecular bypass stents seem to lower the pressure even more, as some data from the Canadian group suggest. And maybe we can implant multiple stents to actually get pressures in the lower teens for some of our advanced glaucoma patients. With this in mind, the next generation of iStents, or the iStent Inject, was born, which are essentially titanium collar studs, which are implanted into trabecular meshwork approximately 2 clock hours apart. Down below, here's the introducer with a button which you press when you deliver the iStent. So the iStents are targeted delivery to the aqueous veins, theoretically should target lower IOP at or near episcleral venous pressure. You got to look for areas of focal blood reflex or increased segmental TM pigmentation. And ideally, you want to space the two iStents approximately 2 clock hours apart. The iStent Inject, you approach the tissue perpendicularly, you penetrate the tissue with the trocar, lightly press on and deliver. And these are 2 beautifully placed iStent Injects, as you can see. Here's a video demonstrating that. The patient's head is towards the other shoulder, the microscope angle towards myself. That's a Swan-Jacob gonioscopic lens providing a direct view into the angle, nice pigmented meshwork, giving you good access. That's the trocar and the cannula, perpendicular access, a little dimple into the trabecular meshwork, and then I press down on the button and I release the button very gently. And you'll see in a little bit, there's going to be a plume of blood that comes down like reflex blood. And there it goes. That's the plume of reflex blood. Okay, and then I shift my gaze to another location to inject the second stent. And I'm going to fast forward this for lack of time. And you can see right there, there's a dimpling and a release. And there the stent is nicely placed. You can use a little bit more Healon to clear it up and visualize the stent properly. The next thing I'm going to talk about is the Hydrus microstent made of nitinol. It's a flexible nickel titanium alloy. It's 8 millimeters long. It's again designed to be implanted ab interno and is a trimodal mechanism of action. 1, it bypasses Schlemm's trabecular meshwork directly into Schlemm's canal. 2, it dilates Schlemm's canal because of the size. And 3, it covers nearly 90% of the trabecular meshwork or the Schlemm's canal, thereby covering greater number of collector channels and thereby causing greater reduction in intraocular pressure. In a randomized controlled study comparing phaco alone to phaco plus Hydrus in patients with mild to moderate glaucoma, there was a superior reduction of intraocular pressure with Hydrus at the end of 24 months. And as you can see here, the blue bars are the phaco Hydrus, the gray bars are phaco alone. And again, in terms of percentage reduction in intraocular pressure, as well as the mean change in IOP in both groups, the phaco plus Hydrus stent comes out superior. This is the video of the Hydrus courtesy of Ike Ahmed. I'm going to let it run.
The Hydrus microstent is implanted into the eye using an ab internal clear corneal approach. The incision is made to the right to allow for the curvature of the cannula, which you can see is uniquely curved to follow the curvature of the angle as you see in its position. The distal tip of the cannula is used to incise the inner wall initially. Only about 100 microns of that distal tip will actually enter the canal. You'll see that there is some torquing of the eye, which is expected, some positive pressure onto the canal to allow penetration. But once this occurs, we will relax our hand slightly and advance the roller wheel to place the device into the canal. Notice how the device is slightly placed in an upward fashion to ensure we have adequate passage. And at this point now, we relax our hand, releasing the tension against the outer wall and allowing the implant to be smoothly directed into the canal. The site interlock releases the inlet from the implantation device, and the cannula is then withdrawn. And we'll now take a look and see the device in its position here as you see the inlet to the right and the 3 windows to the left. There's normal blood reflux in this case. In fact, it actually helped us to visualize the canal position prior to implantation. And we will now evaluate the position of the device using a Sinsky hook just to manipulate the eye. Notice as the Hydrus microstent.
So that's a really well-placed Hydrus, as you can see out there. So this is another study comparing mix to mix, side by side, comparing the Hydrus and the iStent inject standalone for treatment of open angle glaucoma, 12-month follow-up, 152 eyes of 152 patients. Hydrus had a greater complete surgical success rate and reduced medication use, as you can see from the blue bars, the gray bars of the iStent inject. More patients were medication-free. Over 50% of Hydrus patients were medication-free. Secondary glaucoma surgery was required in 2 eyes in the iStent inject group and none in the Hydrus group. So these kind of studies are going to help us decide what kind of stents we want to implant in a particular patient. I'm going to go on to trabecular meshwork stripping procedures. And the first one I'm going to talk about is gonioscopy-assisted transluminal trabeculotomy. You achieve a 360-degree opening to Schlemm's canal, ab interno, minimally invasive, requires corneal clarity. We started off using a 250 micron illuminated microcatheter, but currently we're able to perform this with a 5/0 or 6/0 Prolene suture with a stipped blunting. It definitely requires microsurgical instrumentation. And here's a video of me performing a GAT procedure, one of the first ones. The eye is filled with Helan GV. That's a 250 millimeter micron microcatheter. The patient's head is rotated. That's a direct swan jet gonioscopic lens to visualize the nasal anterior chamber angle. That's a 25 gauge MVR blade used to incise trabecular meshwork so as to gain access into Schlemm's canal, creating a goniotomy. Once an adequate size goniotomy is created using microsurgical forceps, maybe a retina forceps or a retinal peeling forceps, usually an ILM peeling forceps, you can feed the microcatheter into Schlemm's canal. As you saw earlier on, there's a lighted tip at the end of the catheter that gives us the location of the tip. And as you can see, it's coming back into the nasal anterior chamber angle. If you keep pushing the catheter further back into Schlemm's canal, and you'll very clearly soon see the catheter reappear within the anterior chamber angle in the nasal angle. It's a very delicate procedure. You don't want to kink the catheter in any way, and you want to be sure that you don't damage the iris. Both ends of the catheter are held and pulled so that you strip trabecular meshwork for 360 degrees internally. It's a very elegant procedure, and usually you'll see some amount of reflex heme into the anterior chamber because you open up Schlemm's canal. So the 2-year follow-up data shows that the reduction in intraocular pressure in POAG eyes is up to 9.2 millimeters of mercury, again with the decrease in the number of medications. In secondary glaucoma eyes, like uveitic eyes, steroid-induced glaucoma eyes, the reduction is even more to approximately 14 millimeters of mercury. Transient hyphema remains the most common complication because of the amount of trabecular meshwork open and the reflux bleed into the anterior chamber. So much so you must avoid this procedure in patients on blood thinners or those who cannot stop their blood thinners. The Cahoog dual blade is the new version. It's a dual blade with a pointed tip to pierce trabecular meshwork. It's got a little ramp so that you elevate and stretch the meshwork, and it's got a dual blade to cut the meshwork equally. And there's a foot plate at the back that is flat, and that prevents damage to the anterior wall of the canal. Again, it's performed the nasal anterior chamber angle. Nice pigmented meshwork, as you can see here. You can pierce the trabecular meshwork very easily, and then the blade is carried out to one side, and you can see the white line showing you access into Schlemm's canal. And once one side has been performed, you very gently turn the Cahoog blade so that you can actually do the other side. I try and strip as much trabecular meshwork as I can see. So sometimes I move the gonioscopic lens to one side and then the other side so as to cover as much trabecular meshwork as I can. In short term, you can see the real nice white cleft. If you do a postoperative gonioscopy, this is the appearance you're going to see with an open cleft. So at 6 months, good reduction in intraocular pressure. Now, this is a 12-month outcome study performed in angle closure eyes, and you'll wonder how can you perform this in angle closure eyes? In angle closure eyes with goniosynovitis, you're able to strip it across and open up the meshwork and open access to the meshwork, and again do a goniotomy. And you can again see at 12 months, there's a good reduction in intraocular pressure and a reduction in the number of anti-glaucoma medications postoperatively. If you compare phaco KDB versus phaco iStent in a prospective fashion, 164 eyes of 164 patients, both lowered IOP and need for IOP lowering meds. Significantly more Cahook blade eyes achieved a target pressure of greater than equal to 20% or greater than one medication reduction at month 12. So in conclusion of all the mixed procedures, our goal with glaucoma surgery is to lower intraocular pressure in the safest possible manner. We want to consider surgical options early, especially if a patient is intolerant to medications or there are compliance issues. You can today customize glaucoma treatment for a patient. MIG certainly offers earlier surgical management for glaucoma and surgical management even for earlier glaucoma to mild to moderate to relieve patients of the burden of using drops long term, and also if they have side effect profile to the drops. These procedures seem to work well in combination with cataract surgery. So again, if a patient needs a very low intraocular pressure, like normal tension glaucoma, or patient with very advanced primary open angle glaucoma or angle closure glaucoma, it's worth the risk of performing a trabeculectomy with mitomycin C, and then it's worth the risk of associated lifetime of bleb vigilance to avoid complications from bleb endophthalmitis. However, many patients seem to do really well with postoperative intraocular pressure in the mid-teens on one medication, and that is achievable with these newer minimally invasive glaucoma surgeries. I would definitely consider angle surgery for adult open angle glaucoma patients. Among all the procedures that I've shown you, the procedure that you might be able to perform today in India without any special setup is the GATT procedure with a 5-Proline suture. There are videos available on YouTube. I'd hope you consider watching them and trying these for your open angle glaucoma patients. Thank you very much again for allowing me to share my ideas, and I hope you all have a good meeting, and thank you once again. Appreciate you.
to announce the winner for the e-poster competition. It was held online also. The winner is Dr. Harshita Sharma. Is she there? She's from HV Desai Eye Institute. Anybody on her behalf? Dr. Harshita Sharma? Okay. And now there are some certificates of participation. I would like to call upon the names. Participants, please come here and take the certificate. Dr. Akanksha Sahu. Dr. Akanksha Sahu. She is the second winner. Next one is Dr. Anagha Gole. Dr. Anagha Gole. Akanksha. Dr. Anagha Gole. Dr. Lalita Kumari. Dr. Lalita Kumari. Dr. Radha Jain. Dr. Radha Jain. Major Dr. Rohit Bhanot. Major Dr. Rohit Bhanot from FMC. Dr. Anjali Singh. Dr. Anjali Singh. Dr. Jindal Kavadia. Dr. Jindal. The judges for the e-posters were Dr. Parikshit Gupte sir and Dr. Mandar Paranjpe sir. Thank you, sir, for your valuable contribution. Now for the free papers. Session was occurred on 5th of December. It was an online session. The winner of the session was Dr. Shitish Tamboli. He received the award in the inauguration function only. And rest of participants are Dr. Kuldeep Dore from HV Desai. Dr. Anjali Singh, she is also from HV Desai. Dr. Vrushali Varar. Dr. Anuprita Gandhi Bhatt. Dr. Neha Shetty. Dr. Vrushali Varar. Dr. Neha Shetty. Dr. Harshita Sharma. Dr. Agrima Bhatia. Dr. Pooja Pathak. Dr. Akanksha Sahu. Dr. Anushri. She's from FMC. Dr. Akanksha. Dr. Anushri, Dr. Insaf Ali, Major Dr. Abhishek Tripathi, Major Dr. Iram Riaz, Dr. Aarti Heda, Dr. Aarti Heda, Dr. Chirag Bhattad, Dr. Amod Ahuja, DY Patil. Amod Ahuja. Okay. Dr. Amod Ahuja. Dr. Gopi Naresh. Dr. Lalita Kumari. Dr. Gopi Naresh. Dr. Lalita Kumari. Dr. Shrikant S. Dr. Shrikant. Dr. Apeksha Raghunath. Dr. Devika Damle. The judges for this competition were Dr. Udayan Dikshit, Dr. Shrikant Joshi, and Dr. Varsha Kulkarni. Thank you for your contribution, sir. Now for the quiz.
Good evening, everyone. Today morning we had an exciting quiz competition which was held by our own Doctors Subhash Bijlani sir and Dr. Vardhaman Kankaria. And winner of the quiz was Dr. Mandar Paranspek. Congratulations, sir.
बैंक की नौकरी
गूगल से बोलिए क्योंकि बोलने से सब होगा।
First runner-up, Dr. Mukesh Paryani. Second runner-up, Dr. Pratik Singh. Fourth and fifth position, Dr. Radhakrishnan and Dr. Fatima Siddiqui.
Nine of participants were to get cash awards. Those awards are with Dr. Vardhaman Kankaria. They will be delivered to you.
Thank you, sir.
From PS.
May I request the conference coordinators? Sir, please felicitate them. Dr. Sanjay Shah, sir, and Dr. Subhash
बैंक की नौकरी
Please come.
गूगल
Dr. Prakash Barati, sir, Executive Trustee POS. Scientific committee members, Dr. Jeevan sir. Dr. Nipin Prabhu Desai sir. Dr. Sangeeta madam. Event manager, Mrs. Renuka Saxena. Now, in the capacity of the organizing secretary, I would like to make suggestions and ideas.
So good evening all. I think we are coming to the end of this wonderful conference in this COVID pandemic era. Probably we were in two minds whether this conference will be held or not. Even last year it was in online platform, and then everybody was waiting whether this day will come or not. So after the efforts of this organizing committee, I think the day has come. And coming to the end of this conference, I must say it's a wonderful conference. 3 cheers to the team US. Considering the 12 mind, whether online, offline, and then the challenges were taken by this organizing committee headed by Dr. Tekaude and very well aptly helped by Dr. Rujuta and Sima. I think the daring to take this decision to conduct the conference, I think they must be appreciated by all of us. In Pune, in Maharashtra, I think this is the first hybrid conference. To organize physical conference is difficult. To organize online conference is also difficult. But to organize hybrid conference is the great challenge. Because to coordinate physical as well as online at the same time, and it is the great trial. So many things were included in that. And considering the venue, menu, everything. I think all sessions like cataract, refractive, skin, pediatric surgery, and then everything was very well covered by the scientific team headed by Dr. Jeevan and his colleagues. All sort of presentations were fantastic. The quality of scientific material was very good. Even the food, hospitality, what we say. Because what we have experienced that international faculty as well as national faculty, those who came here, were very satisfied. And I think that is the success of the conference. Even it is the local city conference which was started by us, my colleague Dr. Bijlani, when I was vice president. I think 14 years ago, this was our dream that in the city of Pune, such sort of conference must be held. And I think we're through over the years. Only exception of last year, where also we could conduct it online. And definitely this sort of conference will be continued in future. The memories of this particular conference will be cherished forever. 3 cheers to Team POS again. Congratulations to you all, and happy that I am part of this particular conference. Thank you so much.
Thank you, Marathi sir. Two names from the MC which I would like to mention here. One is Dr. Piyush Bansal and Dr. Ashwini, who made the inauguration function flawless. Thank you, both of you.
And I would like to take the names of all my MCs who were 24/7 on the run. Dr. Nirupa, Dr. Pranjali, Dr. Nitika, Dr. Vrushali, Dr. Ashwini, Dr. Sagar, Dr. Piyush, Dr. Nishita, yes. Dr. Natasha also, yeah. She couldn't attend. Dr. Devika, yes. Very much, a lot of contribution from Dr. Devika.
Good evening, all. The last and sweet thing of giving vote of thanks comes to me. I'm thanking to all my MC members, MOC, President Dr. Tekode, Secretary, Organizing Secretary Dr. Rujita, Executive Trustee Dr. Marathe sir, Conference Coordinators Dr. Bijlani sir and Dr. Shah sir, Scientific Committee Chair Dr. Ladi sir. For SSTC, I must thank Dr. Mukesh Paryani. For live surgery session, Dr. Shrikant Joshi sir and the whole team of the Dinath Mangeshkar Hospital. Then I must thank the members of boat club for their extended support. Renuka Sangle and her entire team, DigiShield, I cannot forget Dipen Mehta and Piyush for their help. And importantly, all audience, all delegates who contributed by their presence and also by online presentee, and their because of them, we because of their comments, we could understand there was a problem in the streamline, and we could rectify that so that if all content were delivered across the country through the online streaming and through the YouTube also. So if anybody is remaining not to from my side, apologies for that. And any comments, any improvements, do call us on the phone or WhatsApp. Thank you. And I conclude the Pos Spectrum 21. Thank you. National anthem we are going to sing.
Everyone.
No. Mayuresh, एक photo.